Department of General Surgery, and
I, Dr. Preeti, intern from Department of General Surgery.
our host for today's event.
It gives me immense pleasure to welcome you all to the continuing medical education in breast disease update
Organized by Khaja Bandanawaz University, Department of General Surgery, in association with Associations of Surgeons of India, Kalaburagi chapter.
We are truly honored by your presence today.
As we embark on this incredible event of knowledge, innovation, and collaboration.
We are privileged to have such distinguished personalities among us who have significantly contributed to their respective field and continue to inspire countless individuals worldwide.
May I now request these chairpersons to please come forward and to be seated on the dais.
Dr. Sachin Shah sir, HOD Department of Orthopedics.
Dr. Guru Prasad sir, Professor and HOD, Skin and VD.
Dr. Sanjeev Tatsadmat sir, Department of ENT.
Dr. Sadashiv Yadgikar sir, Department of Orthopedics.
We welcome you, sir.
I request Dr. Moinuddin sir to felicitate the chairpersons. I request Dr. Amrendra Biradar sir to please come on the dais. Here.
Dr. Amrendra Dharwa sir has completed his UG from MRMC Gulbarga, MS from Jawaharlal Nehru Medical College, MCH from MCH in Surgical Oncology in Kidwai Memorial Institute of Oncology, Bangalore.
Sir is notably working as Assistant Professor, Department of Surgery, Oncology at Kidwai Hospital in Gulbarga.
We welcome you, sir.
Hello, Chief. Hello. Hello.
Good morning all, respected dignitaries on stage, my colleagues, students and friends. I'm glad to be presenting here. This was quite last minute. My name is Dr. Amrendra Dharwar, not Biradar. Dr. Amrish Biradar is plastic surgeon. So the topic given to me was benign breast diseases. Next slide, sir. So my scheme of presentation will begin with introduction, classification, some common lesions and risk reducing strategies. Next. Next slide, sir. So what is benign breast disease? Any radiologic or palpable abnormal area when subject to biopsy and the pathological result comes out to be as benign, those are referred to as benign breast diseases. Earlier there was a different classification, ANDI, that is aberration of normal development and involution. That has been removed and a new classification has been proposed now. Next slide. So this is the schematic representation of the breast. As we all know, it includes both epithelial and stromal elements. So there is a lobule of the gland which drains into lactiferous duct and sinus which comes out through nipple as discharge. Next slide, sir. So as we all know, DuPont and Page classified, they came out with this classification. They simplified benign breast diseases and classified as mainly three categories. That is non-proliferative disease, proliferative disease without ertypia, and atypical hyperplasias. They included based on epithelial proliferation abnormalities seen in histological findings in various breast diseases. Next slide, sir. So this is a simplified classification. These include non-proliferative breast disease, mainly mild duct hyperplasia. All our cysts are classified in non-proliferative disorders. Fibroadenomas, ductictasia, and benign Phyllodes tumor. So they carry a relative risk of cancer which is minimal or next to nil, It is a relative risk score of 1.2. Next is proliferative disease without ertypia. This includes mostly moderate duct hyperplasia, radial scars, and papillary lesions. They carry a relative risk of cancer, that is 1.8. And as we move to atypical hyperplasia, which includes ductal hyperplasia and atypical lobular hyperplasia, the risk of cancer significantly increases. And last but not the least is lobular carcinoma in situ, which carries a higher risk of breast cancer than any other lesions. Next. So we'll be discussing some of the common lesions seen. So most common lesions are fibroadenomas. They are palpable, mobile lesions. It is one of the first procedures that we get to do in either our post-surgical training or our internship training. So on ultrasound, they are usually round to oval, homogeneous echo texture. They usually present with popcorn calcification. That is mostly seen in only 30% of the cases. They can be classified as either simple or complex. Complex depending on the degree of calcification or the degree of hyperplasia. The diagnosis is mainly by core needle biopsy. Coming to imaging, a simple ultrasound will pick up your fibroadenoma. Next slide, sir. So this is a very controversial statement. Most fibroadenomas need not be excised. Surgical excision is only indicated if there is discordance with your imaging, or if a pathologist finds a typical hyperplasia in the specimen. And for those young women who are not willing to undergo surgery, they can be observed with follow-up with 6 to 12 months. If there is doubling of size within 6 to 12 months of follow-up, then they can be considered for surgery. Or any symptomatic fibroadenomas, surgical excision can be advised. Next slide. So mild ductal hyperplasia, this is mostly a pathological finding. This refers to increase in the number of epithelial cells above the basement membrane in the terminal lobular unit. The number of cell increases is 3 to 4 times, and they have normal appearance compared to normal breast echo texture. But these do not require surgical excision unless there is discordance with your imaging, that is mammography. Next slide. Coming to radial scar or complex sclerosing lesions, both are almost same lesions. However, the only difference is the difference is size. If there is more than 1 centimeter, it is referred to as complex sclerosing lesions. They usually present with palpable masses. Their only feature mimicking cancer is their speculated appearance on mammography. Next slide. Same here, excision is not warranted in radial scar or complex sclerosing lesions. Surgical excision is to be considered only when ertypia is present, or it is more than 1 centimeter in size, or if your sample is inadequate or the pathologist is not able to give a diagnosis, then you can go for surgical excision. Next slide. So coming to papillary lesions, these are a very heterogeneous group of lesions. They include intraductal papillomas, atypical papillomas, and papillary cancers. They usually present with nipple discharge, which is usually bloody, or rarely they present with mass. Diagnosis is usually by mammography and your core needle biopsy. Next slide. So in these cases, surgical excision is warranted in almost all the cases. If it is arising from a single duct, you do a microradiectomy, or if multiple ducts are involved, then you excise all the ducts. However, in some cases, we can observe those patients who are willing for follow-up, who are compliant to follow-up, or in those cases where ertypia is not present in pathological report, then such cases can be observed with 3-monthly or 6-monthly follow-up with routine mammography. Next slide. So coming to atypical hyperplasia, these carry a very high risk of malignant transformation. So these refer to epithelial proliferation above the basement membrane and terminal lobular unit. However, the difference with mild ductal hyperplasia is they do not resemble the normal breast architecture. They involves only 1 to 2 ducts and they are less than 2 mm in diameter. So core needle biopsy is used for diagnosis. However, a word of caution that core needle biopsy may underdiagnose this condition in about 10 to 30% of the cases. Surgical excision is standard of care in these cases. So beware of this diagnosis. Next case. So coming to Phyllodes tumor, so we as oncosurgeons face a tough time to distinguish between Phyllodes tumor and ductal carcinomas. However, Phyllodes tumor are very typically appearing. They are usually huge, firm to hard in consistency, usually mobile. They involve almost all quadrants of the breast. They present as usually palpable masses. They increase over time, may reach up to 20 to 30 centimeters in size. It is mostly due to hypercellular stroma rather than epithelial proliferation. So they are classified as benign, malignant or borderline depending on mitotic count. Next slide. So surgery is mainstay in Phyllodes tumor. Wide excision with negative margin is sufficient in benign Phyllodes tumor. However, a margin of more than 1 centimeter is advised in borderline and malignant transformation. However, most of these cases recur with a high recurrence rate of about 15%. So re-excision is advised when recurrent cases of Phyllodes tumor come to you. These present with only 2% incidence of axillary nodes. So axial lymph node dissection is usually not warranted. Radiation is advocated in recurrent cases of Phyllodes tumor. Next slide, sir. So coming to some of the risk reducing strategies where you can reduce the risk of malignant transformation as such. So first and foremost and the most important probably is your lifestyle modification. Low fat diet and maintaining a healthy adequate diet and healthy weight and smoking should be avoided. Medications, many medications have been advised, that is tamoxifen, raloxifene and anastrozole. These can be given depending upon the IHC status. You have to determine the ERPR status and the postmenopausal status or the premenopausal status should also be known before starting these agents. These agents, studies have shown that these agents help in 50 to 70% risk reduction in the incidence of cancer, especially in atypical hyperplasia and lobular carcinoma in situ patients. So this is the least preferred risk reducing strategy, that is risk reduction mastectomy. Not all patients will agree for risk reducing mastectomy. These are used in highly select cases, those of atypical hyperplasia or LCIS patients who are tired of undergoing multiple biopsies or those who have high risk of family history of breast cancer. So there are few prediction models which help to determine the individual's risk of getting cancer. That is, one of them is Gale model. So it is a software which takes into account various parameters and that will tell you individual risk of undergoing malignant transformation. However, before undergoing this procedure, patient should be well informed. All the pros and cons should be well explained to them. And as there is changes of in image and as well as sexuality, so it is rarely advised to patients in benign breast disease, but you can advise in atypical hyperplasia or LCIS patients. Next slide. So the take-home message is imaging should be the first and foremost. Never biopsy before your imaging, and always biopsy is preferred over FNAC. Always biopsy, core needle biopsy, preferably image-guided biopsy should be preferred. And always correlate clinical and your radiological findings. Foremost is counseling your patients. All your patients should be adequately counseled. Whichever procedure should be undergoing, everything should be explained to them and documented. in this era of medico-legal cases. And the last and foremost is whatever procedure or whatever imaging or whatever intervention you do not miss your cancer diagnosis. Thank you.
Thank you. Thank you, Mr. and Dr. Amrendra Dawar, for your nice presentation. Anybody has got any doubt, any questions? Kindly ask.
Now, house is open for discussion. Yeah, please.
Presentation, sir. Sir, just I want to ask about you have mentioned about the benign breast disease, about the fibroadenomas.
Yes.
So what we are encountering here, very young age patients,
Yes.
like 18 to 20 years. There is always a combination with on FNACs, fibroadenoma with fibroadenosis. So when we are giving a diagnosis of fibroadenosis, so what is the interpretation on your side as a surgical expert?
Sir, I feel FNAC should not be investigation of choice. You always go for core needle biopsy. Unless the lesion is very small, you can go for FNAC, sir. And just to be cautious, whenever you are doing a fibroadenoma, just don't go for a simple enucleation. Always do a wide local excision, so that even if it comes out as cancer, the pathologist will be able to tell whether the margins are clear or not. And next, the patient can directly be subjected to either axial lymph node dissection or radiotherapy, sir. So you have taken care of the primary if you do a wide local excision. So you can directly subject the patient to ALND or radiotherapy, sir.
So what we are considering as the FNAC is the best modality.
FNAC is simple modality, but if you discuss with your pathologist, they will always suggest core needle biopsy is always better than FNAC.
So it is very difficult, I think, to convince for the surgical biopsies, what we are going as the core needle biopsies nowadays. So what I prefer is the FNAC is the best modality for the at least the benign breast diseases for the younger age patients.
Sir, the problem with FNAC is it is highly sensitive. So if it is positive, then it is 100% positive. But if it is negative, then you are in a fix, whether it can be positive later on or it is negative, sir. So core needle biopsy is 95% sensitive and specific, sir. So if unless the lesion is very small, you can consider for FNAC, sir, or else any time, any day, core needle biopsy is preferred, sir.
Biopsy is better. It all depends, I think, also with the clinical examination and along with the imaging. So when we have the clinical data and we feel it is completely benign lesion, then I think, as sir told, in younger patients we can prefer FNAC. But when there is a slight doubt of any malignancy or if there is any intermediate nature of the disease, in that case I think true cut biopsy or the core needle biopsy is the best. And moreover, true cut biopsy is definitely an office procedure. It can be done within 5 minutes, and we have very good true cut biopsy gun, which is just like a needle but a little bit bigger size. And it really helps in giving a very clear cut diagnosis, elevating the ambiguity of the lesion. Thank you.
Prefer for the younger age patients and for the benign breast diseases with very young patients, better for the FNAC is the best diagnostic tool.
Yes.
A patient with benign breast disease, when we operate and send for HPR, the reports comes as malignancy.
Yes.
In this case, whether it needs a revision breast surgery or directly chemoradiography to be subjected.
That's what you need to discuss with your pathologist, sir. Your pathologist should give diagnosis, and they should be able to comment on all the margins, sir. So the new NCCN guideline states that you don't need to give a bigger margin for malignancy, sir. If your inked margin is negative for malignancy, that will suffice, sir. So your pathologist should comment on all the margins, sir, and your base. So if all these margins and base are free of tumor, then
no revision surgery.
so the primary is addressed, sir.
Right. Thank you.
You need to address the axilla.
Now this result came as a benign, then it is only how long we are going to follow the case?
Benign disease, sir. Sir,
Duration exact.
patient A, sir?
Follow up how many days? After getting that report came as a benign, we have to go.
Sir, you
with
can
patient.
keep the patient on a longer follow-up, I feel, sir. Younger patients, you can keep them on either a 6 to 12 months of follow-up, whereas older patients, you can keep them for follow-up every 3 to 6 months. You can call them for follow-up, sir.
6 months to 1
3
year.
to 6.
Maximum?
Sir, maximum 6 to 12 months, sir.
Right. Thank you.
Thank you, Dr. Amarendra Harva, once again for your very informative and illustrative this thing. And I also thanks, Dr. Mankar sir, please put your words.
Sir, keeping the patient's apprehension in mind,
Yes, sir.
all fibroadenomas should be excised.
Yes, sir, I feel that's what I also do. But some young women, they are very this thing about their appearance and all. Such patients can be followed up, sir. Who are apprehensive of their appearance, such patients can be kept on follow-up, sir.
Excuse me, I am
Sir.
Dr. Aslam.
Namaskar, sir.
You nicely mentioned about benign breast disorders. But what are the incidence of tuberculosis breast disorders?
Sir, tuberculosis, sorry, I forgot to.
You have not
include-
mentioned about
yes.
it.
Sir, in our Indian population, we get a lot of granulomatous disorders. So recently, a doctor had referred me saying that the patient had mass and the patient had persistent pus discharge from the breast. So she had already subjected the patient to FNAC. FNAC was inconclusive, so we subjected the patient to core needle biopsy. So core needle biopsy came out as granulomatous disorder, sir. But her mammography finding was Birad's 4, but core needle biopsy came out as granulomatous disorder. So we started her on AKT. Now she is fine, sir.
Same things happened with me. I doubted the case of sphere mass moving finely.
Yes, sir.
But needle biopsy turned out to be a tuberculosis one. Once we started antitubercular, it disappeared. But another case came with a fat breast abscess.
Right.
And when we drained it, sent it for the culture, then it turned out to be a tuberculosis one.
Yes,
So
sir.
nowadays incidents are very common. One
Yes,
should keep
sir.
in mind about this.
Tuberculosis breast disorders are very common in our Indian setup, sir.
Thank you.
Thank you, sir.
I thank you the very enthusiastic and active participation of the audience. As the time limitation is there, we have to go for the further next session. And there will be definitely a panel discussion at the end. I think you are most welcome. And this is setting a tempo for the all others that audience is so enthusiastic. So we will thank once again, and we will thank the organizers of this program providing us the opportunity to chair this session. We are fortunate enough, and thank you the speaker. Thank you.
Thank you, Dr. Amrendra Dharwa, sir, for enlightening us with your wisdom.
May I now request Dr. Moinuddin sir, Professor and HOD, Department of General Surgery, to felicitate Dr. Amrendra Dharwa, sir. I request
We must specially thank Amrinder Dharwad because he has accepted our invitation at the last minute or 11th hour because of the speaker in Sholapur was held up because of his protocol. So I wholeheartedly thank you once again.
I request Dr. Moinuddin sir to felicitate the chairpersons. Dr. Moinuddin sir, I request you to felicitate the chairpersons.
Thank you, Dr. Moinuddin, sir. We will continue with the next session. May I now request Dr. Arun Bharat, sir, consulting onco-surgeon, ESIC Kalaburagi, to please come on the dais and talk on Introduction to Carcinoma of Breast and Clinical Presentation.
May I now request these chairpersons to please come forward and to be seated on the dais. Dr. Suresh Patil, sir, Professor and HOD, MRMC, Kalaburagi.
Dr. Sangmesh Tondare, sir, Department of Surgery, GIMS. Dr. Arun Bharat, sir, did his MBBS from Sri Siddharth Medical College, Tumkur. MS General Surgery from Regional Institute of Medical Science, Imphal, Manipur.
DNB Surgical Oncology from Omega Cancer Hospital, Hyderabad, and Fellowship in Minimal Access Surgery and FMSO.
He has worked in various prestigious institutes like JIPMER, Puducherry, and Vaidhi Institute of Medical Science, Bengaluru.
Thank you. Thank you for the introduction. Good morning, everybody. My name is Dr. Arun Kumar Bharat. I am a surgical oncologist working at ESIC Kalaburagi. So I really thank all the dignitaries present on the stage. I really thank the management committee, the organizing committee, and the management of KBN Hospital for providing me this opportunity to present a brief introduction about the carcinoma of the breast today. So this is my topic. I'll be talking very briefly about the introduction of carcinoma of the breast, and then briefly about its clinical presentation. Next slide, please. Excuse me. So, breast cancer is most common cancer diagnosed in the women worldwide, and it is accounting for more than 1 in 10 new diagnoses worldwide. So, as we all know, it is also a leading cause of death from cancer among women all over the world, and it always evolves very silently. And majority of the times, the major common presentation of this cancer is a lump in the breast, so the survival rate improves with the early diagnosis. So early diagnosis is the key in any form of cancer, whereas in breast cancer it is even more important. And early diagnosis definitely improves the overall survival of the patient. The tumor tends to spread lymphatically and hematologically, leading to distant metastasis and poor prognosis. So briefly about the history of the breast cancer. So since ages, the female breast has been a symbol of beauty, fertility and femininity. And since antiquity, it has challenged the physicians about its diseases. So the history of breast cancer is a very complex maze of attempts to understand the wily nature of this hormone responsive cancer. So as early as 3000 BC, we have found the records of the breast cancer in the Edwin Smith surgical papyrus. So this was way long beyond 3000 BC. So this was the first mention the breast cancer has received. That was in Edwin Smith surgical papyrus. Next slide. So as early as 4000 BC, Hippocrates mentioned that breast cancer was because of the imbalance in the humors, that is blood, phlegm, yellow and black bile. And it is also very noteworthy to mention that Hippocrates was the first person to describe the stages of the breast cancer as early as 4000 BC. Then another great physician, Galen, around 200 AD, he attributed breast cancer to the accumulation of black bile in the blood. And it is also very noteworthy that Galen was he was the first person as a physician to mention that breast cancer was a systemic disease. Next slide. So 19th century, fast forwarding to the 19th century, from the 200 AD till the 19th century, nothing much happened. The breast cancer, many of the physicians tried to solve it, but nothing much improvement happened till the 19th century. Whereas 19th century, it is considered as the golden age for the surgery. All the credit goes to the anesthesia. Invent of anesthesia greatly increased the ease of the surgeons to operate and to plan difficult and more major surgeries. So anesthesia changed the overall ball game for the surgeons. So during the 19th century, one of the famous figures of that time, Dr. William S. Halsted, he was a professor of surgery at Johns Hopkins Hospital at Baltimore. So he was the first one to describe radical mastectomy, which later came to be known as Halsted's radical mastectomy. Halsted is a word which is associated with the radicality, because he was the first person who mentioned that radical surgeries are to be done for all sorts of cancers. So Halsted's radical mastectomy was first reported in 1894, and this became a mainstay of management for a century following this report. And he mentioned and emphasized that the whole of the tumor along with the lymph nodes should be removed in one piece. So that was a very good mention which was given by him during that time. He mentioned that removing the tissues in one piece to prevent the spread, and he also emphasized on the removal of pectoralis major muscle to prevent the recurrence. So this became an undisputed path for the many of the surgeons following a century, and they followed Halsted's radical mastectomy for a very long time. So this continued for another century. Next slide, please. So in his own words, William Halsted, he suggested that the suspected tissues should be removed in one piece, lest the wound becomes infected by the division of tissues invaded by the disease or the lymphatic vessels containing the cancer cells. And because shreds or pieces of cancer tissues might readily be overlooked in the piecemeal extirpation. So before, there was no concept like no-touch technique. So before, the surgeons used to remove the tumor by breaking it into the half and in many pieces. But Halsted, for the first time, he mentioned that the tumor should not be broken and should be removed in a one piece. He also emphasized that by breaking the tumor, by touching the tumor, the possibilities of cancer cells coming out of the tumor and causing the local recurrence are very high. So he was the first person to make a very worthy note of the nature of the disease. Next slide, please. So this was the adage during the 19th century. During the Halsted's era, they used to say that big surgeons make big incisions. So this adage was there for 1 century since the advent of the Halsted's radical mastectomy. So this was short-lived when another surgeon, next slide please. This was short-lived when another surgeon, very noteworthy surgeon, all the physicians, all the surgeons who are present over here who are dealing with the breast cancer will definitely remember and know about Dr. Fisher. Next slide. So Bernard Fisher, he was a professor of surgery at University of Pittsburgh, reviewed Galen's ancient belief that breast cancer was a systemic disease. This was a very noteworthy mention because as early as 200 AD, the physician named Galen mentioned that breast cancer was not a local disease, it was a systemic disease. This concept was revived by Dr. Bernard Fisher in the late 20th century, and he made a very noteworthy mention that breast cancer was a systemic disease. He conducted many large randomized controlled trials like the National Surgical Adjuvant Breast and Bowel Project, which got published in 1989, and many other large RCTs, randomized controlled trials, which gave proof for the way the breast cancer should be treated. So one of his very famous quotes, I think everybody must have heard about it. He mentioned that in God we trust, all others must have data. So this means that he emphasized so much on the data. If you have data, if you have something to prove, if you are telling the other surgeon is not doing the correct way of the treatment, but you have to prove it by data. So he emphasized more on the randomized control trials, he emphasized more on the studies, he emphasized so much on the data that he conducted so many RCTs, and the result of those data completely changed the way the breast cancer is treated at present. Even today, Bernard Fisher is attributed to so many his achievements which completely changed the way the breast cancer is treated. So as late as late 20th century, many surgeons still followed Halsted's radical mastectomy, which was very disfiguring, which was not very good for the patient. Patient had to live with that disfigurement for a very long time, and this all changed by the data published by the Bernard Fisher. Even though he was a surgeon, ironically, he was the first person to tell that neoadjuvant chemotherapy should be started for the breast.
breast is not only a local disease, it is a systemic disease. Surgery is not the only solution. We need to start the chemotherapy as well. The next slide, please. So it is ironic that as a surgeon, Dr. Bernard Fisher, he contributed to the disabandonment of radical Hastadian approach. Then he started the institutions of trials. Then he also propagated the acceptance of neoadjuvant chemotherapy. So these were all the brainchild of a surgeon. Ironically, people say that surgeons are the one who always love to do surgeries and cut. But as a surgeon, he also propagated the idea that majority of the breast cancers need chemotherapy, but it's not only surgery is the only solution. Next slide, please. So coming to briefly about the statistics, as we all know, this is the latest 2020 Globocon data. It suggests that breast cancer is a very common cancer all over the world among the females. So in this 2020 Globocon data, the most important thing emerged out, which suggested previously lung cancer was the most common cancer, whereas breast emerged as the most common cancer among females. Next slide, please. Worldwide, female breast cancer has now surpassed lung cancer as the most commonly diagnosed cancer, and estimated more than 2 million new cases of breast cancer were diagnosed in the women. So breast cancer is the most common cancer worldwide, surpassing the lung cancer for the first time in the 2020. So the 2020 data revealed that the breast cancer was the most common cancer among the women, and it even surpassed the lung cancer. Next slide. So globally, breast cancer now represents 1 in 4 of all cancers in women. Since 2008, worldwide breast cancer incidence has increased by more than 20%, and mortality has increased by 14%. This is again a very alarming data which has come out very recently. The increase in the breast cancer incidence has by more than 20% is really alarming, and the most important noteworthy point about this is this increase in the incidence has happened in the poorer countries, developing countries and least developed countries, which is again a very wrong thing, because the overall breast cancer treatment is a very financial burden and psychological burden for the patients. And considering this data that there was an increase in incidence among the women of the poorer countries is again a very negative point. Next slide. So breast cancer also contributes to the number of deaths. So it is just second to the lung cancer among the women. Next slide. So coming to the Indian statistics, there are few changes in the Indian statistics compared to the world statistics, but they are not very major or very noteworthy. So from being the 4th in the list of the most common cancers in India during the 1990s, it has now become the very first cancer. So earlier, cervical cancer was very common in the rural population of the Indian women, whereas in the urban population, breast cancer was very common. Nowadays, according to the various statistics in the India, all over the India, breast cancer is the most common, whether it is rural or the urban population. Breast cancer is the most common cancer among the women. Whereas there is one cancer registry in Maharashtra that is called as Barshi, where the uterine cancer still remains the most common cancer among the women of that particular location. Next slide. So prevalence rate of 25.8 cases per 1 lakh people. In 2020, it accounts for 13.6% of all new cancer cases and roughly 13.3% fatalities per 1 lakh population. Approximately 13.3 deaths per 1 lakh population in 2020. The survival rate for the breast cancer has also dropped by 2.7% in cases of detection at the stage 4 as against stage 1. So always this again emphasizes the fact that early diagnosis is the key for all cancers, whether it is breast cancer or whether it is any other organ cancer. Early diagnosis is the key, and it definitely improves the overall survival of the patient. Next slide. So this is again a Indian data. So here this graphs, it is a very alarming picture of the current scenario, cancer burden or cancer scenario within the country. Here you can notice that breast cancer, head and neck cancer, lung cancer, stomach cancer and uterine cancer. So when you take all these major cancers among the Indian population, what is very noteworthy is majority and most of the cases, that is 60%, 57%, 66%, more than 60% of the cases, they are all diagnosed in the locally advanced stage. And when it comes to the lung cancer, they are diagnosed in the distant metastasis. This is a very alarming data which has emerged from the Indian statistics. So here we have to do a lot about the prevalence screening programs for the commonly existing cancers of the population. So Indian government is, I feel according to this data, this directly reflects without any dispute
that nothing much has been done for the screening, as a part of screening in our country, because all the cancers, which are the most common cancers, as you can see here, every cancer is diagnosed in a locally advanced stage. When the diagnosis happens in the locally advanced stage, there is very little hope for the patient to survive. Next slide, please. So coming briefly about the risk factors of the breast cancer. So these are the most common risk factors. Age, the female breast cancers are more common in the elderly age. And coming to the gender, breast cancers, as we all know, is very common in females. Personal history of breast cancer. Any patient who was diagnosed with the breast cancer is again in a high risk area for development of the second primaries or the second breast cancers in the opposite breast. Histological risk factors. As Dr. Amar repeated previously, he suggested that there were 3 histologies which are very high risk for the breast cancers. Among them, lobular carcinoma in situ has very high risk, and along with that, hyperplasia with atypia is again a high risk factor. So any family history of breast cancer and genetic risk factors are very contributing. Among all the number of breast cancers, genetic reasons contribute to 5 to 10% of all the diagnosed breast cancers. So when one female is diagnosed with a breast cancer, her first degree relatives, her daughters or her sisters, or first degree relatives, they have a 3 to 4 times increased risk of the cancer. Reproductive risk factors are namely when the overall exposure to the estrogen for a lady increases during her lifetime, it is again called as a risk factor. So these are contributing factors like early menarche, late menopause and nulliparity. They are also the risk factors for the breast cancer. Exogenous hormone use is a very controversial topic, because there were many large amount of studies which contributed to hormonal replacement therapy causing breast cancer. Whereas there are also few studies which also suggested that hormone replacement therapy do not cause cancer. So this is still a gray area, but according to the majority of the studies contributing to the cause of the breast cancer for the hormone replacement therapy, here we can definitely suggest that hormone replacement therapy or in the postmenopausal females, hormone replacement therapy in the postmenopausal females and contraception in the premenopausal females is a contributing factor for the risk factors of the breast cancer. Next slide, please. So this is a very famous chart. Everybody has an idea about this, because we classify the risk factors into non-modifiable risk factors and modifiable risk factors. So modifiable risk factors are definitely female sex, as the breast cancer is most common in women. Older age, as the age increases, breast cancer becomes even more common. Coming to the family history, genetic mutations, race and ethnicity. So white women, Caucasian women has a very high risk of breast cancer compared to the Asian or Hispanic women. Pregnancy and breastfeeding, menstrual periods, that is early, late menopause, early menarche, density of the breast tissue. Again, it has been suggested that whenever there is a very high density of the breast tissue, it is again a risk factor for the breast cancer. Coming to the modifiable risk factors, hormone replacement therapy is a risk factor. Diethyl-stilbestrol is a very controversial drug which is commonly used in pregnancies, and it has been suggested that when diethyl-stilbestrol is used during pregnancy, not only the mother who gets the drug is at the high risk of the cancer, along with that her baby is also having the very high risk of breast cancer. So physical activity, increased physical activity has overall decreased risk of breast cancer. Overweight and obesity is again a contributory risk factor for breast cancers, as well as smoking and alcohol. And there is one data which has been mentioned here. It says that excessive exposure to artificial light. So excessive exposure to artificial light in few studies has also suggested to be a very contributing factor for the breast cancer. It is named as ALAN, which is artificial light at night. So when people are working under the artificial light, especially for the people who do night jobs, so exposure to the artificial light is again a contributory factor for the breast cancer. Next slide, please. So these are the very common genes which are commonly mutated for the breast cancer, and everybody knows that BRCA1 and BRCA2 gene, they are very much contributory to the breast cancer. BRCA, when the gene is positive, breast cancer risk is as high as 45 to 87%, whereas in BRCA2 the breast cancer risk is 50 to 85%. Next slide. So familial breast cancers. So it causes 5 to 10% of all cancers and 25% in women less than 30-year-old. Any woman diagnosed with the breast cancer who is less than 30 years of the age, the possibility of it being because of BRCA1 or BRCA2 gene is very high. And these, any ladies getting diagnosis of breast cancer less than 30 years of the age should always get a genetic counseling, and they should get a genetic testing done. Next slide. Next slide, please. So coming briefly about the classification of the breast cancers. So broadly it is in situ carcinoma or the invasive carcinoma. Under the in situ carcinoma we have ductal and lobular types. Among the ductal we have many other types like comedo, cribriform, papillary, solid, micropapillary. Coming to the invasive carcinomas, the most common, as we all know, is the infiltrating ductal carcinoma. Then the other less common varieties are tubular, mucinous, medullary, and invasive lobular. Next slide. So these are the types of the breast cancer. As we discussed earlier, infiltrating ductal cancer is the most common cancer diagnosed among the women. It contributes to around 80% of the overall load. Then coming to the infiltrating lobular carcinoma contributes to 10% of the cancers, whereas all these medullary, mucinous, papillary, and Paget's disease, they are all less common varieties of the breast cancer. Next slide. So nowadays, this histology has very much treating implications in the breast cancer. This histology has changed the way the breast cancers are treated due to the emergence of the newer chemotherapy drugs, due to the emergence of newer monoclonal antibodies. The overall treatment of the breast cancer was changed by the discovery of these various hormones and the suggestion that the breast cancer is a hormone-dependent cancer. So based on the hormonal receptors positivity or negativity, the breast cancer has been variously classified broadly into these 5 to 6 groups. So among which luminal A is the most common, luminal A, luminal B, normal breast-like, HER2 enriched, and basal-like. I will have a very brief discussion about this in the coming slides. Next slide. So luminal A type. Luminal A type is the most common variety of the breast cancer happening. So it contributes to around 70% of all the breast cancers. So here the most important characteristic is the ER and PR hormones are positive, whereas the HER2 hormone is negative. ER, PR, estrogen receptor positivity, progesterone receptor positivity is the main hallmark of this type of cancer. And the noteworthy point here is they are very low grade cancers, they are slow growing cancers, and they tend to have a best prognosis. So any lady getting a luminal A type of breast cancer which is diagnosed in the early stages of the disease, then we can say with confidence that she has a very high cure rates by surgery and chemotherapy, conjugately plus or minus radiation, or by the hormonal therapy. So when the person gets diagnosed with this type of the cancer, she has a very high cure rates. The next slide, please. So luminal B, the main difference between luminal A and luminal B is luminal A is always HER2 negative, whereas luminal B can be HER2 positive. So here the ER-PR can be positive or negative, whereas the HER2 will be positive. So luminal B type is again is a higher grade cancer, and it has a worse prognosis. Next slide. The third category is the HER2 enriched category, and nothing much to say because this is also a very worst prognosis. It has a worse prognosis, and it is also a high grade cancer. The HER2 enriched group makes up to 10 to 15% of breast cancers, and it is characterized by the high expression of HER2 with absence of ER-PR expression. So HER2 enriched cancers grow faster than the luminal cancers and used to have the worst prognosis of subtypes before the introduction of the HER2 targeted therapies. Before the introduction of HER2 targeted therapies, any HER2 cancer had a very high mortality rate, and it had a very high worse prognosis. After the discovery of the monoclonal antibodies for the HER2 positive targeted therapies, the overall prognosis has improved by a little. So how to differentiate between the HER2 enriched and the luminal B? This is by the fact that HER2 enriched is always ER-PR negative, whereas the luminal B, it can be ER positive. So next slide. The fourth category is the basal-like, or it is also called as the triple-negative breast cancer. So this constitutes about 20% of all the breast cancers, and again it is a worse prognosis cancer. It is biologically very aggressive, and with this type of cancer diagnosed before the surgery or before starting any treatment, it is a very noteworthy point to mention that any TNBC cancer at any of its stage, whether it is early stage or the late stage, it should always be treated with the neoadjuvant chemotherapy first, because by starting the neoadjuvant chemotherapy, we will gain the information, prognostic information about the nature of the disease. If we directly do the surgery, then that critical point is lost. So whenever a patient is diagnosed with the triple negative breast cancer, it is imperative to mention that the physician or the surgeon who diagnoses should always start with the chemotherapy first. So majority, approximately 80% of the breast cancers arising in BRCA germline mutation. So ladies in the early age diagnosed with the triple negative breast cancer, they have very high possibility of BRCA gene to be positive. So this indicates that if she has any daughters, if she has any children, they are also at very high risk of having the BRCA gene positivity. TNBC tends to be biologically very aggressive and is often associated with very worse prognosis. The most common histology seen in TNBC is infiltrating ductal carcinoma. Next slide. This is again another variety of the breast cancer which has very less implications on the overall treatment of the breast cancer. So this is same like triple negative, where all the hormonal receptors are negative, and the difference is it is characterized by the low expression of genes involved in the center cell adhesions. Next slide. So coming briefly about the presentation of the breast cancer, so all the dignitaries present, all the delegates present here, they have definitely a very good idea about the various stages of presentation of the breast cancer. I will just be briefing about this topic very superficially. So early breast cancers are asymptomatic, whereas the tumors, always all the lumps, any painless lump in the breast cancer should always arise the suspicion of it being a cancer. Next slide. So these are the clinical, coming to the most common presentations. So breast lump is the most common presentation of any female diagnosed with the breast cancer. Then there are other presentations like nipple retraction, nipple discharge, nipple excoriation, then nipple pain, then redness over the skin, thickening of the skin, powdery orange, skin tethering, dimpling, and axillary lumbar mass. Next slide. So these are various presentations of the breast cancer, again in a pictorial form. Next slide. So when the breast disease is locally advanced, so it can, and she was at the age of 28, her only presentation was pain in the hip joint. She had a very constant pain. She used to do yoga, she used to do regular walking, she used to do all the physical activity, and she had only constant pain at the right hip joint. There was nothing else which she complained of. Then getting an X-ray of the hip joint, there was nothing much we could make out, because X-ray is a very vague investigation, especially to know whether the metastasis is starting early in the bone or not. So we had to then subject her to just general physical examination. So during the general physical examination, we happened to ask her many questions, and by that she even happened to reveal a thing that she had a very small lump in the breast which was constant for the past 6 months. Again, this lump being constant in the past 6 months, it is again not a contributing history for diagnosis of a cancer, but still we prefer to have a good clinical examination. After the clinical examination and considering its suspicious nature, we subjected her to the FNAC first. Then in FNAC we got the diagnosis of it being breast cancer, and when the whole body PET scan was done for her, we got to reveal that she had a metastatic deposit in her right head of the femur. So this was one of the very rare presentations where the patient will not present to you with a breast lump. She will present to you with very vague symptoms like bone pain, back pain, leg pains. So these pains in any patient who is suspected to have a breast cancer should be taken very seriously. Then any patient who is having a liver mets, she can present to you with the jaundice. And if there are lung mets, she can present to you with the breathlessness or cough. So another noteworthy case, I am taking a lot of time, I am sorry for that. Another noteworthy case which happened just last week was, there was one lady who had multiple brain lesions, though it was reported as multiple subdural hematomas. Her only complaint was severe headache and she had blurring of the vision. Considering this, some neurosurgeons, they tried to get a hematoma evacuated. They didn't know the proper reason, she didn't give any history of trauma or any RTAs. But considering the report, they went forward to remove the hematomas, and they found out that it was not a hematoma, but it was a lesion which was profusely bleeding. Then they happened to get a biopsy and get out. So after the biopsy, it revealed that it was a cancer, probably breast cancer. Then they happened to check her breast, then they found a lump. So this again emphasizes the most important aspect of the overall treatment of the patient is the clinical examination. Clinical examination, irrespective of the symptoms, has to be done in very detail. We have to look at all the lymph nodes, we have to look if there are any lumps. We have to ask leading questions to the patients whether she has any lumps which in the body which are not painful, which are not troubling her. Because the patient, if something is not troubling her, she will not think that as a symptom. Next slide, please. Coming briefly about the treatment strategies, other delegates will be speaking very detailedly about this. I will just have a little word about this. So as we all know, coming to the surgery, we all know that there are two major types of the surgery. One is breast conservation surgery and then mastectomy. Whereas to address the axillary lymph nodes, we have two varieties, that is sentinel lymph node biopsy and then we have axillary lymph node dissection. Next slide. Chemotherapy can be neoadjuvant chemotherapy, which is given before the initiation of the surgery, and it can be adjuvant chemotherapy, which is given after the surgery. So neoadjuvant chemotherapy is used for locally advanced breast cancers, inflammatory breast cancers, for downstaging the large tumors to allow for the breast conservation surgery to happen. In small tumors or in worst prognostic molecular subtypes, which can help to identify the prognostic and predictive factors for the response. As I told you earlier, any patient diagnosed with the triple negative breast cancer or HER2 enriched breast cancer, these are the varieties which should receive always neoadjuvant chemotherapy. Before the initiation of surgery, they should always receive chemotherapy, irrespective of their size, irrespective of their early stage, irrespective of their axillary lymph nodes not being palpable, irrespective of everything, these two varieties they should always receive neoadjuvant chemotherapy always. Next slide. So various varieties of radiation therapy are available. Next slide. Coming to the hormonal therapy, various hormonal therapy, these hormonal therapy are employed only for the patients who are ER and PR positive. If they are negative, then hormonal therapy doesn't work for them. Next slide. Coming to the newer targeted therapies, as I was speaking earlier, HER2 positive breast cancer, for all the HER2 positive breast cancer, nowadays we have drugs like trastuzumab and pertuzumab. These are the major drugs, and after the invent of these drugs, the HER2 positive cancers, in the HER2 positive cancers, the overall survival has increased. In case of luminal HER2 negative breast cancers, premenopausal women more often receive everolimus STAR inhibitors with exemestane. Next slide. So coming to the conclusion, again emphasizing the same thing again and again, as the morbidity and mortality rates of the breast cancer have increased significantly over the past decades, it is an urgent need to provide the most effective prevention strategy. Prevention is always better than cure, as they say. So most effective prevention, taking into account that modifiable risk factors might be crucial in providing the reduction of breast cancer incidents. Next slide. Thank you. I thank everyone for giving me time and listening very carefully for my talk. I really thank everyone. Thank you, sir.
Thank you, Dr. Arun Kumar Bharat, for a elaborative update on carcinoma of the breast. As the time is very short, it's open to the auditorium. Anybody can ask questions and let it be brief.
Introduction of the carcinoma of breast.
Thank you.
Just I want to know, you have mentioned about the carcinoma of the breast in young ages, that is less than 30 years.
Correct, sir.
So, what we are, I have given a breast cancers in the youngest age of 22 years.
Positive.
On the FNAC, not the like cord needle, not the excision. So just I want to know that you have mentioned the causes of the breast cancer about the familial history. So just I want to know about the whether is the only cause is the familial BRCA1 gene only the cause or genetic cause or other than this?
Yes, sir. Sir, there are many other genes which are mutated in and they help in the causation of the breast cancer. BRCA1 and BRCA2 are the most prominent genes. Whether along with that we have other genes like BRIP1 gene, and there is ret oncogene is also contributed to the breast cancer. Along with this, any ladies who are getting breast cancer at a very early stage, for example, as you told, your patient was 22 years old. So these patients, they have very high probability of having BRCA1 positivity. So these patients who are getting a breast cancer at this age, as you told it was 22 years, these patients should always be subjected to genetic counseling. They should always, not only her, if she has daughters, then her daughter should also get BRCA testing done. And this is a patient developing breast cancer at this age, the genetic cause is very high.
So what is the incidence of the routine like dietary factors involved in this?
Sir, dietary factors, as again the previous speaker has highlighted, high fat diet, high calorie diet, lack of exercise, smoking, alcohol, they are all contributory factors for the
breast cancers?
The incidence of this genetic factors or familial factors is more important, or the dietary factors is important?
Sir, actually, breast cancer at the age of 60 or 70, genetics contribute only to 5 to 10% of the cases. Beyond that, majority of the causes are environmental causes and the genetic predispositions. So when the patient is diagnosed with the breast cancer at the age of 60, the genetic contributory cause is only 5 to 10%. Rest of it is environmental causes, which can include the dietary factors as well. So in the Indian population, considering the increase in the overall incidence of the breast cancer, which has happened in the past decade or the 2 decades, so it has been mentioned that the dietary factors is a major contributory factor, because nowadays the junk food has increased. High fat diet, high calorie diet with low amount of nutrients is very common among the people consuming especially in the urban as well as in the rural populations. So dietary factor is a major contributing factor at the age of around 60 years.
It is in the high socio-economic status.
Sir, high socio-economic status was described 2 to 3 decades back. Nowadays, high socio-economic status doesn't matter, sir, because even the poor people have access to the high calorie, low nutrient diet.
Yes,
because the poor people, poor people are getting engaged in the junk food more often, and they are using the high fat content, because nowadays oil, everything has become so accessible, and they are taking a lot of junk food. Even the low socio-economic patients, they are at a very high risk of getting breast cancer because of the dietary factors.
So the junk food is a contributor factor, what do you mean to say?
Definitely, because it is rich in calories and fat, whereas it is very low in nutrients. So,
the concept of old age breast cancers, what we are saying, is absolutely gone. So whether what is a 30 years, 20 years, we can...
Dr. Bharat, I think we are running short of time. There are a lot of questions to be taken, but let us discuss this in the afternoon session.
Right, sir.
And I thank you very much for your informative talk.
Thank you, sir.
Thank you.
We are very grateful and thankful, Dr. Arun Bharat sir, for gracing us with your insightful words.
May I now request Dr. R.G. Devni sir, Professor, Department of General Surgery, to felicitate Dr. Arun Bharat sir.
I request Dr. Devni sir to felicitate our chairpersons.
Thank you, Dr. Devni sir. Continuing with the next session,
May I now request these chairpersons to please come forward and to be seated on the dais.
Dr. Abdul Basir sir, Professor and HOD, Department of Community Medicine.
Dr. Nitin Tengri sir, Associate Professor, Department of Surgery, MRMC.
Dr. Nagendrappa Patil sir, Professor and HOD, Department of Radio Diagnosis.
Dr. Bilal Ahmed sir, Professor, Department of Microbiology. Diagnosis, to please come forward and to speak on breast imaging.
Dr. Rupa Tandu ma'am did her MBBS from KIMS Hubli.
MD Radio Diagnosis from Government Medical College, Baroda.
She has worked in prestigious institutes like CMC Vellore.
She has published many publications in national and international journals.
We welcome you, ma'am.
Good morning, everyone. At the outset, I would like to thank the organizing committee for giving me this opportunity to talk on imaging of breast. So, outline of my talk will be like this: introduction, different imaging modalities available, and later touching upon the advanced breast imaging techniques. As we all know, the breast cancer is among the top 3 cancers in the world, second to lung and colon cancer. 1 in 8 women will be affected by breast cancer. So the primary aim would be to detect the cancers early so that best treatment option would be given to the patient and survival will be improved. Mortality will be less. With the advent of this screening mammography, breast cancers are detected early and they are treated early so that mortality is less. Different imaging modalities available, they have specific indications. So these modalities have, so the diagnostic imaging modalities which are most commonly used are, one is mammography, ultrasound and MRI. The choice of modality will depend upon the age of the patient and the density of the breast tissue. Coming to mammography, mammography is nothing but simply the X-ray of the breast. So there are two types of mammo. One is screening mammo, another is diagnostic mammo. Screening mammo, it is done for asymptomatic females. It can be started at the age of 40 to 45 years. And diagnostic mammo, it is whoever is coming with symptoms like pain, discharge or lump, or else any pathology which is detected on screening mammo, we have to evaluate it further on diagnostic mammo. Sometimes we will be picking up lesions on CT chest or PET CT or MRI. So those lesions will be evaluated better on diagnostic mammo. Any lesion which was earlier diagnosed as benign, and to follow up those lesions, diagnostic mammo will be applied. So how do we do mammo? So here the breast tissue will be compressed and then X-rays are passed through the breast gland and we will be acquiring the images. So these are the two, So this is how the breast tissue will be compressed. This is a compression plate. So there are two weaves. One is CC, that is craniocaudal weave. Another is MLO weave. In CC weave, the breast gland is compressed from superior to inferior aspect, that is craniocaudal. And in MLO, it is compressed in the oblique fashion from medial to lateral aspect. The basic principle behind this compression is the breast gland will be spreading out so that any lesions, especially the cancers, will be picked up better. So this is how the mammo of the breast will look like. American College of Radiology has given these 4 types of breast composition. The first one is composition A, that is predominantly fatty. Here the percentage of the glandular component will be less than 25%. We all know breast contains fat component, fibrous component and glandular component. So this composition type A, the sensitivity of the mammo will be very high. Breast cancers will be detected much better. Composition B, that is scattered areas of fibroglandular density. Here 25 to 50% of the glandular component will be there. Third type, that is composition C, that is heterogeneously dense. Here 50 to 75% of the glandular component will be there. Some small lesions might be missed on this type of breast composition. So last one is composition D, it is a dense parenchyma. More than 75% of the glandular component will be there. So this is the most difficult type of composition because mammography is very less sensitive. Carcinomas can be missed in this dense background parenchyma. So this is how we read these mammography images. So CC of the right breast will be compared with the CC of the left breast, and MLO of the right breast will be compared with the MLO of the left breast. So this is the skin, this is the nipple. Here we are seeing white thing is the fibrous and glandular component. This black thing is nothing but the fat. This is the pectoralis major muscle. So we have to compress and include the breast so as to include the inframammary region as well as the pectoralis muscle. And usually the marker will be placed on the outer quadrant. And we have to draw a line from the nipple to the pectoralis major. So that is called as posterior nipple line. So this will divide the quadrant into outer quadrant and inner quadrant. And in MLO view, we have to draw again this posterior nipple line. So this will divide the quadrant into upper and inner quadrant. So that's how we get outer and inner quadrant, upper and lower quadrants. And what is this? This is the pectoralis major muscle. So when MLO of both the breasts are put together, so this pectoralis major will form a shape of V. So what are we seeing here? These are the axillary lymph nodes. So always axilla should be included in MLO view to pick up lymph nodes. And this will be divided into anterior 1/3, middle 1/3 and posterior 1/3 of the breast. So let us see a few examples. A 54-year-old lady presented with lump. So what are we seeing in this? This is MLO view of right and left breast. Here we are seeing some abnormal density lesion. So always on mammograph, we have to see the density of the lesion in comparison with the glandular component. Whether it is equally dense, whether it is more dense, or is it less dense or fat dense. Fat density lesions are usually benign. So here we are seeing a high density lesion. It is lobulated, it is showing some calcification, it is located in the posterior third of the breast, located in the upper quadrant. And the same lesion in the CC view, it is located in the outer quadrant and in the posterior third of the breast. So this was thought to be benign, and FNAC showed fibroadenoma. Another case, 54-year-old lady presented with some pain. Here what are we seeing in the lower quadrant? There are some microcalcification. Some are linear, some are rounded. All these are in different shapes and they are very tiny. There is no discrete mass, and the same microcalcification in the craniocaudal view. And this turned out to be DCIS on histopathology. Next, 68-year-old lady presented with lump. So what are we seeing in this case? There is a high density lesion. It is a well-defined lesion. It is showing irregular spiculated margins. So this is located in the middle and posterior third of the breast. If you notice here, this is the nipple region. Here nipple is retracted. Even we can appreciate this on CC view also. So there is nipple retraction, there is some amount of skin thickening. If we see here in the axilla, we are seeing axillary lymph nodes. So there is a high density lesion associated with nipple retraction, some amount of skin thickening and axillary lymph nodes. So this is a straightforward case of breast carcinoma. So what are the advantages? Advantages is that it will detect microcalcifications much better, and microcalcification is one of the important feature of malignancy. And disadvantage is it carries a risk of radiation hazard. And the second thing is dense parenchyma. As I showed, ACR 4 type of composition, that is dense breast parenchyma, malignancies will be difficult to pick up. Next modality will be ultrasound. It is done usually with the help of high frequency linear transducer. Patient will be lying down supine. So how do we do it? We can follow 3 methods. It could be radial pattern in a clockwise direction, or vertical pattern, or horizontal pattern. Any pattern we can follow. The main thing is that we have to cover the entire breast. And imaging of the ultrasound is incomplete without the examination of the axilla. Axilla should be evaluated to look for lymph nodes. So what are the indications? So any patient who is, young patient who is coming with symptoms like pain, discharge, or any lump, especially less than 30 years of age, and pregnant and lactating patients. And the best advantage of ultrasound will be it differentiates solid from cystic lesion. If we pick up some lesion on mammo and MRI and those lesions are indeterminate, next we have to take the help of ultrasound. That is called as complementary assessment. And being a real time imaging, ultrasound will help in guiding the biopsies. And sometimes in case of cyst and abscesses like breast abscess, it will help in aspiration. So we have some different subtypes in ultrasound. The conventional is B mode. It's also called as grayscale ultrasound, where lesions will look in black and white. And we have something called as Doppler. Here we will be placing color. So the basic principle behind this color Doppler is tumors, because of neoangiogenesis, they will show vascularity. So on color Doppler, the malignant lesions will show vascularity and color. And the third will be elastography. So the principle behind this will be the malignant lesions tend to be harder. So they will show stiffness. Benign lesions are usually soft. So this is an example. So here the lesion on B mode and color Doppler and elastography. Here we are seeing a well-defined hypoechoic lesion, and we are placing color Doppler. This is a color coding. Here we are seeing vascularity because of the neoangiogenesis. And elastography, here color coding is given. So this lesion is very hard, stiff. So here we are seeing red. So this means this lesion is malignancy because of increased vascularity as well as stiff nature. So American College of Radiology has given BIRADS classification for uniform reporting purpose, breast imaging reporting and data system. Type 0 means the study is incomplete, that is incomplete evaluation. For example, in case of dense breast parenchyma, mammography is incomplete, we cannot see any lesion. So in those cases, we have to do ultrasound. We have to take help of another imaging method to assess that breast. So that is BIRADS 0. BIRADS 1 is nothing but a negative examination, means normal study. There is no focal lesion, no calcification, no abnormality. Type 2 means benign finding. Example, simple cyst, intramammary benign lymph nodes, or else fat necrosis, or calcified popcorn showing calcification type of fibroadenoma. And BIRADS T is nothing but probably benign. Short-term follow-up is needed for these type of cases. The risk of malignancy in these cases is less than 2%. Next we have BIRADS 4, that is suspicious abnormality. We cannot place the abnormality in definitely 5, that is carcinoma, or definitely benign. So in those cases, it will be subcategorized into A, B, C, depending upon the risk of malignancy. If it carries 2 to 10% risk of malignancy, it is A, B is nothing but 10 to 50%, and C from 50 to 95%. And BIRADS 5 is nothing but the features are highly suggestive of malignancy, that is more than 95%. BIRADS 6 is nothing but biopsy proven malignancy. Example will be patient would have come with carcinoma of right breast. Now we are evaluating left breast, that is to rule out any lesion. So let us see a few example. Sorry. So here what are we seeing? There is a well-defined, wider than tall hypoechoic lesion. So this is the ultrasound image. Here this is skin, this is the fat component, this is the glandular component, this is the pectoralis muscle. Here if you see the transverse diameter is more, and this lesion is parallel to the chest wall. So this is wider than taller. It is showing a well-defined echogenic capsule. There is no calcification in this lesion. If you see, we have put color Doppler. There is no vascularity. So well-defined, wider than taller lesion. It has got a echogenic capsule. There is no calcification, no internal vascularity. So this lesion appears to be a benign. So diagnosis is fibroadenoma. This will be placed in the BIRADS 3. This lesion also showed some macro calcification, that is a popcorn calcification. So this lesion here, if you see, this lesion is taller than wide, and if you observe, there are microlobulations, and if you notice here, there is some dense black thing. This is called as posterior acoustic shadowing. So taller than wide lesion with microlobulations and posterior acoustic shadowing, this will be nothing but BIRADS 5 malignant lesion. Advantages of ultrasound will be, there is no risk of any radiation, it is easily available modality and very cost effective. Disadvantage is that it takes lot of time and it is operator dependent. Next modality will be MRI. Usually it is done minimum with 1.5 Tesla magnetic strength MRI, done in prone position. Why prone position is needed? The breast tissue will spread out and cancer detection will be improved. And we have to use a dedicated breast coil. This will improve the image quality. And the important sequences will be T1 weighted, T2 weighted images, diffusion and dynamic contrast enhanced images. This is the prime sequence to detect carcinomas. So indications of MRI would be, primary indication would be breast cancer staging. Second thing, we to look for multiple lesions, like invasive lobular carcinoma, they are known to be multicentric and multifocal. And we want to assess the response to neoadjuvant therapy, which will have a surgical implications. Problem solving, whenever we have doubt on mammography or ultrasound, ultimate problem solving tool will be MRI. In high risk screening, patients who are carriers of BRCA1 and 2 gene, and screening of women with extremely dense breast. As we have discussed, mammography will be less sensitive in those patients, MRI will be helpful. And some patients can present with isolated axillary lymph node metastasis and no focal lesion on ultrasound mammo. In those cases, MRI will be very much helpful. Evaluation of the breast implant, and to identify any recurrent carcinoma in a case of breast conservative BCS patients. So let us see one MR image. So this is how MR mammogram will look like. This is the breast, this is sternum, this is heart, this is pectoral muscle, this is chest wall muscle. So this bright thing is nothing but fat in the breast parenchyma. Here if you notice, there is some hypointense lesion. This is the skin on the right side, and here if you can see, the skin is thickened and it is edematous. The stir sequence, we can appreciate edema much better, and the lesion is looking hypointense. On dynamic contrast enhanced images, this lesion is enhancing brightly with some central necrosis. And here if you can see, there are axillary lymph nodes. So intensely enhancing mass lesion with enhanced axillary lymph nodes with diffuse skin thickening and edema, it is nothing but a case of Barrett's 5 malignant lesion. So advantage is that there is no radiation risk associated with MRI. That's why high risk patients, they will be followed up with MRI. It is very high sensitive to detect malignant lesions. The disadvantage is it is availability, and it is very costly. It takes lot of time to acquire these images, and we cannot do in case of claustrophobic patient and one who have metallic implants like pacemaker or aneurysmal clips. Advanced imaging techniques will be digital breast tomosynthesis, automated breast ultrasound, contrast enhanced mammo, and elastography, as we have discussed earlier. So digital breast tomosynthesis is nothing but a 3D reconstruction will be done from the multiple radiographs which are taken at different angles. If we see, the X-ray tube will rotate for an angle of 15 to 60 degree. So multiple images will be acquired through the breast tissue, and from that data will be reconstructed, and we will be interpreting those images. So what is the benefit of DBT? So here the burden of overlapping tissue will be reduced, so that detection of the cancers will be better. And another advantage is that architectural distortion will be better seen. So what is architectural distortion? It is nothing but a small area of some spicules or lines. There will be no discrete mass. So this is how the conventional digital mammo will look, and these are the DBT images. If we see here, other overlap dense parenchyma will be suppressed, and here we can pick up the architectural distortion. This is one of the findings of carcinoma. The disadvantage is it takes lot of time, again because of motion and the tube rotation, we can have artifacts related to that. The take home message is that screening modality will be mammography. And mammography will pick up calcifications much better, which is one of the important findings in case of carcinoma. And for younger patients, one who are pregnant and lactation, there is no radiation risk, so that's why ultrasound is the best modality. Patient post-operative period where we are suspecting some collections and seroma, the best modality will be ultrasound. And in case of breast where sensitivity of the mammo is less, ultrasound or MRI will be better. Ultimately, whenever we have doubt on mammography or ultrasound, the best problem solving tool will be MRI. Having said this, all these modalities are complementary to each other. We have to take help of each other, that is hybrid imaging, which will increase the detection rate of malignancy and ultimately helps in detecting cancers early, and treatment will be given early. Thank you for it.
Thank you, Rupa madam. You made it a very simple manner within 15 minutes. It was indeed very good, and you have elaborated easily and made it very simple.
Thank you, sir.
Thank you.
Heartful thanks to Dr. Rupa Tandur ma'am for your contribution, and we are privileged to have you here.
May I now request Dr. Baswant Patil sir, Associate Professor, Department of General Surgery, to felicitate Dr. Rupa Tandur ma'am.
I request Dr. Baswant Patil sir to felicitate our chairpersons.
Dr. Abdul Basir sir, Professor and HOD, Department of Community Medicine and also Director IQAC for KBN University. Dr. Nitin Tingli sir.
Dr. Nitin Tengri sir.
Dr. Nagendrappa Patil sir.
Dr. Bilal Ahmed sir.
Thank you, Dr. Baswant Patil, sir.
May I now request these chairpersons to please come forward and to be seated on the dais.
Dr. S.S. Kharbari, sir, Professor, MRMC, Gulbarga.
Dr. Girish S. Nulla, sir, Associate Professor, ESIC, Kalaburagi.
Dr. Rajshri Paladi, ma'am, Dean Research, KBNU University, Kalaburagi.
Dr. Srinivas K, sir, Professor and HOD, Department of Anesthesiology.
Dr. Vinod Uplonkar, sir, Associate Professor, Department of Pediatrics, KBN University, to please come forward and be seated on dais. Dr. Zeenat Begum, ma'am, Professor, Department of Pathology, KBNU, FOMS, and Member Secretary, Scientific Review Committee, to come on the dais and talk on breast tissue diagnosis. We welcome you, ma'am. Dr. Zeenat Begum, ma'am, did her MBBS from Alamin College, Vijaypura.
MD in Pathology from JJMC, Davangere.
She has trained for transfusion medicine from Tata Memorials.
She has published 22 publications in histocytocorrelation in clinical pathology, cytology, breast and gynec pathology, and various others.
She is MEU coordinator since 2020. We welcome you, ma'am.
Thank you so much. Good morning, everyone here. I'm not listening the good morning back. Good morning, everyone. Thank you so much. At the outset, I'd like to thank Dr. Mainuddin sir for giving me opportunity to speak the experience here. My topic is on diagnosis. I would like to just highlight all the diagnostic efforts, difficulties, and the conclusion during the 17 years of the tenure of the post-MD pathology. So here is the PPT. Can I have your PPT, please? Beyond the microscope, navigating the landscape of the breast lesions. This is, our audience will not be very interested in knowing what is there in the histopathology. I just want to give the entire conclusion of the lesions about the breast. Can I have next PPT? Here is the FNSA request slip. We actually all the pathologists would like to have from the requesting doctors, whether it can be surgeons or the gynec individuals. So everything what we expect from the final aspiration cytology request is the clinical features, which is actually visioned by the surgeons, visioned by the OBG persons, visioned by the physicians who are requesting for the FNAC. Actually, the patient is there right in front of us. We will not be that good in giving the conclusion about the what is there in the examination part of the breast. So we expect the entire FNAC form to be filled properly in this manner. This is the standard FNAC request slip. Next slide, please. Same way, after FNAC, if you get some conclusion about that to be subjected for the histopathology, what should be there in the histopathology slip? This is the request, which is the standard request slip. Try to write about what is there in the type of the biopsies, what kind of a, because in histopathology sections, we are not there to see the patient. What we receive is only your request letter and the specimen with us. So it is not going to bias us, but what is there in the microscope, what we are going to see. It is going to help the patient to finalize the diagnosis based on whatever clinical features you are going to write, whatever the special investigations which were offered, what were the final conclusion about the radiology diagnosis, all that should be mentioned in the histopathology request form, other than all that details which are required and everyone knows about it. Thank you so much. Next slide. Let's not have a confusion among what is there, what I'm going to see, and what I'm going to discuss with my prescribing doctors. Next. I would like to begin with the non-neoplastic lesions of the breast, which are more common than the malignancies and which are usually ignored. And that is why I just want to start inflammatory and infectious lesions, which with we have the acute mastitis, which is turning to be abscess most of the time, amyloid benign breast implant related changes, cystic there are so many number of cases where we are going to see the non-neoplastic lesions. Next slide. We'll have a WHO classification. Next slide, please. WHO classification of the breast neoplasia based on 2019. We are not going to tell in detail about what is there in the epithelial tumors and all. Next slide, please. So we have a rare and salivary gland type of a tumors, because here I'm just insisting again more on the request. So give me the proper request, so we'll have a proper conclusion about what is the disease it is. So neuroendocrine neoplasm, which are though rare, are encountered in the breast. Next slide, please. Epithelial bioepithelial type of tumors are seen. Non-invasive lobular neoplasia is seen. Ductal carcinomas of various categories of low nuclear grade, intermediate nuclear grade, and high nuclear grades are encountered in the breast. Next slide. Benign epithelial proliferations and the precursors, usual ductal type of hyperplasia, all that, and then adenosis, papillary neoplasm, which was again discussed by Dr. Arun Barat sir. So we are not going to tell in detail about it. We'll have, next slide please. There are adenomas which are seen, and the numbers here given is the ICD coding numbers for each disease we are having. So mesenchymal tumors are rare, vascular tumors are even rare. Next slide. Fibroblastic, myofibroblastic tumors are also rare, but they are seen in the list of cases are many when it comes to pathology. But next slide, please. Adipocytic tumors are there. Fibroepithelial tumors, here are the fibroadenomas, all that are more common than anything else. The category number 12 is more common, which are encountered in benign lesions, like fibroadenomas, villus tumor which could be benign, borderline malignant, and some hematomas. Next slide, please. There's the nipple. Again, we have the lesions on the nipple also. So malignant lymphomas are also seen in the primary breast lymphomas are also common nowadays. They are also seen in the breast. Metastatic tumors are rare. Tumors of the male breast are seen as a gynecomastia and carcinomas, which could be invasive carcinoma, in situ carcinomas. Here to highlight, in male breast there are more of the familial cases than that of a normal individual, sporadic cases. What surgeon wants? Very simple. Whether it should be a neoplastic, they don't want what all the classifications are mentioned. What surgeon actually wants, whether it is a neoplastic or non-neoplastic. If neoplastic, it is benign or malignant, and if it is malignant, what are the prognostic factors? If non-neoplastic, what could be the etiology? This is what they want from us. So next slide, please. Let's begin with the HPR sample. I would like to thank many of the persons who are sitting here in the audience for supporting me with their histopathology. Here is the list of the HPR sample for the last case, having 277. The fibroadenomas were the most commonest lesions. Then again, we have a fibrocystic disease without atypia and the carcinoma breast. Here is the, I just want to tell something about the fibrocystic disease without atypia. Some of the doctors, male doctors, most of the time at the villages and all, are not very comfortable to examine the breast. So when the patient comes to the doctors telling that I have something in my breast, they directly send to the FNSS, what I have encountered in my practice. So when it is usually written as bilateral breast disease. When you see, it is the pathologist's job also to see what is there in the breast. So most of the time it is the costochondral junction pain or the cervical spondylosis which is radiating to the breast, and nothing is there in the breast. But as a pathologist, we are supposed to prick the breast and then find out what is there. And at the end, we are not getting anything in that except a few ductal epithelial cells which are as a bare nuclei and nothing else. So which is turning to be making the figure of fibrocystic disease without atypia as more than actually which should be noted. So here it was just wanted to highlight this point. Again, we have this 2018 onwards, what I have seen increase in the number of cases for malignancies. Carcinoma breast. Then granulomatous diseases, mastitis, which is AFB negative, CBNAT negative. Again, it is most commonly granulomatous mastitis. What we are encountering is AFB negative. They are not non-tuberculous. So it is idiopathic granulomatous mastitis, which is more commonly than. I just got one case of tuberculous mastitis, which was AFB positive as well as CBNAT was confirmed positive, and patient was treated very well with the ATT and was responded very well. Then we also have a fibrocystic disease with atypia, which on biopsies and along with that radiological examination proved to be having intraductal carcinoma, not invasive type, and also had a atypical ductal hyperplasia. Benign fillets are more common than the malignant fillets. One I came across one tumor with the malignant fillets, which were, could be malignant fillet or was a fibrosarcoma. I was not very much sure. The further follow-up was lost for this patient. Papillomas are also there, which are encountered, tubular adenomas. Among fibroadenomas, also seen the lactating adenoma. Next slide, please. Just differences between how fibroadenoma looks like, different from the filostoma. It looks almost similar. The only difference what we see is a more cellular stroma. Also, the leaf-like pattern of arrangement of the ducts with the stromal elements having the nucleus which is perpendicular to the ductal elements. I just want to highlight one more condition here. This was a case, the fillets here given here. This case, next slide please. Next. Previous slide. This was a fillets case which came to me, and even before the histopathological sample here, I'd like to thank here Dr. Suresh Patil sir for having confidence in me in sending the samples. And here is a case, your own case. This case was, FNAC was performed, the needle was in duct. It was not in the stroma. And what I got is, next slide please. This is what I got. A monolayered sheets of ductal cells which were bordered by myoepithelial cells. And I've given the diagnosis of fibroadenoma based on this cytological picture. Because my needle was in duct having proliferative activity, and the diagnosis was fibroadenoma, but later on histopathology it turned out to be a benign fillets. Yeah, here is the difference to show the differences between, here is the malignancy and this is the benign condition. Benign usually have the cohesive clusters of the ductal cells, and malignant have discohesive clusters. And look at the pleomorphism, the cells are not smaller, or uniformity is not there. One is large, one is small. Here you have monolayer sheets of ductal epithelial cells, they are cohesive clusters. This is how the difference between the malignant and benign cells. Next. I want to begin with the case number 1, again with a simple thing. Here is a 42-year female with a lump in the breast. Previous FNAC reports were non-specific inflammation. USG-guided FNACs was carried out, and radiological features were benign cyst. And type of aspirate was chylous. What I got was a full white in color. That gave me one clue that something is there in the slide. Dispersed bare nuclei were there, and the lymphocytes were there. Whether they were bare nuclei or lymphocyte, it was hard to identify. Next slide, please. This is what I got in the FNAC. May I know the diagnosis, please? Anybody, please? What is this? And also I had a chylous, lot of lymphocytes in them. They are the RBC here, and this is the lymphocytes. And there are the two structures, parasite I could get here, which is very microfilaria, which is very common here in the South India and North Karnataka region. So this was the microfilaria, and the sir, again Suresh Patil sir, it was Suresh Patil sir's case, and with the DEC, patient responded very well and is discharged now. Next slide, please. Again, one more, I just want to highlight some of the interesting cases rather than going for a PPT which will show you how to approach for the diagnosis. Every one of us know how to go with the diagnosis. Just want to tell you. There is a 64-year case, nulliparous female, breast lump. This was given by my husband, Dr. Jelani, who is here again. So it is the case 64-year-old female, nulliparous female. USG was having hypoechoic mass. Mammography showed the architectural distortion. Then we had so many pleomorphic cells in the smear. Next slide, please. This is what I got. The cells are arranged in India file pattern. Look at this India file patterning. Okay, you can make out the cells very beautifully. They are arranged one after the other. Next slide, please. The histopathology, I always get whatever FNAC I get from my husband, the histopathology also I get. The histopathology sample showed look at the arrangement of the cells, one after the other. India file pattern in histopathology. This is in nulliparous female and was having ISC marker, ERPR. Can we have the previous slide, one more? Yes, one more back, one more slide. Yes. A lot of plasma-sided appearance and all in the FNAC. Next slide. Next. And here is this patient behaved very badly and was a large size, axillary lymph nodes were involved, higher histologic grade was there, E-cadherin negative, high Ki67 index and hormone receptors were negative. This patient responded very bad and could not survive the disease. Next slide please. I just want to highlight the importance of, what is the importance of doing FNAC without guidance and with guidance. This was a case, again having very small lesion in the breast. I was unable to palpate them. Then I just told I'm not able to find out what is there inside. So then the previous slide, please. Sonography, there were 2 lesions which were identified and were very smaller, and this was the lesion which had in FNAC fibroadenoma. And this was a lesion, it was a cystic and was having something which is looking like a papillary lesion inside. So this I could aspirate the material, enough material, and had a papillary structures in the FNAC finding. I'm not having the slide right now with me. The histopathology, next slide. Histopathology turned out it's very bright here, but this is a dark and having the papilloma inside. It was a benign papilloma, which was usually, without guidance. Most of the time, FNAC, we will miss the lesion. Blindly going, if it is not palpable, it becomes difficult to come to the conclusion. Next slide. Here is a 33-year female patient with the left breast mass, hard inconsistency. Usually, most of the time when you are not having FNAC and then you are already having the lumpectomy specimens with you, then you are going to have this type of etiology. Most of the time it is a granulomatous idiopathic mastitis. They are the giant cells here. Many giant cells are seen just next to the ducts here. It was AB negative and it turned out to be idiopathic granulomatous mastitis. Next slide. Again, one more slide. I just want to show the importance of the FNAC, which is guided and with the clinical relevance than without the guidance of the USG. A 39-year-old female with 2 fibroadenomas at the left breast, one at 9 o'clock and another was at 3 o'clock. FNAC was carried out. The report was dispatched as fibroadenoma. I have a very good radiologist who called me. Zinad, why are you giving report of fibroadenoma like this? There is something else is there. Then I was in hurry and then just signed out as a fibroadenoma. I was leaving. Then she called me, come back. There's something just sitting just below the nipple. Then she told, we'll revise FNAC again. The retroareolar mass, where in the mammography had a category 4 BIRAT, and the USG was showing something which is irregular in shape. Again, USG guided FNAC turned out to be a infiltrating ductal carcinoma. In one individual, I was having 2 fibroadenomas, which were very obviously noted on examination. This gives the importance of, here I admit that I failed to examine the breast properly, which was just below the nipple, the lesion was situated, and it was very small, 1.5 centimeter, though it was again taller than the wider, and that is why it was missed, and it was the infiltrating ductal carcinoma on FNAC itself. So coexisting lesions in the breast are very common, and that should be taken care. Next slide, please. Again, there is one more interesting case where I just want to highlight what was my mistake. So here is the 90-year-old female patient. The patient FNAC was carried out, and I could see again the back-to-back arranged cells which were plasmacytoid appearance. Then I gave this as a lobular carcinoma because I have missed this one which is there in the cytoplasm. I gave the diagnosis as lobular carcinoma again. So though infiltrating ductal carcinoma, NOS is very common than the lobular carcinoma, I am just discussing here the rare lesions. So lobular carcinoma, next slide please. Then gross I just received was an infiltrating mass located at the upper outer quadrant, which is measuring 3 into 3 gray white form with the mucoid areas and necrosis. Here I could see the mucoid areas. The next slide, please. They are the tumor cells. I just want to one more thing highlight here. The tumor cells are here not looking very much aggressive, but look at the pools of mucin. So again, going back to FNAC, I could identify, again, revive the slide with the previous FNAC, I could find intracytoplasmic mucin again there also. Then Elchin blue was, pass was carried out. Next slide, please. This was the pass positive. This was colloid carcinoma or mucinous carcinoma of the breast. Next slide, please. Next slide. Here how we categorize the carcinoma of the breast are low grade, intermediate grade, and high grade. This is modified Bloom-Richardson's grading system, where you have a more of tubular formation of more than 75 is grade 1 with the nuclear pleomorphism, where you do not have the nucleoli, and then 0 to 7 mitosis. And grade 2 will have a 10 to 75% of tubule formation, which are becoming less as it goes into the higher grade, and where the mitotic index is high here. And here there are 3 categories: one, tubule formation; second, pleomorphism; third where you have the second one is nucleoli, tubule formation is there, and then here can you see there is an abnormal mitosis and increase in the mitotic rate. I would like to differentiate this with, this much is not enough. Most of the, oncosurgeons giving the Bloom-Richardson grading is not enough for them. They want to confirm it with the Ki-67 indexing. That I am going to discuss in the next slide. Next slide, please. There's one more case I just want to highlight. Is a 48-year-old female with the 2 breast lumps, larger measuring 4 into 3 centimeters, smaller was 3 into 2 centimeters. Both were clinically mobile, fleshy. It was easily taken out from the breast. But one turned out to be a medullary pattern of invasive breast carcinoma, no special type, with having the syncytial arrangement, pushing margins, extensive lymphocytic infiltrated at the border. And this patient had a DR/PR positive, HER2 negative. This patient responded very well because the mass was smaller, were not having the axillary lymph nodes, and age was also not very old. Next slide, please. This was the histopathology of my own slides. Here is the sheets, syncytial sheets of the cells and the bordering lymphocytes. Next slide, please. What are the prognostications? This is important for the oncosurgeons here. What is the prognostication for breast cancer? The selecting ER-positive breast cancers for hormonal therapy. ER/PR positive indicates luminal-like breast cancer, which was discussed again by the Bharat sir. And differentiating hyperplastic and neoplastic breast lesions, again ER/PR is important. If you are finding homogeneous ER staining, it favors neoplastic. If it is homogeneous, then again what are the things you are going to see? The columnar cell change, columnar cell hyperplasia flat, with ATPR, atypical ductal carcinoma in situ. They all comes in the neoplastic elements. If you are finding heterogeneous ER staining, then it becomes a normal breast epithelium, usual ductal hyperplasia, florid epithelial hyperplasia. Androgen receptors can be used to demonstrate the epicorine differentiation, usually with co-expression of the GCD. This is the GCD FP15, gross cystic disease fluid protein 15. There are many other uses of ER/PR, which includes assessment of the metastatic carcinomas and some of the gynecological lesions. Next slide, please. How do you interpret the hormone receptors? Estrogen, progesterone, and androgen receptors of the nuclear stains. Interpretation of the ER and PR are outlined by ASCO and CAP guidelines on the estrogen and progesterone receptor testing in the breast cancer. This is the latest journal which gives which gives the correct idea about how to do the interpretation of the hormone receptors. This staining is considered positive regardless of the intensity. Whatever intensity it could be, if it is positive, then it is positive. Reported as percentage of the tumor nuclei, which is starting from 0 to 100%. 1 to 100 is considered as positive. Less than 1% staining is considered as negative. Then you have a ER low positive category could be 1 to 10% introduced in the latest ASCO and CAP guidelines, which can have, again, impact on their chemotherapy and radiotherapy. Next slide, please. The other scoring system, as per the Ann and Cole 2013 article, Allred scoring system, which is the summation of A, that is the proportion, and B, which is the intensity, which proportion ranges from the 0 to 5 based on the amount of cells which are showing the expression. Intensity, whether it could be weak, negative, weak, moderate, or strong. The scores are 0 and 2 are interpreted as negative. Scores 3 to 8 are interpreted as positive. Next slide, please. There's one more type of scoring that is called as H scoring. The score of the 0 to 300 from the multiplying proportion of the S percentage 0 to 100 and intensity 0 to 3 for ER positive tumors. Percentage of the tumor cells with the weak staining into 1 plus percentage of the tumor cells with the moderate staining into 2 plus the percentage of the tumor cells with the strong staining into 3. Then finally you are going to get the final score. There are pitfalls in the ER and PR assessment which is very common and should be avoided, and here is the reference how we can avoid the pitfalls. The positive staining in non-neoplastic or in trapped breast tissue and the proliferative lesions and in in-situ lesions should be excluded. How are you going to do this? Then you need to have HPR, HND stain sections of the same site along with the immunostaining with you, so that you should not be missing the normal elements as should not be then counted as positive. ER and PR antigenicities are very sensitive to tissue processing. Before that, there is a prolonged cold ischemia time can decrease ER and PR expression. They ensure that cold ischemic time is less than 1 hour. So please make sure that you put your specimen immediately into the formalin. Do not delay putting the for fixation. As delay in the fixation can have a lot of effect on tumor cells. Total fixation time should not be less than 6. It should not be more than 72 hours. Then ER and PR antigenicity are also sensitive to tissue processing, fixation and fixation protocol and as well as decalcification. Every care must be taken during processing, staining, everything, including from the cold ischemic time. Next slide, please. Here are the few slides, my own slide. They are the HER2 new. Look at the intensity, it is high, as well as proportion is 100%. And you are also having the ER positive, though here every cell was stained, but the intensity was very weak. Here intensity was high, but the number of nuclei stained are less. Next slide. What is Ki67? It's a nuclear stain. Cytoplasmic stain is disregarded, only the nuclear stain. Ki nuclear expression is proportional to the mitotic count but reveals more proliferating tumor than the latter. Why? This is very important here when with reference to Bloom-Richardson grading system, where the third parameter where we are discussed as the mitotic activity. Mitotic activity, what we will see in the microscope, may be counted as 4 to 5 mitosis per 10 high power field, or then you are not actually accurate there. Their Ki67 index will tell you, even if they are not projected as mitotic activity in HND section, whether they are proliferating or not proliferating. Less than 30 is having good prognosis, more than 30% is having bad prognosis. Percentage of positive tumors is usually calculated in hotspot region with highest staining. It distinguishes the benign from non-neoplastic, malignant from neoplastic lesions. Invasive breast carcinoma component of the grading, in addition to the tubule formation and nuclear pleomorphism, which I have discussed along with the Bloom-Richardson's grading system. This was the article from where I have taken this. So it is also important, Ki67 indexing is important to differentiate the benign, borderline and malignant fillets, whether it is low grade or high grade. This is only you go with the Ki67 with the fillets tumor, you will come with some conclusion of what is your prognosis of your breast tumor. Next slide, please. This is Ki67, which is showing less than 5% of nuclear staining. Next slide. This is my last slide, where I just want to highlight about some of the molecular genetics, which is, though I am not in touch with the molecular genetics, but I keep teaching to everybody, so I have some knowledge about it. Here are the, this is called as the circus plot, where the DNA rearrangements are mapped. And based on the molecular genetics and mRNA expression, protein expression as a ER, PR and HER2 and Ki67, and based on the morphology, the tumor is divided into luminal type, and here you are having the basal type. Under your luminal type, you may have the low proliferation, you may have the high proliferation. Based on this, you decide whether this tumor is behaving normal, behaving good with the good prognosis, having bad prognosis. There are more, here the pink indicates there is just one gene rearrangement. But here you are having this green loops shows that interchromosomal rearrangement, and this pink are here displayed as intrachromosomal rearrangements of the genes. Along with that, here in this mRNA expression, and this is the red color indicates that increase in the expression levels, green color indicates that decrease in the expressions, red color indicates there is no change in the presentation of this mRNA. Either it can be a HER2, this area is representing the HER2, it can be a proliferating gene here, and here is the ER regulated genes. When it comes to triple negative cancers, look at the ER regulated genes are less expressed. They are less in expression, but when it comes to proliferation, it's more here. And when it comes to morphology, it is highly pleomorphic, and the basal keratin becomes positive. Look at the type of rearrangements here. There are multiple DNA rearrangements. This makes the tumor insensitive to human radiotherapy. This becomes a very challenging tumors. Compared to this type of a tumor, you have more ER-regulated genes. HER2 oncogenes are to some extent expressed. You are not finding much of proliferating genes, and there is nicely ER-positively stained nuclei. And look at the nice tubule formations here. Compared to this, where you have a more proliferation, case 67 is almost 100%, you have a lot of pleomorphism, there is a lot of DNA rearrangements. This makes, even though it is a luminal cancers. Thank you so much.
Thank you, madam, for your nice presentation. And we, as you all know, we all surgeons are very much dependent on the pathologist for our diagnosis. And thank you for your elaborative cases. And various cases you have presented, notable was filariasis. And my question was, what was the suspicion which made you to go for biopsy?
It was not a biopsy, sir. The picture were of FNSs only.
Okay.
We did not go with the biopsy. It was not operated, just treated with the DC, and patient went back.
Okay, congratulations. Then you have got a very nice diagnosis of microfilariasis.
Yes, thank you,
sir. Thank you, Zinat, for this wonderful presentation. Socially speaking, if you think of cancer breast and cancer cervix are the two important leading causes of death in the woman. And now cancer breast has emerged as the most important cause of death. I must congratulate the organizers for sensitizing the audience about the importance of breast screening, breast diagnosis and management. And most importantly, as rightly pointed by Dr. Karbari sir, I would like to quote an example wherein a close friend of mine was brought in with some enlargement and was diagnosed as mastitis, and COVID came. Within 6 months, she had a stage 2 carcinoma breast. So this is the significance and importance of timely diagnosing the lesion, the pathology, and it is beyond doubt, in spite of what radiologists say, the pathologist's rule. So your word goes for all the management, care, treatment, and all the talks which are hereupon based on is what report you give. And congratulations for elaborating all the topics so very well, especially the grading, the numbering, the numerological scoring, and all the various pathological and histopathological findings. And most importantly, not only the diagnostic, therapeutic, and the prognosis is all dependent on what the pathologists do and say. So you keep to rule here. Congratulations.
Thank you, sir.
Since we are getting late for the inauguration, I feel if at all if I have questions, please contact Zinat madam during lunch hours.
Thank you so much. Thank you.
Thank you, Dr. Zinat Begum ma'am, for enlightening us with your wisdom.
May I now request Dr. Nandakishore Shinde sir, Professor, Department of General Surgery, to felicitate Dr. Zinat Begum ma'am.
I request Nandakishore sir to felicitate our chairpersons.
Dr. Vinod Uplonkan sir.
Dr. Srinivas K sir.
Dr. Girish Yasnula, sir.
Dr. S.S. Karbari, sir.
Dr. Rajshri Paladi, ma'am.
Thank you so much, Nandakishore, sir. Now I request Dr. Afia ma'am, second year postgraduate, Department of General Surgery.
Dr. Aisha, ma'am, first year postgraduate, Department of General Surgery, to continue with inauguration ceremony. Thank you.
A very good morning to one and all present here. Firstly, I welcome you all on behalf of our entire Department of General Surgery, KBN Hospital Faculty of Medical Sciences, Kalaburagi. We are more than delighted to host the CME on breast diseases. This continued medical education is a convergence point for all trailblazing ideas and transformative insights to maintain competence and stay updated. With immense pleasure, I open the CME to our collective commitment towards medical excellence. Now I would like to call upon our dignitaries to the dais and occupy their respective seats. Under the blessings of our patron, His Holiness Dr. Syed Shah Husru Hussaini Sahib, Sajjada Nasheen Dargah, Hazrat Khaja Bandanawaz, His Excellency Chancellor at Khaja Bandanawaz University and President at Khaja Education Society, I invite our guests of honor, Janab Syed Muhammad Ali Al Hussaini Sahib, Honorable Pro-Chancellor, KBN University and Vice President of Khaja Education Society. Now I would like to call upon Professor Al-Raza Muswi, sir, Honorable Vice Chancellor, Khaja Bandanawaz University, to the dais. We are honored by your presence, sir. Now I would like to invite Dr. Rajshekhar Patil, sir, ASI President and Professor in Department of General Surgery, MR Medical College, Kalaburagi, to the dais. We are pleased to have you, sir. Now I would like to invite our beloved CEO, Nadoja, Dr. P.S. Shankar, sir, Emeritus Professor of Medicine in Rajiv Gandhi University of Health and Sciences, KBN University, Kalaburagi. We are pleased to have you, sir. Yes, sir. Now I would like to call upon our most honorable personality, Dr. Siddesh Sirwar, sir, Dean of Khaja Bandanawaz University, Faculty of Medical Sciences. Thank you. Now I would like to invite our beloved Medical Superintendent, Dr. Sidling Chenty, sir, to grace the dais with his presence. Now I would like to call upon Dr. Sunil Deshmukh, sir, KMC Observer, to take his seat on the dais. Thank you for your presence, sir. Now I would like to invite our most dynamic personality, Dr. Muhammad Muinuddin, sir, Professor and HOD of Department of General Surgery, KBN Hospital, Faculty of Medical Sciences, to occupy his seat. And lastly, our prize possession, Dr. Nandkishore Shinde, sir, Pediatric Surgeon, Faculty of Medical Sciences, KBN University, Kalaburagi, to occupy his seat on the dais. Thank you, sirs. Now we are going to start our inauguration ceremony with the recitation of Khirat by Dr. Nabil Afnan.
Assalamu alaikum wa rahmatullahi wa barakatuh. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم سبح اسم ربك الأعلى الذي خلق فسوى والذي قدر فهدى والذي أخرج المرعى فجعله غشاء نحوا سنقرئك فلا يسعى إلا ما شاء الله إنه يعلم الجهر وما يغشى ونيسرك لليسرى فذكر إن نفعت الذكرى سيذكر من يشفقا ويتجنبها الأشقى الذي يصلى النار الكبرى ثم لا يموت فيها ولا يحيا قد أفلح من تزكى وذكر اسم ربه فصلى بل يعطرون الحياة الدنيا والآخرة خير أبقى إن هذا لفي الصحف الأولى صحف إبراهيم وموسى بسم الله الرحمن الرحيم. Glorify the name of your Lord, the Most High, who has created everything and then proportioned it, and who has measured proportionates of each and everything, even to be blessed or wretched, then guided, that is, showed mankind the right as well as the wrong path, and guided the animals to pasture, and who brings out the pasture and makes it dark stubble. We shall make you to recite, so you shall not forget, O Muhammad, and we shall make you easy for you the easy way, that is, the doing of righteous deed. Indeed, whosoever purifies himself and remembers the name of his Lord and worships him and praise him and neither prefer this world than the hereafter, which is better and more lasting, shall achieve success. Verily, this is in the former scriptures, that is, the scriptures of Abraham and Musa, the Moses. Jazakallahu khair.
Thank you, Nabil, for reciting such beautiful khirat. Now I would like to invite all the dignitaries present on the stage to come forward and inaugurate the CME program by watering the flower pot. Thank you, sirs. Now I would like to call upon our beloved HOD, Dr. Mohammad Moinuddin sir, to speak a few words and enlighten us regarding this CME.
Good afternoon, everybody. Respected Vice Chancellor sir, Professor Shankar sir, Senior Chief Secretary, Dean Dr. Siddesh, Medical Superintendent Dr. Chengte, ASI President Dr. Rashekar Patil, KMC Observer, Dr. Deshmukh, Organizing Secretary for the program, Dr. Nankishore, all the HODs who are present, Dean of Research, Dr. Rashi Paladi, Fraternity of Surgical Society of Gulbarga, all the surgeons from 4 medical colleges of Gulbarga, senior surgeons practicing in the city, faculty of KBN University, faculty of medical sciences from all disciplines, 21 disciplines of the college, and my dear students. Under the guidance of our patron, His Holiness Dr. Sayyid Shah Khusro Hossaini Sahab, and our beloved guest of honor who was supposed to be here, Dr. Janab Muhammad Al Hussaini Sahab, and Director of the University, Dr. Sayyid Mustafa Ali Hussaini Sahab. They couldn't be present today because of some engagements. I would like to start my welcome speech by reading out a message which has been given by our President and Honorable Patron, His Holiness Dr. Sayyid Shah Khusro Hossaini Sahab, with the permission of the Vice Chancellor. Please. It is addressed to the organizing chairman, Dr. Muhammad Moinuddin. Subject, inaugural function of CME on breast diseases update on 19 January 2024. Dear Dr. Moinuddin, I thank you for inviting me for the inaugural function. Due to my health issues, I will not be able to attend the inauguration. I, however, wish all the success for the CME. Thanking you with kind regards, yours truly, signed Dr. Sayyid Shah Khusro Hossaini, Chancellor, Khaja Bandanawaz University. We feel honored and we gratefully accept his message and thank him for the wonderful message at the outset. Similarly, at 3 a.m., Dr. Ali Al Hussaini, the Pro-Chancellor, messaged me on WhatsApp and told Dr. Moinuddin, because of my engagement late in the night, I won't be able to come to the function today, but I congratulate you all and wish you a grand success for the function. And all the organizing people, the efforts they have made, I really compliment them. So this was the message from Vice President Sir on WhatsApp. Sir, we thank you for your excellent message. Now coming to the proceedings of the morning, I welcome you all for this CME. This was done in a very short span of time. And when we started organizing this CME on 6th, we never knew that there will be a spate of holidays on 13, 14, 15, 16. So we had a very small time to communicate with all the peoples. Nonetheless, the organizing committee, Dr. Devni, our organizing secretary, Bashir, all my colleagues worked hard, and we could get a record 310 registrations. All this was the inspiration given by our Vice Chancellor, sir, when he came for the ENT CME. He said, Doctor, we need to do a CME before 31st of March so that it goes into the account of this year. So we took a leave from that and we started working on it, and today we are here. I'm very happy to welcome you all for this CME. The 2-3 lectures we had in the morning session before this inauguration were, I must appreciate, were of a very high quality. All my colleagues will vouch when they come for the panel discussion later on. Department of Surgery has been making healthy strides in the KBN Institute of Medical Sciences, which was formerly now Faculty of Medical Sciences, in the sense that since we have embarked on the postgraduate program in 2015, we have been participating at national and international levels in paper presentation and competitions or poster competitions. From 2017 onwards, for 5 consecutive years, our PG students bagged prizes, first, second in posters and paper presentations consecutively for 5 years. I think the guidance from Professor Shankar Patil, he used to review all the papers before they sent the abstract to the conferences, make them read, reread, present, represent, and then at conference in 2019 in Chennai, when the first and second paper presentation, scientific paper presentation went to KBN, all the national delegates were asking, where is this college? That was the first time our people got this prize. First and second, both were backed by our students in KBN Medical College. And then they wrote a letter to the professor in HO department, Dr. Devani, that time. Sir, yours is such a new college, and both the first prize at national level were won by your students in 2019. From the, this was a landmark achievement. We were also, you see, stunned by this performance. Our college was put on the national map. Then, from there onwards, we took the cue, and then we modified everything, slide presentation, how the slides should be presented, the methodology, how dress rehearsal in front of mirror, everything, training was going on in the Department of Surgery. And we are now happy to tell you that 5 consecutive years we have been bagging one prize or the other at national as well as state conferences. Second thing which we do in the Department of Surgery is there is a 6 days teaching program per week. This is, I think, a very phenomenal thing or a consistent thing. 5 days we have for the PG students, 1 day we have for the interns, and all our teachers take part. So I am very grateful. I will not find another occasion to thank them for their perseverance, hard work which we are doing in the department despite their busy schedule, other teaching, undergraduate, etc. KBN Institute of Medical Sciences is now embarking on a new era with the development of hospital in the new section, that is the new casualty, new emergency wing, 62-bedded ICU with latest equipments like you see the FNAC and 160 slice CT, which is the best in North Karnataka, where we can do non-invasive coronary angiography, is already functional. And I want to inform all my colleagues from other disciplines, other medical colleges, to make use, elaborate use of this equipment which is present in Gulbarga. Other development of the college is taking place, and with the help of our dynamic Vice Chancellor, we are embarking in a new era of technical excellence, academic excellence, and infrastructure development of both college and hospital, and on the whole as a university as such. This CME is one of the representative or small sample of what is going on in KBN Institute of Medical Sciences. On this occasion, we have also taken liberty, and we have taken permission from Vice Chancellor Sir to honor few of the senior surgeons of the Gulbarga who have given relentless service in this area to the people of North Karnataka. So once again, I thank one and all. It will not be possible for me to take names of everyone who has worked hard for this CME because of the constraint of time, but your presence is a boost and encouragement for us, and I wish that further CMEs which are going to happen in medicine and other disciplines also will have such presence and austerity and grandeur. One more thing I would like to tell you, that we can do a CME in a very economical side of budgets, like we can cut the cost on brochures. So you might have seen, we have printed a simple paper brochure on color paper, simple paper with color printing. So that has reduced the cost. We have also cut out on the cost of flowers, etc., because this hall is a very beautifully decorated hall. We felt that there was no need for making it more beautiful. So this is the way. But we have not cut the expenditure on other things like food and grandeur, so that the dignity, austerity, and grandeur of CME is maintained. So welcome to the academic feast, whole day long, and thank you for participation and contribution. Thank you one and all. Thank particularly Vice Chancellor Sir, who is very busy, but she has taken out time to come over here and grace the occasion. Thank you, sir.
Thank you, sir, for such motivation.
A true surgeon is never fearless. They are marked by intelligence, perseverance, professionalism, courage, and creativity. Now we are going to felicitate our senior-most surgeons who are amongst the most famous surgeons from city of Gulbarga. I would like to invite Dr. Kishore Mankar sir, Dr. Sharan Basappa Harwal sir, and Dr. Aslam Syed sir to occupy their seats on the dais, please. We are honored by your presence, sir. We are pleased to have you, sir. Dr. Sharan Basappa R. Halwar, sir was born on 22nd March in the year 1958 in the city of Kalaburagi. He received his primary and secondary education from Sharan Basaveshwar Institute, Kalaburagi. He completed his MBBS and MS General Surgery from MR Medical College, Kalaburagi. He completed his MCH in Pediatric Surgery from Graduate Medical Education and Research, Chandigarh. He is currently the Vice President of Hyderabad Karnataka Education Society. Sir worked in MR Medical College from the year 1990 to 2019. He went from the rank of being appointed as a lecturer to an assistant professor, then associate professor, and became a professor in the year 2001. He worked as a medical superintendent of Basaveshwar Teaching and General Hospital, Kalaburagi from the year 2013 to 2017. Sir was appointed as the vice principal from the year 2013 to 2017 and then as principal and dean of MR Medical College from the year 2017 to the year 2019. Sir was elected as the president of Indian Medical Association of Gulbarga branch in the year 1998. He was elected as the chairman of Indian Association of Pediatric Surgeons, Karnataka branch in the year 2009 up till the year 2011, and then as executive committee member of Indian Association of Pediatric Surgeons in the year 2005. He was elected as the executive committee member of Indian Association of Karnataka State Chapter of Surgeons of India in the year 2010. Sir has been a life member of Association of Surgeons of India, Association of Trauma Care in India, Indian Association of Pediatric Surgeons, Indian Medical Association. Sir has been awarded with lots of district and state level organizations for the professional as well as social service he has provided. He has conducted numerous congenital anomalies correction procedures, CMEs, workshops, both at district level as well as state level, national and international level conferences. Sir has conducted and participated in innumerable number of health checkup camps and educational camps. Sir has done publications on congenital anomalies, corrections in neonates in Focus Journal of Indian Medical Association and presentation on hydatitis in various parts of body in children in the city of Mumbai. Above all, Sir is a well-known and renowned pediatric surgeon in Kalyan, Karnataka region. He is ever-striking, simple living, well-versed with administrative skills, effective communication and leadership qualities with lots of social responsibilities. Sir always lends a helping hand to all the poor and needy people in all fields, especially in the field of health and education. Dr. Kishore Mankar Sir. Sir was born in the year 1959 on 24th of March, and his childhood and schooling has been done in the city of Dharwad. He has done his MBBS and MS General Surgery from KIMS Hubli between the year 1976 to 1985. Immediately joined government service at the Shorapur Taluka, Gulbarga district. He has worked as a medical officer in a primary health center, Taluka General Hospital, Leprosy Center at Shorapur, and as a Taluka health officer. He has also served for a short period at the General Hospital, Sandur district in Bellary. Credited for having more than 60,000 laparoscopic sterilizations, transferred to District Hospital Gulbarga in the year 2000 and took voluntary retirement in the year 2000. Joined KBN Medical College as assistant professor in the year 2007 and got relieved as professor in the year 2021. After retirement from government service, Sir has started his own simple specialty hospital, Sri Renuka Hospital in Kalaburagi in the year 2007, which is still functional. Now Sir's family is settled in Hyderabad. His daughter is working as an assistant professor in Department of Physiology. She is happily married to an intensivist, and both of them are working at the Mallareddy Medical College, Hyderabad, and they have 2 children. He also has a son who has done his second year in MD Anesthesiology and is working at Mallareddy Medical College, Hyderabad. Sir has started a new venture at Medchar, Hyderabad in the year 2023. Samprada Hospital, a multi-speciality hospital which is being managed by his children. And also his son-in-law and a group of like-minded consultants. Future plan of Sir is to take a break after having served for a long time and to lead a peaceful, settled life in the city of Hyderabad. Dr. Aslam Said Sir. Sir was born at Sagar Taluk in Shapur district, Yadgir. He's been in Kalaburagi since childhood. Sir has completed his MBBS from MR Medical College, Kalaburagi. Then his senior residency also from MR Medical College in the year 1974. Later he started practicing at the Rosa Gulbarga in 1980. Sir also has worked in Central Jail as a medical officer for a period of 2 years. Later joined as a medical officer in Government Gulbarga Hospital in 1984. Sir joined for post-graduation MS General Surgery in Mysore Medical College as an in-service candidate and completed it in the year 1992. Sir joined as a junior specialist in Gulbarga Government Hospital and got retired as a senior specialist from the same hospital in the year 2006. Later, Sir joined as an assistant professor in the Department of General Surgery in Al-Badr Rural Dental College and got retired in the year 2018, after which Sir has his own small facility that is a 10-bedded nursing home which is being handled with, along with his wife, Dr. Jamila Aslam. Sir has 3 children, 2 sons and 1 daughter, eldest being an engineer at the Square Enterprises, and second son working as a laparoscopic surgeon in Kenya since past 7 years, and his daughter is a computer engineer. Sir's inspiring words or the daily mantra is to be happy, to keep others happy, to go on working till last breath. I would now like to call upon our beloved Vice Chancellor, Professor Ali Raza Muswi Sir, our beloved Dean, Dr. Siddesh Sirwas Sir, our beloved Medical Superintendent, Dr. Sidling Chengti Sir, to facilitate our chief guest for the day. Thank you, sir. I now request all the dignitaries on the dais to grab a quick tea break while we continue our next session as we are short of time. I would like to invite our beloved Vice Chancellor, Professor Ali Raza Muswi Sir, to address the gathering further.
Very good afternoon to all of you. The Dean, Faculty of Medical Sciences, the Medical Superintendent, Dr. Rajshekhar from the Association of Surgeons, the Head Department of Surgery, the doctors whom we just honored for their long services, members of the audience, students, ladies and gentlemen. I would like to begin with an apology that this should have taken place at 11 o'clock, but the entire university is so caught up in various other activities, equally important activities, that our time schedules have been very stressed and very tight, and that's the reason why I must first thank Dr. Moinuddin for accepting my request and delaying this inauguration. I'm also aware that I stand between you and a hot cup of tea, so I'll not take much time. It would not be very wise for me to go on for a long time now. From my standpoint of my academic field, which is geography and economics, we have a very strong interface with disease, the concept of wellness and health. I recall seeing some statistics which I pulled up today morning, is that from 1998 to 2009, the total number of cancers, especially breast cancers, among the women was at 30%. And from 2009 till 2019, it has gone up to 37%. As social scientists, we are trained to look at possible causes and reasons for this. I think we should all agree that cancer by itself has become a lifestyle disease. Because when you plot the number of cases which are happening in India, we find they are maximum in 5 metro places in India. That is Bangalore, Bhopal, Delhi, Bombay and Chennai. These 5 places report the highest number of breast cancers in India. Now there can be 2 reasons. One is that all 5 are big metropolitan cities and they have more screening there. It's less in rural areas. But the statistics show that breast cancer has become a lifestyle disease, and especially in urban areas. We can also correlate hypertension, blood pressure, heart stroke, all these which were diseases which used to strike a few people, and all these have become common. The second thing is that the age, especially among the Indian females and the women, 35 to 45 has become the most common age for these cancers. In the West and especially in the world, the average age is 47 years when the first stage is normally screened and found out. We all know that the prognosis for the first stage is very good, it's 92%. But as the stages swiftly go forward, then it becomes less and less treatable. Now, all of you are surgeons, but whereas people like us also try to think that surgeries, of course, when it has been detected, there's no other option and it has to be cured. It has to be radical, it has to be removable, it has to be something which is violent towards the body, but it has to be done for safety. But I thought because this was on awareness, I think that it's about time that we were made more aware that what are the lifestyle choices which we are taking as a people, as human beings, which is making us more and more prone to such diseases. Many studies have established that the excessive use of microwaves, which releases free radicals, is causing carcinomas and cancers. Now this is all general education. I am not speaking as a specialist, and if anything I say is incorrect, factually incorrect, then of course I will stand corrected. I think that the awareness, what we shall do, and I am very happy that you are doing this, because screening is very good, I think, because the world, what should be done is that every 2 years, apparently, from the age of 35, we have to undergo this breast screening so that it can be caught at an early stage. That's fine. But along with screening, should we also not, as an institution, as part of our social engagement, also spread awareness as to what are the lifestyle concerns which can be corrected, so that we can perhaps avoid this modern triad, that is cancer, be it among males or females, hypertension and heart disease. This is a triad. This is a triad which has come, which has a very strong statistical link with modern living and growth. This is not a critique of modernity This is not a critique of technological application in our lives, and it is certainly not a critique that medicine is of no use, because at the end of the day, if we live a certain lifestyle, we are going to end up like that. That's not, these are very deep anthropological and sociological questions, and this might not be the correct, I am certainly not the correct expert, and this is not the correct audience for me to speak on these lines. But since we are now a university, and when we are in the universe of knowledge is all interconnected, I would like to encourage that such awareness camps, apart from their clinical parts, apart from their diagnostic parts, perhaps should also have a component where we take into account the larger sociological and economic contours of a disease and try to find out, because there are specific markers. I also learned that there are no specific biomarkers as far as Indian females are concerned. I mean, they are in the process of being standardized. As a university, I would be very happy if we can take up some research on these lines, where we try to develop standardized biomarkers as far as the Indian women are concerned, because there is a background, a culture, a lifestyle, food habits, climate, all these things go in making a human body. So I think that is also a very important thing that we should focus on. With these few thoughts which I thought I'll share with you, I would like to end my brief address here. I would again like to thank the organizers for giving me this opportunity. I again apologize that we were late because of my non-punctual appearance here, and I again thank all of you, and I wish all of you a very successful outcome, and I would like to receive the papers which can be consolidated into a volume which can be issued as part of the proceedings of the CME. Thank you so much.
With your permission, sir, our one of the surgeons, Dr. Karbari, has been selected at the state level. So we would like to call him and present our memento to him. Dr. Karbari, SS, MR Medical College, urologist.
Thank you, sir. Now I would like to invite Dr. Mohammad Moinuddin, sir, to felicitate our guest present on the dais.
Association of Surgeons of India, Kalaburagi chapter.
May I now request chairperson of this section to please come over the dais and take their seats.
Dr. V.S. Kappikeri Sir, Professor, MRMC Gulbarga.
Dr. Mahmood Ali Sir, Associate Professor, JIMS Gulbarga.
Dr. Chandrakala Ma'am, Professor and HOD, Department of General Surgery, KBN University, FOMS.
Dr. Mandakini Ma'am, Professor and HOD, Department of Pathology, KBN FOMS. Professor JIMS Gulbarga.
Dr. Chandrakala Ma'am, Professor and HOD, Department of General Medicine. On this great session, we are indeed fortunate to have with us a befitting personality, Dr. Sharanbasappa Hatti, Onco-Surgeon, SCG Hospital, Kalaburagi. Sir is the chief speaker of this session to speak on breast cancer management. We welcome you, sir. Session, we are indeed fortunate to have with us a befitting personality, Dr. Sharanbasappa Hatti, Onco-Surgeon, HCG Hospital, Kalaburagi. Sir is the chief speaker of this session to speak on breast cancer management.
Has completed MBBS from MRMC Gulbarga. Sir has completed DNB General Surgery in Bengaluru and DNB Surgical Oncology from AFMC, Pune.
Sir is the first oncologist to start practicing in Kalyana, Karnataka region. Sir has got 17 years of experience in oncology department. Sir has operated more than 2,500 major and supra-major surgeries till date. We welcome you, sir.
Good afternoon, everybody. Can you just start the presentation, please? Yeah, meanwhile, at the outset, I would like to congratulate the KBN management and whole of the team responsible for organizing this excellent CME program today, especially on breast cancer, or breast diseases rather. So there is a one-liner in Sanskrit like Nari Samajasya Kushala Vastukaras. That means woman is the most skilled architect of the society. Can you just slow down this volume, please? Little bit. So, woman being most skilled architect of the society, her health has to be of utmost importance. It's a very bad situation that most common cancer, or rather top two common cancers, belong to the woman, and quite neglected part. Just talking about management of the breast cancer, it's a very vast topic. I have kept it very precise. Oh, there was a photograph in that staging. Okay, next slide. Next, yeah. Can you be a little slow, please? Yeah. So management is mainly based on the clinical extent or stage of the disease. And nodal status, pathological characteristic of tumor. As Zeenat ma'am gave a very comprehensive talk on the pathology, and receptor status, hormone receptor status, age of the patient, especially considering the menstruation in point of view, like most postmenopausal or premenopausal. And definitely last but not the least is individual patient preference, keeping in mind the oncological principles. Not like we have to obey whatever patient says, but whenever it is possible and there are two options, we go for patient's preference. Next slide. Sure. Yeah, the main treatment options are local therapy and systemic therapy. Nowadays, the breast cancer is called as a systemic disease rather. So local therapy is mainly by surgery and radiotherapy, which intends to control the primary lesion and the axilla. And systemic therapy is given mainly by chemotherapy and hormonal therapy and the targeted therapy. Next slide. Just an overview of treatment especially for the early breast cancer. Breast conservation therapy whenever possible and whenever opted for, which includes surgery and radiotherapy. It's not plus or minus, it is plus radiotherapy. It has to be with radiation. And based on the histopathology, chemotherapy and targeted therapy and hormonal therapy may be added. Or the mastectomy, where I am talking only about the primary, so total mastectomy, with or without radiation, chemo, and hormonal therapy based on the histopathology. Next slide. So when we are talking about surgery, we are talking about primary tumor and the axilla. So talking about primary tumor, next slide. We have mainly two basic procedures. One is complete local excision, where we conserve the breast, and second is mastectomy, where we remove the total breast. Next slide. So where we conserve, it's called breast conserving surgery, which includes complete local excision and axillary dissection or sentinel lymph node biopsy. So the main aim of BCS, breast conserving surgery or breast conserving therapy, is to improve the quality of life, because losing an organ would hamper psychologically and socially, so without compromising the oncological outcome. So breast conserving surgery, it demands complete local excision, and which means clear histological margins, normal tissue margin with a rim of normal breast tissue around the periphery of the primary tumor on all the sides. So it used to be wide excision of lump or a quadrantectomy used to be. Next slide. So this slide shows like how the breast conservation surgery used to be previously, like just taking out the tumor with a wide margin, or sometimes quadrantectomy. That quadrant of the breast used to be removed, and the cavity used to left alone for healing by itself by fibrosis. This was the old practice. So now today's practice is, next slide, is the oncoplastic breast surgery. It's an approach to allow wide excision, like wider excision, where we don't have to think about the distortion of the breast or anything. So based how much our lump might be, we can go with a wide excision for breast conservation surgery without compromising the natural shape of the breast. That's very important. Or the oncological safety, and is based upon integration of plastic surgery techniques. Next slide. So we have various types of oncoplastic surgeries. Basically, if we divide them broadly, it will be volume displacement and volume replacement. Volume displacement is where the primary breast tissue itself is rotated, or along with the overlying skin also. It may be simple or complex. Simple, where only 20% of the breast tissue is removed, volume loss, or 20 to 50% volume loss. Wherein, like, rearrange of breast tissue by bringing local dermoglandular flaps into the defect. There was a photograph here, it's missing. So volume replacement, wherein large, like more than 50% of breast tissue is lost, maybe plus or minus along with the overlying skin. In such cases, we need a pedicle flaps along with the skin. Like most commonly used one is latissimus dorsi flap. Next slide. These are few photographs which oncoplastic surgery that I have conducted in our hospital. This is the most common one, donut mastoplasty, wherein we remove a rim of donut de-epithelialize around the areola. You can see that where the tumor is. There is no incision directly on the tumor. Next slide. So, and then we are lifting the flap, only the over the tumor, like lower end. Next slide. Next slide. Yeah, previous one. Yeah. So this is the specimen size, you can see. It's almost 5 centimeters. It's the same last surgery. Next slide. After that donut deepithelialization, we take a purse string suture. In the last patient, I forgot to take the photograph after during the purse string suture. So this is another patient at the end of the surgery. So purse string suture, and next slide. So this is the previous one surgery that we have shown. The counter is not much distorted. Next slide. This is another commoner thing, batwing mastopexy, wherein we do for little smaller tumors, still smaller tumors. Next slide. So you can see the size of the lesion over there and the defect. Next slide. So in breast conserving surgery, we said margins, like normal tissue margin. How much is the adequate margin? There is previously we used to call it as like 1 centimeter of margin, but now the consensus is that there has to be a negative margin. Doesn't matter how much is the centimeters, because there is no end for taking out how much 1 centimeter or 2 centimeter. So basically the whole specimen is inked, and there should not be any tissue, any tumor tissue at the inked surface. So it has to be just a negative margin. Sometimes, next slide. Sometimes when a lumpectomy is already done, like in such cases, if you want to do a breast conservation surgery, there will be some cases where we need to do a revision excision. So the situations are like when the surgical procedure was less than a complete lumpectomy, that is like if the margins are positive, or if the resection margins are not commented upon on the histopathology report, or if they are positive margin, and any suspicious residual microcalcification or post-lumpectomy mammography. Next slide. So mastectomy, mastectomy, Dr. Gurraj is going to speak, so I have not touched it. Next slide. So definitely the breast conservation surgery or breast conservation therapy rather, not just surgery, matlab BCS, breast conservation surgery plus radiation therapy is definitely equivalent with the total mastectomy and axillary clearance, and accordingly. Next slide. So now coming to management of axilla, the aim is to one is to see if there is any already spread to the axillary nodes for evaluation for the prognostication purpose, and to determine any adjuvant treatment based on the plus or minus involvement of the nodes, and also eradication of disease if it is already spread to axillary nodes. So this includes axillary node dissection and sentinel node lymph node biopsy. Next slide. So we all know about the axillary dissection, like level 1, 2, and 3 based on with respect to the pectoralis minor. Next slide. So sentinel lymph node biopsy, the main principle of sentinel lymph node biopsy is based on the harvesting the first echelon node. It is not about any enlarged node which on preoperatively sonography and doing a FNAC of that. That's not a sentinel node. So it has to be harvested. Like there are two main methods. One is by injection of the radiocolloid into the skin or just in the subareolar plexus about 1 hour before the planned surgery, and injection of a dye, like commonly used methylene blue, isosulfan blue, not very easily available. So just on induction before taking the incision, 5 minutes before taking incision. So, and after a proper massage on the tumor and surrounding this thing, the lymph node is harvested from the small axillary incision, and whatever the nodes had, next slide, whatever nodes had this reading on the radiocolloid machine, handheld machine, which has to give more than 10 times the other breast tissue reading. So such node and the which has got the dye lymph nodes. So such lymph nodes, it's not a one, nowadays it's not a one single lymph node. The whole of that part of the tissue is taken out and sent for frozen section. So if the frozen section is positive, proceed with the complete axillary dissection. If it is negative, then no axillary dissection at all. Nowadays, there are some RCTs which have come up with a conclusion that even with a sentinel node biopsy are positive, and there are only less than or equal to, or one or two, only less than or equal to 2 lymph nodes are positive on sentinel node. Even such cases also, only there have been seen that only those cases are, only those nodes are the positive ones. So in such case, the axillary lymph node dissection was avoided in such patients also. Next slide. So, so overall survival, disease-free survival and regional control were statistically equivalent between groups, in both the groups. When the sentinel lymph node is negative, sentinel lymph node surgery alone with no further axillary dissection is definitely appropriate, safe and effective therapy. That's what. Next slide. Next slide. Coming to hormonal therapy, it has come with a long way now, and it's going to stay forever. Like previously, only the tamoxifen was the drug that was available. That too, it used to work only on the postmenopausal woman. Next slide. So these are the classification of hormonal therapy. The SCRMs, which is tamoxifen, is most common, and third generation aromatase inhibitors, which are more commonly used now, anastrozole and letrozole. Next slide. So patients with ER positive, hormone receptor positive, ER or PR positive, even patients with only PR positive, only progesterone receptor positive and ER negative also are subjected for hormonal therapy. They should receive at least 5 years. And nowadays, the studies have come for 7 years and 10 years also. Next slide. So, and in postmenopausal women, ER positive women, aromatase inhibitors have got upper hand over the tamoxifen. Both are effective, but aromatase inhibitors or anastrozole or letrozole, they reduce the 10 years relative mortality rate is 15% further reduced than the tamoxifen. Next slide. Just, yeah, next slide. Just one slide on the targeted therapy. The trastuzumab is the commonly used one, and lapatinib that we use. Next slide. Yeah, thank you for attention.
Thank you, Dr. Sharan. You have briefly described all the modalities of the treatment for carcinoma of breast, including surgery, chemo, and hormone therapy. Would you like to just brief about what is the role of prophylactic mastectomy in this CA breast?
Prophylactic
treatment
mastectomy
options you are not mentioned, so just I want to ask.
Yes, sir. Prophylactic mastectomy, when we have a proven BRCA positive, BRCA gene positive patients, or subjects rather, not patients. In such patients, there is some role, but nowadays they say like if they can be, because there is no 100% disease occurrence in such patients. So if they are well educated and if they can come for regular follow-up, lifelong is the key. In such patients, we can spare the breast, sir. There is no need for going for surgery for all the patients. But in the same patients, we have to undergo, they have to undergo a oophorectomy, bilateral oophorectomy, because it can't be identified at earlier stages.
Only those are at high risk gene mutation of BRCA.
High risk is like when like it is like asking when to do a BRCA test. when a patient family has got disease, like two first degree relatives have got breast or ovary cancer, two first degree relatives, or the same patient having both bilateral breast cancer, either synchronous or metachronous, and male breast cancer is also a indication for doing a EGFR. Yes, sir. Sorry.
Thank
BRCA.
you. Thank you.
Yes, sir.
Sir, sir, are there any disadvantages of breast conserving surgeries?
No, sir, not at all. There are no disadvantage at all. Like if we have good margin on proper histopathology and the patient takes complete treatment. If the patient don't take radiation, then definitely it is incomplete treatment. If the patient doesn't take adjuvant radiation, then it is incomplete treatment, even if lymph nodes are negative. Otherwise, there is no thing, sir.
I think, sir, there are two sets of females. One set of female is they are worried of their cosmetic look.
Exactly.
Second set of female is
Yes, sir.
they are not worried of their cosmetic look. They want to just get rid of that disease.
Yeah, you are very much right, sir. In our community, like in our region, we have commonly, I come across with the second set of people.
Yes,
like they don't want breast conservation, they just want it to be removed completely. So whenever it is feasible, I counsel them for both, but majority of them, they ask for complete, like modified radical mastectomy only. You
It's
are
very
much
true,
right,
sir.
Yeah, yeah.
So anybody from the audience, if you want any, ask some queries. Dr. Sharan is.
Sir, patients, like sir was asking what measures we can take for counseling for prophylactic mastectomy. Like first thing is we have to identify who are all at the high risk. Like as I said about where all we have to subject for BRCA gene mutation studies, like bilateral breast cancer or two first degree relatives suffering with BRCA associated CA, like ovaries and even prostate and breast cancer in first degree relatives is also a indication for doing a BRCA test, and male breast cancer. Such patients, if they undergo, if they have gene mutation positive, BRCA positive 1 or 2, both, any of them, if they are positive, it is preferably better to get it done, sir. Like though the study says that we can keep them on observation, but lifelong surveillance is very difficult. So it is better to take out both the ovaries and breast. Yes. Yeah, first part of the question, like how much breast has to be removed, it is like taking a rim of normal tissue. There is no like this much breast tissue has to be removed, nothing like that. Only a rim of normal tissue has to be removed with the tumor. There has to be like once the tumor is out, histopathologists, they apply ink all over the surface, and while they study the slides, they should not see any tumor cells inked with the blue ink. There should not be any tumor cell. Single tumor cell is also there, then it is inadequate, even if we have taken how much ever breast tissue. And second part is like yeah, it definitely the relative contraindication that we say, like when the tumor is large and breast size is small, in such cases it is difficult to do. We can't like we'll have to replace it completely with the flaps.
Here in Gulbarga, according to in your practice so far, any BRCA positive patients who have not yet developed breast cancer you have encountered, and what are the options you have given them, and what are the preferred options in the population of Gulbarga? Any BRCA positive patients for prevention, what they have preferred?
Actually, I have not come across any BRCA positive. As I said, like if at all I come across with any BRCA positive, I would not put them on surveillance. I would ask for prophylactic method.
Young patient, less than 40 years, less than 30 years, getting breast cancer, do you routinely advise genetic counseling?
Yeah, we definitely advise.
But do they follow it, sir?
Only few patients have followed. Like only educated people they can follow, who they understands. Like otherwise, village people they say like when happens we will see.
Can you throw some light on the use of Herceptin?
It's definitely like even now it is in neoadjuvant also, madam. Whenever Herceptin is positive, especially both even like ERPR negative and Herceptin positive, such cases we give as a routine we give neoadjuvant chemotherapy and adjuvant also. And the cost is also quite significantly low now. It's quite affordable.
So any other questions? So thank you, Dr. Sharan.
Okay, sir.
I thank all the audience for their active interaction with Dr. Sharan.
Thank you, sir, for sharing your valuable time and information. May I now request Dr. Devni sir to felicitate to Dr. Sharan Basappa Hatti sir. May I now request Dr. Devni sir to felicitate our chairpersons.
Dr. V.S. Kappikeri sir, Professor, Department of General Surgery, MRMC Gulbarga.
Dr. Mahmood Ali sir, Associate Professor, Jims, Gulbarga.
Dr. Chandrakala ma'am, Professor and HOD, Department of General Medicine, KBNU University.
Dr. Mandakini ma'am, Professor and HOD, Department of Pathology, KBN FOMS.
I would like to request chairpersons to please come over the dais and take their seats.
We welcome Dr. Raj Sekhar Patil sir, Professor, Department of Surgery, MRMC.
Dr. Shanta Patil ma'am, Professor, MRMC Gulbarga.
Dr. Charan Raj sir, Associate Professor and HOD, Department of Pediatrics and KBNU.
Dr. Vardhamane sir, Professor and HOD, Department of Pharmacology, KBN University. It's an immense honor to be graced by the great eminence Dr. Shantling Nigungi sir, Clinical Oncologist, Medical Director, HCG Gulbarga. Now I request sir to address on chemotherapy and radiotherapy in carcinoma breast. We welcome you, sir.
Dr. Shantling Nigudge sir is an alumni of MRMC and sir has 12-year experience in oncology.
Sir has done his postgraduate in radiation oncologist from KMC Udupi, Manipal University.
And fellowship from Memorial Sloan Kettering Cancer Center, New York, USA.
A certified medical oncologist from European Society of Medical Oncology, sir has 4 years of experience in Apollo Cancer Center, Hyderabad, and 9 years in HCG as medical head and senior consultant oncologist.
Good afternoon, everybody. At the outset, I thank organizing team for giving us the opportunity for today's talk. And special thanks to Dr. Moinuddin sir for giving this topic for today's CME. Actually, it's chemotherapy and radiation, each itself takes a lot of time, but I'll try to do justice for the topic. Not this one. Yeah, next slide. So basically, cancer management is a multidisciplinary team wherein, slide change. Okay. So it's basically multidisciplinary team wherein surgeon, medical oncologist and a radiation oncologist has to decide the path of the treatment for a patient, particular patient. It's not all patients are same because each patient responds differently even though they are of the same stage, same hormonal status or molecular status. So basically the latest classification, you can call it as a clinico-pathological classification, we broadly divide into luminal A, B, basal-like and HER2 disease. We classify the breast disease in these four headlines. Luminal A is basically the tumor which are having ERPR positive, HER2 negative and low Ki67 index. Whereas luminal B types are the tumors with ERPR positive but high Ki67 index. Basal-like cells are triple negative type wherein ERPR, HER2 all are negative. HER2 positive tumors are overexpressed HER2 disease. So chemotherapy. What is the role of chemotherapy in breast cancer? Under three headings we will be covering. One is as adjuvant chemotherapy, as a neoadjuvant chemotherapy in metastatic settings. So breast cancer is a systemic disease. It's not a local disease. It is a systemic disease where chemotherapy is an integral part of breast cancer management. So why this adjuvant chemotherapy was added? Surgery would have been enough. This was based on two hypotheses or two models you can call, Fisher hypothesis and Gompertzian model. What was the old thinking was, everybody knows surgeons here, he's in Halsted, William S. Halsted. We do radical mastectomy in his name. So the idea was, the thinking was, breast cancer is a local disease, spreads to the regional lymph node and then to the disseminated part. So removal of breast, lymph node and chest wall muscle was the logical approach. But what happened? There was recurrences. Even after thoroughly removing also, there was a recurrences in the tumor. So why was that? Because breast cancer is a systemic disease in that tumor cells were likely to have disseminated throughout the body by the time of diagnosis. This what the Fisher has said in his hypothesis. And also, once there is a recurrences, even though if you do resurgeries also, then there are chances of again recurrences maybe in the distant sites. So the theory was that the cell has already escaped from that place. So thinking that, and another, he's a Gompertzian, is a mathematician. What he says is growth rate of a populations are exponential at early stages of development and slower at later stage. Mean to say, a single cell, a cancer cell divides multiple times, say to the 10 to the power of 9 times to show its symptoms. So initial cell division, whatever the treatment, be it radiation or chemotherapy, it is more sensitive at the initial stage. So that's the Gompertzian say. So mixing up both the hypotheses, they came up with this concept of adding chemotherapy, wherein smaller tumors which grows faster, chemotherapy acts best. And subsequently, there was an evolution in chemotherapy, like it was given every 21 days or 4 weeks. Now we are planning for every 2 weeks. The reason being, cells are at the nascent stages, they are rapidly dividing, they are more sensitive for the chemotherapy. That is the concept. So this was the old study done way back. Everybody knows this, that here you can concentrate that age less than 50, age more than 50, ER positive status, ER negative status. For the woman who are node negative, giving chemotherapy has shown an absolute benefit of 11%, node positive. If node is negative, adding chemotherapy has given absolute benefit of 7%. This is extra to whatever surgeries or hormone therapy has been given. If at all, if the same thing is in elderly woman, say 50 to 69 years age, the absolute gain is less. So for node positive it is 3%, for node negative it is 2%. So as the age increases, the benefits of chemo decreases. So this is how the chemotherapy has evolved from CMF chemotherapy, that is cyclophosphamide, methotrexate, 5-FU. Then came the adriamycin anthracycline based chemotherapy, which has shown benefit over CMF. And then came the Taxol, that is paclitaxel group of chemotherapy, which has again showed the benefit over using only adriamycin. And now we are in the era of dose dense chemotherapy, where we are giving chemotherapy every 2 weekly. So this is the slide which shows that first generation, second generation and third generation chemotherapies. So for each addition of chemotherapies, there is definitely nearly about 20% risk reduction in the recurrences. So presently the chemotherapy what we follow is adriamycin cyclophosphamide based chemotherapy followed by paclitaxel, or if we want to give the combination chemotherapy with trastuzumab, we give it with taxanes. So neoadjuvant chemotherapy. So what is the benefits of adding chemotherapy before surgery? Major thing is it can render inoperable tumors into operable. It facilitates breast conservation surgeries, provide important prognostic information. Suppose if that initially what I said clinico-pathological, wherein the luminal A, B, C, A, B or basal-like or HER2 overexpression, how this tumor responds to chemotherapy, we will get a data of such kind of tumors so that it is helpful for further studies to find newer drugs or different types of drugs. It also allows for genetic testing. So who are the candidates for preoperative chemotherapies? Basically inflammatory breast disease, breast cancers, bulky or matted N2 lymph node, N3 nodal status and T4 disease. These are the candidates whom pre-op chemotherapy would be benefit. And in patients of operable breast cancer, it is like large primary tumor relative to breast size. Like Dr. Hathi was telling that if the tumor outgrows the normal breast tissue, so in such cases we can use neoadjuvant chemotherapy and downsize the tumor, and then we can go ahead with breast conservation surgeries. So again, a number of trials which had shown the benefit of adding preoperative chemotherapy. The pathological response, mean to say, once a patient receives chemotherapy and we go and operate, almost across the trial, 5 to 20% of the time you find that there is no tumor, there is pathological tumor resolution. So that's the benefit of again giving chemotherapy, which has shown better outcomes. It has also shown benefit in breast conservation surgery rates, giving preoperative chemotherapies. And the only clinch here is ipsilateral breast tumor recurrences are surprisingly higher. No, I don't say surprisingly, but it has shown some 4-5% higher among the preoperative chemotherapy group. Probably because the radiation dose what they gave was not sufficient. so that the recurrences were higher among the preoperative group, but that is not statistically significant. So conclusion, neoadjuvant chemotherapy produces a substantial increases in clinical response rate and rates of breast conservation surgeries. PCR is an important outcome as is presumably associated with again metastasis response, and obviously it will be better for outcomes. But there is no difference in overall survival among the preoperative chemotherapies or adjuvant chemotherapies. Of course, the recent studies are going on wherein adding trastuzumab for HER2 positive cases, whether that will change our overall survival, the studies are going on. Still we don't have the conclusive evidence for that. So in metastatic setting, so what is the treatment goal in metastatic setting is palliation of signs and symptoms, control of tumor burden, and maintenance of quality of life and function of a patient. So what are the prognostic factors in metastatic breast cancers? One is the hormonal status, HER2 status, performance status of the patient, how fit is the patient, and the tumor burden. Like few patients present with a breast disease and a solitary mets. Maybe it is a skeletal mets isolated, or sometimes only isolated liver disease. Rest of the places there is no disease. So such cases we call it as a oligometastasis, and we treat it as a radical treatment, and the outcomes are very well in such patients. So disease-free interval for favorable group are usually more than 2 years, more than 3 years, 5 years. We keep treating them. We see a lot of patients who are almost 3, 5 years, 7 years, even though they are metastatic. Based on the hormonal treatment, based on the HER2 receptor treatments. So how we approach for the metastatic cancer treatment is, again, first we look at the tumor burden or visceral disease. If a patient presenting in metastatic setting has got lung metastasis, liver metastasis, and lot of other soft tissue mets, we prefer to give chemotherapy. Of course, we do biopsy, we do molecular testing, ER/PR testing, HER2 testing, and then we prefer to give chemotherapy first, followed by hormonal therapy, if at all they are positive. If it is an isolated metastasis where the tumor burden is not there, like its liver crisis is not there, lung crisis is not there, we prefer to give hormonal therapy. If patient is again progressing on the hormone, we give second line of hormonal therapies. So chemo, we keep it at the last option. So this chemotherapy, choice of chemotherapy in metastatic setting, what they say is combination chemotherapy has got better response, like 2 to 3 drug combination. Given the chance, given the performance status is good of the patient, we try to give combination chemotherapy rather than single agent chemotherapies because it has got the better response. So this was about the chemotherapy part. With time constraint, hope I have just touched superficially or have covered basic. This is the molecular testing, broadly what we do in this present era. ER/PR, HER2 is mandatory. The mammoprint, oncotype DX, we do in selected cases where a patient comes in a very early stage. We do it to check whether patient requires chemotherapy or not, adjuvant chemotherapy. So these tests we follow. And BRCA testing, indication of BRCA testing is for the younger females, triple negative females, family history of cancer, bilaterality of cancer, or a single person having multiple cancers. These are the conditions where we advise BRCA testing. So let us see the radiation now. So a lot of confusion in the nomenclature only, radiation oncology, radiotherapy. So presently, officially it is being called as a radiation oncology. So what is it? It is nothing but use of ionizing like X-rays. It is basically high energies X-rays used for treatment. Not to be confused with the diagnostic part where we are using it low energy X-rays. So how it works? Basically, X-rays falling on the tissue releases the free radicals, it damages the double-stranded DNA, and it ultimately leads to cell death. This is the radiation action. So how radiation is delivered is by two means. One is external radiation, other one is internal radiation. So role of radiation in breast cancer. It has got a role in breast conserving surgery. It has got a role in adjuvant settings post mastectomy and in palliative settings. So rationale of giving radiation is the most common site of breast cancer recurrence is local. And preventing recurrences also improves the overall survival. And not all recurrences are salvageable. As I told, even after doing sophisticated surgeries, it's sometimes not possible to take whole tumor. So giving an adjuvant setting radiation in few conditions where it is indicated, definitely there is benefit of overall survival. So objective of giving radiation is to eradicate any tumor deposits remaining following surgery, which leads to improved local recurrence rate and overall survival. So once we do surgery, so what are the indications that we advise for surgery is a tumor size should be more than 5 centimeter. If at all the margins are positive, if node is positive, and for all cases of breast conservation surgeries, we advise radiation, adjuvant radiation. In few selected conditions where there are high risk features of recurrences like young woman, young breast patient, or lymphovascular disease positivity, or the HER2 receptor tumors, triple negative tumors, we advise to take radiation, adjuvant radiation. So what's the dose we give is 50 gray in 25 fraction, that is over 5 weeks of treatment. In few selected cases where skin was involved before or the tumor was deep seated, we give 10 gray of boost to that area. So if the tumor has node positive, we cover the chest wall and also the regional nodal irradiation is considered. In case of patient node negative with high risk features, we also cover the chest wall and regional lymph node area. What are those conditions are? Again, T2 disease, high grade of tumor, triple negative breast cancer, young age, lymphovascular disease. These are the recently added risk factors wherein it will be coming out in subsequent, once the data is published in well-known journals. So what is the data why we suggest adjuvant radiation is because it has shown the absolute benefit of overall survival around 10 to 11%. Like what chemo I have told before, that adding chemotherapy has almost shown the absolute benefit of 11% to 7% in node positive, node negative. Same radiation has shown the benefit of 10 to 11% post mastectomy. So in post BCS cases, that is breast conservation surgeries, almost all cases we advise giving radiation. Few cases where we can avoid giving radiation is the elderly woman age more than 65 years, node negative stage 1. We can avoid giving radiation. So what's the benefit of giving radiation is it has shown 50% decrease in 10-year local recurrence rate. Giving radiation has shown 50% decrease in the local recurrence among the breast conservation surgeries. And also 15-year breast cancer related death also. So that's the benefit of adding radiation. I'll skip this. So what is the volume? How we will identify the volume of giving radiation to the breast conservation surgery, because there is no tumor there. So what we do is, few surgeons or surgical oncologists, when they do the breast conservation surgeries, they keep the markers there. 6 markers they keep usually in the post-op cavity area, so that it is helpful to mark that area during radiation. Otherwise, if the markers are not there, what we do is we check the pre-operative images, be it mammography, or sometimes we give the post-operative seroma cavity area. That is the identification mark where we try to give the radiation. So hypofractionation is the newer thing. The radiation duration is usually 5 weeks. So with this hypofractionation, we can decrease the time duration of radiation to 2 to 3 weeks, which has shown the equal results, no cosmosis, like no side effects, and has got equivalent when compared to 5 weeks of radiation. So it was done in UK. Basically, it was started for the logistic reason only, because patient couldn't come for far area and stay for only for radiation. So this idea was started and it has shown a good results. We are doing the few patients on this hypofractionation treatment also we are doing. So when we give radiation is usually after completion of chemotherapy. So what we do, we simulate the patient. Simulate in the sense we do the CT scan, and you can see we do the contour, like where exactly we want to give the radiation. We mark that area, and also we mark the area where we don't want radiation to go, or where limited dose of radiation to be given. So once we mark it, field setups are done by our physicist team, and then it looks like this. So the rays are coming from, like this is external beam radiation, which rays are coming far from the body. So radiation has got different techniques, 3D CRT, IMRT. IMRT is a more specific conformal treatment, wherein you can control the dose to the normal structures. Example would be the left side tumor, where you can control the dose reaching the heart. So that's the advantage of using IMRT. Otherwise, 3D CRT with tangential field is enough for breast. So that's it. Thank you for your time and patience listening. Any questions? I'm ready to answer.
Thank you, Shankling, for your detailed presentation on chemo and radiotherapy. Any questions from the audience?
Dr. Shantling?
Yes.
To downsize the tumor, how many cycles of chemotherapy are we supposed to give? And after how many days, there is an interval gap after chemotherapy, when do we operate?
So ideally for adjuvant setting, 4 cycles of AC and Taxol. That's the standard what we follow. For pre-operative also we follow the same thing. So if the tumor is responding very well with AC chemo, sometimes you can operate after the 4 cycles of adriamycin cyclophosphamide chemo also.
Okay.
So ideally is we complete whole cycle and then operate. If there is very encouraging result, you can stop at 4 and then surgery and then followed by Taxol.
Other than the tumor size, I had a patient of 2 small lung lesions, which they doubted as metastatic. So chemotherapy was given to that, and after 3 cycles, they totally disappeared. As the patient was a bit educated, nowadays patients go into Google and all and search. So she was reluctant to take the other cycles. Then how do we do in such patients?
So this is again an example of oligometastasis, where only 2 lung lesions are there. There are no other lesions in the body. So responded well with chemotherapy. We usually treat it as a radical setup.
Okay.
So those 2 we neglect and take it as a local disease and treat it and keep it on hormonal, or if at all if ER/PR is positive. So we should convince her to take the treatment, because definitely it will come back sooner or later.
Okay.
Sir, after surgery, is there any duration you would like to suggest that within that duration patient should start radiation therapy? Or is it like if sometimes the patient delays the treatment after surgery 2 months, 3 months? After 2 months, 3 months also, is it okay? Will the radiation will be much effective or not?
So ideally what we say is post-surgery 4 to 6 weeks is the time where you have to start the radiation. So if patient is coming after 2 to 3 months, of course seeing the previous reports, if it is very high risk, say T3 or lymph node status are involved, better to treat it. Benefit or less, the percentage would be 1 to 2% less, but still I will go ahead and treat the patient.
And in patients who underwent BCS, So here, are we following accelerated partial breast irradiation, or is it the routine EBRT?
Yeah, it's routine EBRT.
EBRT. And is it only to the tumor bed or to the whole breast?
Whole breast, tumor bed, boost.
Boost. Right. Thank you.
If there are no questions, let us conclude this talk. Thank you for the precise talk, Dr. Shantling.
Thank you, madam.
Thank you, sir, for sharing your valuable time and knowledge with us. I request Dr. M.A. Bashir, sir, to felicitate to Dr. Shantling Nigudgi, sir. I request Dr. M.A. Bashir, sir, to felicitate our chairpersons.
Dr. Rajshekhar Patil, sir, Professor, Department of Surgery, MR Medical College. Dr. Shanta Patil, ma'am, Professor, MR Medical College. Dr. Charanraj, sir, Associate Professor and HOD, Department of Pediatrics, KBN University. Dr. Vardhamane, sir, Professor and HOD, Department of Pharmacology, KBN University.
Forward and be seated on the dais.
Dr. Nitin Kalaskar, sir, Professor MRMC Gulbarga.
Dr. Pranesh Kulkarni, sir, Professor and HOD, Ophthalmology, KBNU Gulbarga.
Dr. Sujata Dhaded, ma'am, Professor and HOD, Department of OBG, KBNU. I now request Dr. Gururaj Deshpande, sir, MCH Oncosurgeon at Kidwai Hospital, Kalaburagi, on the stage to talk on MRM for general surgery.
Sir is Assistant Professor and Officer in charge of VTSM Peripheral Cancer Center, Kidwai Hospital, Kalaburagi.
Sir has done his UG from Mysore Medical College, Mysore, MS in General Surgery from Jain Medical College and JJ Group of Hospital, Mumbai, MCH in Surgical Oncology from Gujarat Center, Gujarat Cancer and Research Institute, Ahmedabad.
Sir has worked in prestigious institutes like HCG Hospital, Vijayawada and Kalaburagi. His area of interest is in head, neck, breast and colorectal oncology.
I would like to thank the faculty and the organizing committee for inviting me for this lecture on modified radical mastectomy for general surgeons. Now, if we look at the present scenario, modified radical mastectomy is the most common surgery performed by any oncosurgeon in India. As general surgeons before surgical oncologists were there or where the numbers were few, general surgeons used to perform reasonably good radical breast surgeries, and as general surgeons also they were very well trained because our teachers were all general surgeons, they were not MCH. So the legacy has continued and we are doing excellent work in the field of breast oncology these days. Next slide please. How we would take this topic of radical breast surgeries, history of breast cancer, evolution of breast cancer surgeries, radical mastectomy, modified radical mastectomy. There are a few images which I would like to show and a video, and complications. I would like to keep this topic concise, and I would like to stress more on the history, how the surgery for breast cancer has evolved, because most of us know that CA breast, MRM, but what amount of thought and insight has gone and how many years they have experimented, what was the initial idea when they diagnosed a breast cancer. So we'll look into that. It will be more a little theory, but I think it will be good, interesting fact. Next slide, please. So earliest evidences where the breast cancers have been documented was in Edward Smith papyrus, somewhere around 3000 BC. Information about breast disease, as well as if you look at the papyrus, there is a lady which is depicted who has undergone a surgery for breast cancer. So this is where the people have recognized that the lump in the breast which is not normal could be a cancer. So way back in 3000, there was a fair idea that cancer exists. Then, next slide please. So as the history evolved, there was Hippocrates, one of the greatest physicians of the Greece. So he has documented a lot of diseases, the etiologies. So he also has documented a case of breast cancer where there was a blood-stained nipple discharge. And he also told that age is one of the important factor for breast cancer. So we all know that the breast cancer most commonly occurs in postmenopausal or perimenopausal ladies. Next slide, please. So later there was a surgeon by name Leonidas in the Greece. So he was the person who has documented the surgery for breast cancer. Initially, how they would operate, you will be surprised. Most of the surgeries were performed in a dark room on an inebriated lady. She would have been fed so much of alcohol that she will never respond to pain. And the surgery used to be quite brutal, because no good pain management, no anesthesia at that time. Most of the surgeries, it seems, were conducted in the backside of the barber shop. If we know, the initial surgical societies were called Associations of Surgeons and Barbers. If you know or not, I don't know, but that is where the association has come. So the first documented surgical management was by Leonidas. Next. So these were on excavation, these were the instruments which were identified and were used in those areas, those era, and some of these could have been used for the management of breast cancer. Next. Next slide. Okay, in 1st century, so there was a big gap, not much was happening on the medical side. Then the Renaissance period will start. In Celsius, we all know Celsius for his contribution to the science of inflammation, rubor, calor, dolor, and so Celsius was one who tried to tell that the staging of the disease. He also told that when the lump is small, the chances of cure is also good. So how we have evolved, see, they have started understanding the concept of early disease. So Celsius was one person who started thinking on that line. Next. We can use? Okay. Oh, thanks a lot. Thanks a lot. Then came the Galen. Galen is so famous that even now, whatever findings or whatever clinical trials happen in breast, it is taken to the St. Galen's conference where a common consensus is done. So Galen, the concept of Galen was that there was something called black bile, and black bile was responsible for malignancies. So in cases of early CA breast, he would do venesection, and he thought that venesection would release out the black bile, and that was the way of treatment. But he also told that deep-seated tumors required surgery. So later in 7th century, so there has always been a gap, because medical, even now if we see, there will not be much change in the surgical technique for last 20 years. So surgical technique will take a long time to take a leap. So this was when, in the medieval period, CA breast was operated with a guillotine method, wherein large needles were pierced through the neck, through the breast, and the breast was pulled, and a guillotine was used to chop the breast. And the raw area was cauterized using a steel, with a heated metal. So then the concept, till then breast was understood to be a localized disease. then the concept of axillary nodal involvement came. Henry Dahn was the person who has identified that nodes also, the tumor spreads to the nodes, and he removed the axillary nodes. And Banks told that even when the nodes were not involved, they should be removed. So now the staging, the concept of staging evolved from this. From T, we went to T and N. So after that, there was a big gap. Again, the father of radical surgeries, Halsted, came up to the picture. Halsted is known for his Halsted's theory. Halsted's theory is that breast spreads in a staged fashion. From initially it develops into the breast parenchyma, then it goes to the lymph nodes, the first stage of lymph nodes, second stage of lymph nodes, and third stage. This was what he thought, and he practiced a very radical surgery for this. See, if you look at the illustration given by Halsted himself, he would remove, along with breast, axillary nodes, pectoralis major and minor muscles, everything which was removed and which is not, without which if the person can survive, that would be removed. So that was what Halsted had advocated. Then what went along that theory, means what was favoring that theory, we all know that the breast cancer goes in a staged fashion, but when it is small, when it is large, the chances that it bypasses the routine path of axillary pathway, we all know that. So initially this theory would have held good, and there was no clinically, we were unable to tell that there is a tumor emboli in the lymphatic system, because that type of investigation was still not available. And what went against this theory was radical surgery was not giving any survival advantage, and animal models, because that was the time when lot of diseases were induced in animals, or they were looking into trying to simulate things into animals and trying to extrapolate to human beings. So when they did in animal models, this didn't work well. Then extended radical mastectomies. It was seen that some amount of lymphatics would go to the internal mammary, though Sampson and Lee, he tried to resect the internal mammary nodes as well. So it's such a extensive surgery. They didn't stop there. They started removing the supraclavicular nodes. They started removing the upper limb as a treatment for breast cancer. Then resections involving the removal of latissimus dorsi muscle and serratus anterior muscle as well. So then comes the next theory, wherein it says that breast cancer is a systemic disease to start with. Then the Fisher, who was the next pioneer in this, and now whatever trials happen under NSABP, National Bowel and Breast Diseases Consortium, was founded by Fisher. So such huge names in the treatment and oncology. He says that it is a disseminated disease to start with. And the MRM was introduced. MRM was introduced sometime in between, and it was not very much advocated, because for 75 years, Halsted's radical surgery was in practice. MRM was introduced, but it didn't pick up, or it didn't become popular. But Volkmann introduced the new technique, wherein he tried to remove the entire breast and axillary nodes, preserving the pectoral muscles. And he also advocated that never dissect the tumor, means never split the tumor. Tumor has to be removed in toto. So this was his, if you look at the literature, it is telling that forgotten Volkmann's technique. If you look, because that was not into practice for a long time, and Halsted surgery was practiced for almost 75 years. Then comes the Pater and Anson, where they started looking for a lesser procedures, because it was already documented that by Fisher it is a systemic disease. Then Volkmann tried to preserve the pectoralis major muscle, and now the pectoralis minor was trying to preserve. But there they preserved pectoralis major and they removed the pectoralis minor, and they found that no survival difference between the Halsted's and the modified radical mastectomies. Then comes the real concept as a systemic disease. He says until an efficient general agent means the agent which works on the whole of the body, for the treatment of carcinoma breast is developed, a high proportion of cases are doomed to die of the disease, whatever combination of local therapy. See, this is the literature, so I am reading as it is. Whatever combination of the local treatment by surgery and radiation is used, because in such a high proportion of cases, the disease has passed outside the field of local attack when the patient first comes for the treatment. That means when the patient has come, the disease is already a systemic. There are already circulating tumor cells in the body. These are the titles of the original papers which they have published. Then the lesser, the concept kept on evolving. Then Madden's theory of lymphangiopathy, wherein it bypassed. So Halstead was telling that it was a staged fashion of spread. Then Madden showed that even if it has not got to the first chain of the node, it would have bypassed. There are some lymphatics which can directly go to the third chain of the nodes, third group nodes. So this was advocated. Then Auchincloss used his wit at the time and he tried to conserve the pectoralis minor. He dissected it. Then he tried to dissect the level 1, 2 and level 3 should be removed only if it was enlarged. Then Scanlon advocated that we can divide the pectoralis minor muscle and then remove the level 2 and level 3 nodes, which we can do if it needed now. Otherwise, we generally do level 1 and level 2. Level 3, we have other ways of doing. We have ways we can retract the pectoralis minor if it is not possible or if it is infiltrating and if the patient has come up for surgery or sometimes it is surprised during surgery. So we have to remove. So it is more of a local excision. So with that background, whatever insight, whatever thought had come, we come to a stage where we are doing routinely modified radical mastectomies. What are the indications for modified radical mastectomies? A patient with breast cancer. Then we have a patient who has already undergone an excision and for a breast lump which was a malignancy, or if she had not taken any treatment, if there is any contraindication for radiation for that patient, inflammatory breast cancer, then if on imaging, if we find multifocal disease, we still think about modified radical MRMs. Widespread disease, then even at times what happens, there will be lot of DCIS or microinvasive disease in the periphery of the hard lump. So that means even after repeated excisions, repeated histopathological or frozen sections, we still get margins positive. In such case, again we need to do a MRM. Then there are some relative indications. Connective tissue disorders is also one of the absolute indication. What if the patient wants MRM? We have to give, because you can counsel the patient, your lump is small, you will be able to retain your breast, your physique will be fine, you look good, but patient will say, bad research, we want MRM. So if that is the case, we have to do it, and elderly wherein we need to avoid radiotherapy, we can go for MRM. Technique for MRM, patient is under general anesthesia in supine position with the arm abducted, and sometimes to get a better access to the axilla, we keep a roll of towel below the hemithorax. The boundaries are the skin flap MRM incision taken. Most of the time it is Stewart's or modified Stewart's, which looks like a teardrop. Incision is taken, the superior and inferior flap is raised, then medially the extent of the dissection is up to the lateral margin of the sternum, laterally up to the lateral margin of the latissimus dorsi, superiorly up to clavicle, inferiorly up to rectus. So then the breast is gradually dissected from the pectoralis major fascia. As we go laterally, we encounter the lateral border of the pectoralis major muscle. Then we lift the pectoralis major muscle. Then we remove the nodes between the pectoralis major and minor. Again, we continue laterally towards the lateral edge of the pectoralis minor and enter the axilla by dissecting the clavipectoral fascia. On dissecting the clavipectoral fascia, we encounter some nerves. They are the intercostal brachial nerves, and we encounter the lateral thoracic nerves, which are generally cut and ligated. Medial pectoral nerve, if possible, we can save. Most of the time, we try to save that. Axillary lymph node dissection is done. Axillary lymph nodes are dissected along the thoracodorsal pedicle, along the axillary vein, and once the dissection is done, we will be able to see the thoracodorsal pedicle clearly along with thoracodorsal nerve, and medially we will be able to see long thoracic nerve of Bell. Again, I will show you all the images. This is just a theory. Long thoracic nerve of Bell, pectoralis minor and the Rodner's nerve has to be removed. So if this is the incision, see, incision can be oriented in any fashion, however we want. This is routine incision. We take an elliptical incision or a teardrop incision. The incision should never extend beyond the medial aspect of the sternum, and laterally it should never go beyond it should never reach up to the posterior axillary fold. By doing this, if we do that, if the patient has to undergo radiotherapy, the chances that patient will have complication because of radiotherapy, because the incision margin has to be covered in the radiotherapy. If we go more laterally, the chances that the radiotherapy will cause lung complications, or if we go more medially to the heart, radiotherapy to the heart or the radiation to the heart increases. So we can avoid, because in breast, radiotherapy is always tangential. Then this is how the flap is raised. How the flap is raised, because breast is all fat, how will we identify which fat has to be retained and which fat has to be taken with the flap? See, the flap, sorry. This fat is having small lobules. The fat which is there, the part of the breast will have large lobules. If you see, there is a plane of dissection, this white plane of dissection between these two. This is the dermal fat, this is the breast fat. See the lobule size, it is big. See the lobule sizes are small. So we need to identify a plane in between these two. The plane is generally marked out by this loose areolar tissue, which can be well stretched using this hook. Then we will be able to dissect it. So after the margins, we have reached the upper and lower margins. Then from medial aspect, we start dissecting the breast tissue from the pectoral muscle. See, so I'm sorry. If we notice, we have removed the pectoral fascia as well. That's why the muscle fibers are looking bare. And how do we enter the axilla? We enter the axilla lateral to the pectoral muscle by giving a cut. This is pectoralis major already, and this pectoralis minor. This is clavipectoral fascia. So this vertical cut. Always this has to be vertically aligned, because just below there comes the long thoracic nerve of Bell. So it has to be vertical dissection. Because when we go parallel to any blood vessel or neurovascular bundle, the chances of injuring that structure is reduced. Then after completion, this is how the axilla looks. This is the thoracodorsal pedicle along with the nerve. This could be faintly seen, long thoracic nerve of the Bell. This is serratus muscle. See, this is serrations. This is muscle, minor muscle. The pectoralis major is somewhere here. So once the surgery is done, the tumor is, when the specimen is delivered, most of the times we use staplers to close. We put wash with antiseptic solution and saline. Then we close with staplers. We can do subcuticular suturing as well. After putting, vacuum suction drains. Drains are placed. If we look into the Fuckerson's book of surgery, he has documented how the drains has to be placed. The medial drain goes along, medial drain goes like this, the lateral drain goes like this. So this goes towards the axillary armpit, this goes along the flap. So this is how the drains have to be placed. Try to play that video. Close the window and play the video. Mute kar le. See, this is a case demonstration wherein they have done sentinel node biopsy as well along with MRM, because they found that the node was positive. So this is how the dye is injected. The incision is marked. See, the knife has to be perpendicular to the skin margin. It should never bevel. By beveling, we'll lose the skin. And this is how the flaps are being raised. ಸ್ವಲ್ಪ ಮುಂದೆ ಮಾಡಿ. So flaps are being raised, inferior flap being raised. See, this is how the loose areolar tissue stands out. Then along the pectoral fascia, you see, as I told, the fascia has to be excised and the muscle is bare. So laterally, this is how they are dissecting. Clavipectoral fascia is being cut. Once the clavipectoral fascia is cut, axillary fat pops out. So since they had done as dye, they had injected, so that lymph node is stained there. Next. So they are doing a frozen section of that. So that is the point where we have to look for long thoracic nerve of Bell. See, that's where you see long thoracic nerve of Bell. Then laterally, along the inferior margin of the axillary vein, the dissection continues to remove all the axillary sheath is also removed. The vein has to be bare. The thoracodorsal pedicle has to be bare. Forward. So this is a complete 1 and 2 level dissection. Thoracodorsal pedicle is seen, axillary vein is seen. So this more lateralized. There we are seeing in the floor of the dissection, we are seeing latissimus dorsi. Sometimes level 3 notes may not come as along with the specimen, so we may end up doing it as sending it as separate specimen. See, all the structures have been identified. So the axillary, the deepermost limiting factor would be the Halsted ligament. Close. So this is how the cavity looks after the surgery. Drains are placed and the incision is closed. This is how what we routinely do. Back to the next. Okay. So looking at the complications, early complication will be pain and stiffness, hematoma, skin flap loss, seroma formation, infection and injury to the neurovascular bundle. Most of this can be avoided, but these days it is difficult to avoid seroma formation because it is there almost for all the patients. Then hematoma is somehow with good cautery, we are able to take care of that aspect. Pain and stiffness is there generally because this intercostal brachial nerves get excised during the surgery, so there will always be pain in the medial aspect of the ipsilateral arm, which goes up to the infra-axillary region. So that area, neurological paresthesia will be there. And infection, if the patient is diabetic and if we have not taken care of the sepsis, then that antisepsis, then infection is bound to happen. Delayed, some patients will, because of initially if they have not done the physiotherapy properly, there will be some pain, stiffness and paresthesia. And restricted movements will be there at the shoulder joints if they have not done their physiotherapy properly. Encourage them. These days what I have told, idu new madillandre mundu rotti badilike agalla nodri. This is what I tell to my patient. So somehow we have to encourage them to do limb physiotherapy. Lymphedema is bound to happen if there are large nodal disease and if we go above the axillary vein. Generally, we keep our boundary just at the level of axillary vein. If we start dissecting the fascia and lymphatics above the axillary vein, that lymphatics are supposed to drain the upper limb. So if we remove that, then lymphedema is bound to happen. Chronic seroma, even after lot of efforts, patients even after 6 months do come with seromas. Psychological complications of MRM, because initially that fear will be there that the disease will recur. So how to do, nan badukbeku. But once they have seen the outcome and if they are able to live happily without disease, then the problem will start. Breast idre hangitri doctor. So that psychological thing will be there, but with adequate counseling we can still overcome, and good surgical technique, most of these complications have reduced. And I thank everybody here for giving me this opportunity. And if you all have, I request the Faculty of Surgery to post your postgraduate students to VTSM Peripheral Cancer Center so that they also get used to these type of radical surgeries more. I am sure that these are happening in your institute as well, but they will see more in numbers. So that will give them a lot of confidence, and at least they will be able to make decisions in their life and they go out as general surgeons. Thank you, everyone.
Thank you, sir. The forum is now open for discussion. Dear audience, please state your questions, if any. Thank you, sir, for enlightening us with your knowledge. I request Dr. Nankishore Shinde, sir, to please felicitate
Dr. Gururaj Deshpande, sir. I request Dr. Nankishore, sir, to felicitate our chairpersons.
Moving on with the next session, we now request our distinguished chairpersons on the stage. Dr. Sangmesh Sir, Associate Professor, JIMS, Gulbarga. Dr. Sunil Kumar Sir, Associate Professor, General Surgery, ESIC, Gulbarga.
Dr. Amol Patange, sir, Professor, Department of Psychiatry, KBNU. Dr. Mohsin Ahmed, sir, Professor, Department of Pharmacology, KBNU. May I now request the most dynamic personality, Dr. Amresh Biradar, sir, plastic surgeon, on the stage to talk on the topic, reconstruction of breast after mastectomy.
Dr. Amresh Biradar, sir, is a practicing plastic, cosmetic, and hand reconstructive microsurgeon in MRMC Gulbarga. Sir has completed his MBBS and MS in the same institute.
He further chased his dreams of MCH in plastic surgery, completed from Bangalore Medical College and Research Institute, and DNB in plastic surgery from National Board of Examination, New Delhi. Sir got his fellowship in cosmetic and reconstructive microsurgery from Apollo Hospital, Bangalore.
Sir completed his fellowship in reconstructive microsurgery from Memorial Sloan Kettering Cancer Center, New York, USA, and hand surgery from Christine M. Kleinert Institute of Hand and Microsurgery, Louisville, USA. The stage is yours, sir.
Thank you for the kind introduction. Good afternoon, everyone. I'd like to thank the management of KBN Medical College and University for giving me opportunity to present my work. I also thank Department of Surgery and the organizing committee, Dr. Moinuddin sir, Dr. Devani sir, Dr. Bashir sir, Dr. Nand Kishore, Dr. Anup, and everyone. So next 20 minutes is going to be very interesting. It's going to improve a lot of life and how we change people's life. That's what I'm going to show in next 20 minutes. So what is the importance of breast? The breast is the most important external identification of femininity, and loss of breast can have a devastating psychological effects on the woman. A woman who has lost breast through a cancer may feel self-conscious, insecure, inferior to other women, and she will be undesirable for men. So what is the ideal breast? So ideal breast is something where you can see here, the 45% of the breast should be above the nipple, and the 55% of the breast should be below the nipple. This is what looks an ideal aesthetic breast. So this is an ideal breast. Not everyone has the same breast. Breast comes in all sizes, all shapes, because all human beings are not equal. The same thing applies to the breast as well. So what we get is something like this. We get something like this, and we have to do something like this. Our job is similar to an architect. Architect, you see, he gets a plain hall. The interiors are done by the architect. It's something like that. Our job is something like that. So what happens after mastectomy? So I always tell, probably this part of India or this part of Karnataka, not many people emphasize on reconstruction. But whenever the patient comes to us, when I ask them, what is the primary reason of undergoing a reconstruction, they always feel that what happens after mastectomy is similar to what happens if a person loses his hand or upper limb. The same is a feeling. You imagine morning, you get up one fine day and you don't have your breast. So bad you feel, you cannot see your face or your body in your own mirror. That is how is a feeling. A person's losing breast, it is most devastating for that person. So the feeling is same as losing an arm or any other part of the body. So the patients are usually depressed. They will not be able to wear their favorite gowns. They will not be able to go outside parties. They will not able to be found their femininity. This is the problem. So why breast reconstruction? The people most common answer is, I have a long life to live. I want to live it whole. I wanted once again to put the beautiful nightgown and fill it all out. I was gardening one day. When I bent over, my prosthesis fell out. Crying, I picked it out of muddy water. Then the next day, she visited the plastic surgeon. So the most common questions when the patients ask is, who is a candidate? Will the breast reconstruction interfere with the cancer treatment or the detection? Are there some women who should not have reconstruction? Does the type of cancer make a difference? How does the adjuvant therapy impact on reconstruction? So the most common indication for reconstruction is anyone who have breast cancer and who have achieved the complete cure of the cancer, there we can do a reconstruction. In case of a toilet mastectomy, when patients underwent stage 4 cancer where there is complete involvement of the chest wall, even there is a metastasis, in those cases we just do a chest cover, but other places whenever the patient desires, we can do a breast reconstruction. So the goals of reconstruction is volume, that is to achieve a perfect size and projection, envelope to achieve a good shape and projection, symmetry is very important to match the contralateral breast, and finally we have to recreate the nipple areola complex. So comparison between the breast surgeries and the extent of resection. So in most radical mastectomy, the reconstruction would be skin graft or local flap required to cover the defect in case of a radical mastectomy. In case of a modified radical mastectomy, we can do a possible immediate reconstruction or a delayed reconstruction. And in case of a simple mastectomy, we can do a immediate or delayed reconstruction. Skin sparing mastectomy, we can do a immediate reconstruction. And in case of breast conservative surgery, usually the reconstruction is not required. So timing of the surgery is very important, whether to combine the reconstruction during the mastectomy or we have to delay it. Both have its own advantages and disadvantages. The immediate has the advantage that no feeling of loss of femininity, less self-esteem is maintained, body image, and less incidence of depression. In case of a delayed, that is indicated when the patient is needing a radiotherapy, because in radiotherapy can interfere in reconstruction, and most reconstructions are immediately following mastectomy nowadays, because as you see, the social media has played a huge role in increasing the awareness about breast reconstruction. So immediate reconstruction, there is a better breast symmetry that can be achieved, and more of original sensate skin can be preserved, and the breast remains sensate. Especially in the delayed reconstruction, the flap what we use, most of the times it remains insensate, and it is easier to preserve the inframammary crease. That is one of the important landmark in the breast, and that can be retained in immediate, but very difficult to re-establish. It can be re-established, but difficult to re-establish in a delayed reconstruction. So the patients who are undergoing additional cancer therapy such as radiation, in those patients we recommend a delayed reconstruction, and sometimes it gives an advantage that patient to consider the other options of reconstruction, and mastectomy scar is present on the chest that requires an additional surgery and recovery, and most of the times the secondary surgeries are very difficult because already there is a lot of scarring that has happened, and the patient has to undergo the second delayed reconstruction. So what are the options of breast reconstruction? So there are autogenous and there are alloplastic. So autogenous, there are these flaps, local flaps what we use. Abdominal flaps are tram flap, that is transverse rectus abdominis myocutaneous flap, that can be a single pedicle or double pedicle flap. These deep inferior epigastric perforator flap, superficial inferior epigastric perforator flap, and latissimus dorsi musculocutaneous flap. These are the local or free flaps that both can be used. And distant flaps like gluteal flap, superior waist, inferior waist, Rubens flap, lateral transverse thigh flap, that is tuck flap, thoracoepigastric flap, gracilis flap. These all require a microsurgical procedure. That is we need to have a microscope and we take out the flaps from the other parts. We use a microscope to anastomosis in the either axilla or in the chest. So alloplastic, what we have a silicone gel implants or saline implants. So silicone gel implants we can fill with the saline, or it can be combined with the LD flap, or it can be combined with the tram flap. So we have a patient like this. The patient comes to like this. So what are the options? We can use a latissimus dorsi musculocutaneous flap, or we can use a rectus abdominis musculocutaneous flap, or we have some other options. Again, we have to sit with the patient, we have to decide, we have to give all the possible options what the patient has, and then we help them to decide what option they want. So the prosthetic techniques, the indication for this is usually the bilateral reconstruction, smaller breast molds with a minimal ptosis. There is a lack of adequate abdominal tissue due to previous surgeries. The patient is not willing for a additional scar on the back or on the abdomen, and patient requesting a augmentation in addition to the reconstruction. So what we do here is we immediately after mastectomy we place expander or a implant below the muscle. We expand it when whatever size we need, and then we reconstruct. The relative contraindication for prosthetic breast implant is patient unwilling to adhere to the follow-up, very large breast, very ptotic breast, and absolute contraindication is silicone allergy. Some people have a silicone allergy, implant fear, and previous failed implants, and need for adjuvant radiotherapy. These are the absolute contraindications for the silicone breast implants. The expander implant reconstruction. So appropriate for the patient whose skin envelope is preserved, and that is the patient is treated by skin sparing mastectomy, and it can be immediate or a delayed. A permanent prosthesis is placed subpectorally and tension-free skin closure is obtained. This technique usually it has 2 stages. it corrects the skin deficiency, and it needs a multiple office visits. These kind of implants, we usually have something like this. You can see these are the tissue expanders. We place it below the muscle. We expand using this port. We insert the saline, we insert the distilled water. We expand whatever size we want. Once the size what we want is expanded, then we place the silicone implant inside. This is the incision what we use, and we place the expander. Expanded, this is the final result that can be achieved. This is a preoperative of a some patient having a malignancy, expander in situ after the placement of the implant. This is a final appearance after nipple areola complex has been reconstructed. In case of a permanent expander, that is the implant what we place below the muscle, that acts as an implant as well as an expander, both. It acts as the same. That can be used. It has a special port. This can be removed after the adequate size has been achieved. This has an advantage of single stage, correct the skin deficiency, and this also needs a multiple office visits. So this is a patient with the immediate implant-based breast reconstruction. We have placed the tissue expander implant and expanded after multiple visits. Usually takes around 3 to 4 months to achieve a symmetry. The advantages of this is it decreases the operative time, no required of second procedure, no additional scars, good color match can be obtained, and no donor site morbidity. You might be knowing this lady, beautiful lady, many times, many years. She was the face of ideal aesthetic plastic or ideal face. She underwent a double prophylactic mastectomy and implant-based reconstruction. She underwent 3 stages for implant-based reconstruction. She used expanders. Expanders were removed in 3rd stage, and permanent silicone implants were used. So coming to the transposition flap reconstructions, the options available for us is latissimus dorsi musculocutaneous flap and transverse rectus abdominis musculocutaneous flap. The advantages of this is it corrects the skin deficiency. The normal subcutaneous tissue has to be used. There is no use of foreign material. Longer operative time is needed after mastectomy, and it carries a bit higher morbidity compared to the other techniques. In latissimus dorsi, this is a fan shape, the muscle in the back of the abdomen, and this cannot be used in cases where there is a thoracodorsal pedicle has been already damaged. So the indication for breast reconstruction using LD flap is a smaller breast, minor breast ptosis, abdominal donor site is not available due to scar or lack of tissue, salvage of previous breast reconstruction, and absolute contraindication for this is previous thoracotomies. So this is a lateral latissimus dorsi flap, and this is a skin pedal that can be used. So once we harvest, we move it in the breast, and this is a sutured line. Let us see some of the practical cases. This patient had a CI breast, stage 2, and she underwent a MRM, axillary lymph node clearance, and latissimus dorsi flap was used along with the skin paddle, and these are the drains. Sorry. And this is the final appearance, well settled flap. Another patient who had a fungating growth, LD muscle was harvested from the back. This is a skin paddle that was used, and skin paddle sutured to the defect. Now let us see about TRAM flap, that is transverse rectus abdominis myocutaneous flap. The indication for this is a large breast, the breast which has a ptosis, and the contraindication for this is a previous abdominoplasty. So pedicled TRAM, what we do is we based on superior epigastric vessels, we take the muscle along with the lower part of the abdomen, and along with this pedicle, this muscle, this much part of the abdomen has been taken, and we use it to reconstruct this part. Here we cut out this part of the vessels have been cut. We retain one side of the vessels, and once the abdomen is closed with the abdominoplasty, like we pull down the abdomen, I'll show you the practically how we did. This we did way back in 2017 when I just came back from US. This patient had a mastectomy. After that, she was very depressed. She came to me. She wanted a breast reconstruction. She had a very lax abdomen, 3 pregnancies she had. So we used a tram flap here. This is the marking. We used a contralateral rectus abdominis muscle along with the pedicle. This is a marking what we do. And this is after the harvest of the tram flap. We sutured the rectus abdominis with the other side of the rectus abdominis and other para-abdominal muscles. And this is after the reconstruction immediately on table. You can see very nicely done abdomen. Like, who doesn't want abdomen like this? See, this looks youthful, this looks wonderful, right? So, very well settled flap. This is immediately on table. This usually settles. This is after 2 weeks and this is after 6 weeks. The patient came to us after 6 weeks. She said, just wow, like she cannot believe. She had a new lease of life after that. And abdominal suture line, it is completely hidden in her pantry lines. So, absolutely youthful abdomen. So, who doesn't want like this from here till here? Everyone wants, but it's not been offered. It's not, the patient doesn't know that this can be achieved. If we offer, who doesn't want this? So, another patient who had a CA breast, same tram flap was planned, tram flap was harvested, contralateral flap, the reconstruction, this is after him. Another single pedicle tram flap, post-op immediately. So, if we have a microscope, we can do something called as free tram flap, where we disconnect the deep inferior epigastric vessels and we use either transverse arteries or internal memory artery to connect the superficial epigastric or deep inferior epigastric vessels, and this is a free tram flap. The same, the incision, everything remains the same, only that we disconnect the flap. The entire flap has been disconnected. So, for evaluation of these flaps, we need to understand first whether the vessels are very nicely, which vessel is prominent. To see that, we need a CT angio for evaluation of deep inferior epigastric artery or superficial inferior epigastric artery. Here you can see that is superficial inferior epigastric artery, and this is a deep. Deep is very prominent, so we have to use a deeper one. The primary reconstruction with the DIP flap, the patient had a CA breast, the marking of a DIP flap, this is a harvest along with the vessel. Here the advantage is you can spare the other side rectus abdominis muscle so that the abdomen still remains tight. This is after the inset of the flap. Another patient who had a mastectomy, delayed reconstruction of the breast, DIP flap was done. This is immediately after inset, and this is immediately after the closure of the abdomen. DIP flap, here no muscle, no sheath, only perforator. You can see this is a perforator. This is a perforator, this is a skin and this soft tissue. That's the only thing. Now, we don't use a muscle here. So, the advantage is the abdominal strength remains the same. The advantages of DIP flap, rectus abdominis muscle is saved, rectus sheath is saved, primary closure is obtained, so no mesh is required. Another few more techniques, because the evolving medical sciences, gluteal flaps have come, that is superiorly based or inferiorly based. Here superior based is preferred because the amount of tissue what we get is more, and it doesn't bear the pressure on the sitting position. Internal memory arteries are the most commonly used for recipient, and the vessels where what we use is the branches of internal iliac artery. Based on those branches, we use the free flaps. So this is a S-gap flap, that is a superior gluteal artery flap based on internal iliac artery. This is a flap what we take, we use the vessel, we bring it to the abdomen, close the defect, anastomosis with the internal memory artery, and this is a primary closure of the muscle where we take. Absolutely hidden inside the bikini line. So this is a S-gap flap. Patient had a CA breast, mastectomy was done. Then we use the superior gluteal artery flap. These are the flaps, and both the sides, and reconstructed. Another, this is an inferior epigastric artery flap, where this comes inside the cleft. So after mastectomy, this is a defect, this is a flap what has been taken, and this is after reconstruction. There is another, now after many people, even after wearing those bikinis, monokinis, as they are getting smaller and smaller, they wanted something which the entire scar has to be hidden. So this lead to invention of a transverse upper gracilis flap. This flap has a skin, fat, gracilis muscle of the inner thigh, and it constitutes the transverse upper gracilis flap. The incision line is within the groin crease. The skin and the fat can be made in a cone shape. That is the biggest advantage. Used in patients where the patient's abdomen cannot be used. In the small volume reconstructions where the breasts are really very small, and it has a most superior cosmetic outcome in the present reconstruction of the breast. The nipple can be reconstructed in the same setting. So this is a tuck flap. Here, this is how it is based. We use a gracilis artery along with the gracilis muscle, and skin and soft tissue has to be taken. It is brought to the chest, anastomosed with the internal memory artery, and practically this can be molded. It can be molded in any shape, breast shape, and nipple can be reconstructed in the same setting. This is a reconstructed nipple in the tuck flap. So this is an on-table result, and this is a final appearance. So coming to nipple reconstruction, our reconstruction doesn't stop at just breast reconstruction. Giving volume doesn't stop that. Some patients, they even want a normal appearing breast as well. So in those patients, we offer something called as nipple reconstruction. The position of the nipple has to be judged properly for the aesthetic appearance, and usually it has to be delayed 3 to 6 months after complete reconstruction of the breast mold, because there is some amount of inflammation, there is some amount of scarring, fibrosis that is going on in the new flap. So methods, there are many methods. Most common is locally flaps we use, or we can use a opposite sided nipple graft, skin graft from the labia, or it can be used from the inner thigh. For giving elevation, we can use a cartilage graft. Nowadays we are using fillers, injectables, hyaluronic acid we are using for giving an elevation. So there are these many local flaps are there, like skate flap, modified skate flap, star flap, but I commonly follow is star flap or a C flap. This is something called as a skate flap. We place an incision, we give a elevation like this and suture it. We do tattoo. There are medical tattoos. We do tattoo for areola reconstruction, and this is the final appearance. This is a DIP patient with the NAC reconstructed. Both appears almost similar. Hardly, if you see from the distance, you can hardly make out that this breast has been reconstructed. Areola reconstruction in another patient who had underwent mastectomy and breast reconstruction. So we can use a graft either from the opposite side, or we can use it from the labia. We can make areola using the graft. So no breast reconstruction, is it an option? Yes. In few patients, women who choose, it can be, it cannot be, I mean, we can just leave it like that. As Hatti sir said that in our patients, many of them, they don't want to get reconstructed. Yes, it's their own choice. Again, age of the patient, stage of the cancer can play a very important role in breast reconstruction. There are available external silicone prosthesis that is available. Women can choose that, something like this, external prosthesis, they can keep it their bra, and they can mimic that the breast is fuller. But rehabilitation, breast reconstruction following mastectomy is not to restore the function, but it doesn't need to be. The point of the breast reconstruction is to make the patient as whole again as she was before the breast mastectomy. So the breast reconstruction, including the revision balancing procedure, has to be viewed as rehabilitation and not as a cosmetic. That is the reason why nowadays insurance has started covering breast reconstructions, all end to even including the implants, they are started covering the breast reconstructions. The end result is to make the woman very happy. The starting I showed you a depressed woman. You imagine one fine day you get up in the morning and you say that you don't have a breast. How it feels? Depressed, right? So at the end of the day, achieving a happy woman is through breast reconstruction. So the future of reconstruction, there have been a lot of innovations in last 1 decade People have started using robot to harvest the LD flap. There have been extensive use of acellular dermal matrix. Lymphovenous anastomosis have been offered in a primary mastectomy patients to prevent lymphedema. Stacked flaps for breast reconstruction, that is use of multiple flaps to reconstruct the breast, achieve a normal volume, have been recommended in the last few years. So this is a harvest of the LD using a robot. Here these multiple ports have been used. No use of this long skin incision have been placed. So this is a harvest of the LD through a robot, very small incision in the axilla. And this is a result after reconstruction of the breast using a LD flap harvested through a robot. So to conclude, breast reconstruction may be one of the most significant female surgeries of this era, and it has been increasing in last 1 decade. It may lessen the fear that contributes to women's avoidance of medical evaluation of the breast problems. Immediate reconstruction is favored because studies have documented no increase in oncological risk, no delay in adjuvant therapy, better aesthetic outcome, less depression and more cost effective compared to a delayed reconstruction. Autogenous tissue provides superior results but at the cost of a donor site. I thank Department of Surgery and Organizing Committee for giving me opportunity to present my work, and if any doubts we can discuss. Thank you. Thank you, Chairperson.
Congratulations, Dr. Amrish. It was a very detailed and a nice demonstration with lot of pictures and a bold presentation, I can say. The house is open for discussion. If anybody has any questions, we'll take up 1 or 2 questions. Any questions from audience? Okay, sir has a question. Please, can someone give mic to sir?
In free flaps, what is the rejection rates and how do we tackle it?
Sir, nowadays a center which the free flaps, if it's not having 97% of success, the entire team needs to be retrained. That is how the dictum goes today. It's again multifactorial. The patient is not having any coagulopathy, doesn't have any ischemic changes in any of the other places. There is because chest is very well vascularized area. Internal memory artery is one of the major arteries, very near to heart, has a very good blood supply. Rejections are very less in head and neck and chest. Peripheries it is more. In chest obviously 2 to 3% is accepted. More than that, the entire team needs to be trained again.
I have a question, Amrish.
Yes.
Since it's a reconstructive surgery, how do we plan for maintaining the symmetry and the volume of the breast?
There are 2-3 things, Dr. Sanmesh. So I showed you my patient. So when I was planning, she had a very lax abdomen. The breast size what I wanted to match on the opposite side, that much amount of soft tissue was available in her. So we used that much. If we are having more amount of soft tissue, we discard. We have less amount, we use an implant. So that's why I said use bigger breast. If you are using LD, we have to use a tissue. We have to use an implant in those patients.
So book gives that most of the procedures we have to do symmetrization. So
yes.
when you're doing on the like CA breast patient you have operated, whether you do augmentation or reduction mammoplasty in the opposite breast?
In case if there are huge breasts who patients are not happy with their opposite side breast, we can do a reduction.
Okay.
Smaller breast undergoing a reconstruction on the opposite side, we can do augmentation, correct both the sides. That is also one of the most commonly done.
So, can I know this statistical data to Western countries compared to Indian country,
Sir,
India like this?
India again, metros, yes, many people are opting nowadays for reconstructions.
Specifically our area where you are practicing, what whether patient demands or
in
not?
last 5 years, 7 years, 2017 to 24, we did some 6 cases.
There's,
not many people are coming. We are trying to push.
Yes, sir.
They are not coming.
Thank you.
If there are no more questions from the audience, I conclude this session. Thank you, Amrish, once again. And call upon the anchor.
Thank you, sir. I request Dr. Ajay Devni, sir, to please come and felicitate
Dr. Amrish Biradar, sir. I now request Dr. R.G. Devni sir to felicitate our chairpersons.
Dr. Sangmesh sir, Associate Professor, JIMS Gulbarga. Dr. Mohsin Ahmed sir, Professor, Department of Pharmacology.
Dr. Amul Patange sir, Professor, Department of Psychiatry.
Dr. Sunil Kumar sir, Associate Professor, General Surgery, ESIC, Gulbarga. Thank you, sir. I thank the chairpersons for chairing the session.
I now call upon my co-intern to continue with the session.
Thank you.
Good afternoon.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ.
Assalamu alaikum.
ವಣಕ್ಕಂ.
Sasriyakal sarenu.
I, Dr. Ragini, intern, Department of General Surgery.
I, Dr. Prajwalita, intern from Department of General Surgery.
We welcome you all to this beautiful afternoon.
It gives me immense pleasure to extend you all a very warm welcome to each one of you on behalf of Department of General Surgery, Faculty of Medical Science,
who has clubbed all of us for the continuing medical education in breast disease update.
I would like to request chairpersons to come over the dais and please occupy their seats.
Dr. M. Sharif Beg sir, Professor and HOD, Department of Biochemistry.
Dr. Nazir Ahmed sir, Dean, Student Welfare, Professor and HOD, Department of Anatomy.
I now welcome our beloved sir. Sir, you hardly need any introduction. You have made all of us proud by your distinguished work in numerous capacities.
The man of distinct vision, a fountainhead of illuminating ideas, an ideal of knowledge and experience, and inspiration to all of us.
Dr. Muhammad Moinuddin sir, Professor and HOD, Department of General Surgery, KBN University, Faculty of Medical Sciences. I call upon sir to present us on rare breast cases.
We welcome you, sir. Sir has completed his undergraduation and post-graduation from VMCC, Sholapur.
A small man from Solapur came to Gulbarga on 1st January 1987.
Sir started his career as general surgeon in 10-bedded Aminabai Hospital and from there became the founder member of the team which started as KBN Medical College.
Yeah, since, sorry I have interrupted the our host because we are running short of time. As a last batsman, I would like to conclude post-lunch session. I'll just be very brief. Dr. Nandkishore and Dr. Basi told me that I should be brief. First slide, please. I'll be giving a glimpse of overall view of rare disease in the breast. Next, the disease spectrum. All diseases in the world can be classified under this spectrum. This is a special KBN spectrum which we have created for our students, and I keep on telling whatever disease, whatever discipline you are, whether in surgery, medicine, gynec, every disease which is present on the planet Earth can be classified into 5 broad categories. Next. This is the disease spectrum. We divide the basic is congenital and acquired. Down below, it should have been on the reverse way. So whatever diseases are there, they are either congenital or acquired. And acquired we have made 4 subheads. One is the big section is the trauma. Second is infection and infestations. Third is a neoplasm. Fourth is degenerative. And fifth is autoimmune. So any disease if you pick up, I teach my students, you can classify into, suppose you pick up a hydrated disease, it can go into infestation. If you know fibroadenoma, it will go into the neoplasms. So that is how you teach the students. Next, congenital disease of the breast, accessory breast, absence of nipple athelia, multiple nipples, unequal breast. Next, see this is the known as mammary line, which we are taught in anatomy. It extends from the axilla, goes up to the medial side of the thigh. So breast can be present on any one of these areas of this, which is shown in the diagram. Next. These are accessory breasts in the axilla. Next. Athelia and amastia, a very rare condition but very depressing condition for the person, so that now we will have to take Amrish brother's help. So reconstruction is very often by either implants or by flaps. So this can be now tackled. Next. Anosmia, that means there can be unequal breasts or absence of breast on one side. Next. Multiple nipples, polythelia, again a depressing condition. Again we require a plastic surgeon or a general surgeon to remove the extra nipples. Next. Now coming to the infection and infestations. Now a rare disease which is infection which is missed is the hydrated disease of the breast. We send the patient for radiology, we find the disease, report as a cystic lesion, and then we will have to keep hydrated is one of the possibilities, because in our place we have encountered one hydrated disease case. Next. Yes. There can be acute infections which are not very rare. Mastitis is there. Of this, I will just run through. Next. These are various stages of disease: mastitis, passage disease of nipple. Next. This is one important entity. This is probably a series which we are working at our medical college. We have already gathered 21 cases in the last 3 years, where tuberculosis of the breast is the diagnosis. Most of them are not diagnosed on FNAC. About 50% we picked up on FNAC only, suspicious granulomatous lesion. And when we sent the patient for biopsy, it came as a granulomatous lesion. Then we had to do Montauk's and Gene Next and other things, and we established the diagnosis. But there were situations where we were in a country, we were not able to establish the diagnosis in the absence of a primary disease in the chest. There was one patient who had a lesion in the arm, and then we biopsied. I showed to Sachin Shah, I said, okay, that's a granulomatous lesion on the arm. Why she got, we biopsied it, it was a tuberculous lesion of the humerus. And then she simultaneously had a lesion in the breast, that also was primary tuberculosis of the breast. So this is a very common entity nowadays we are facing once we tackle benign disease of the breast. 21 cases in 3 years, I think, is a significant number for a small area like our medical college itself. So the Department of Surgery. So Dr. Nankishore and myself are working on the paper for this. But this is the rare entity, but nonetheless it's a very common entity in our area. Next. Yes, carcinoma of breast has been dealt with at length. Next. I'll just talk about inflammatory carcinomatous mastitis. Next. Cystic disease I've already told you. Next. Next. Yes. These are all common cystic diseases. The blue dome cyst and all these days we don't get because of the advance in the technique and the awareness of the people. We get people getting ultrasound done very early, come to us, and they are treated. Next. Next. Yes. Next. No. Next. Next. Yeah, the cystosarcoma phyllate tumor getting malignant is a rare condition. We had one such case in our place. We excised it thinking a benign tumor. The report came as benign tumor in the first place. Then the patient had recurrence in 3 months. We did another excision of that tumor, again reported as benign. Then she came with an axillary mass and a huge tumor. We excised the whole thing like a modified radical mastectomy, sent for histopathology. Then it came as sarcomatous changes in the lesion. By that time, the patient was moribund. She had already had secondaries in the lungs also for that, unfortunately. Right, next. Adenoid cystic carcinoma, another rare variety. Pathologists will dealt with in the morning. Next. Papillary benign breast carcinoma. Next. Colloid carcinoma. These are some of the various, for the sake of students, secondary carcinoma of the breast. Secondary carcinoma of the breast, yes, we commonly ask as a postgraduate question for the students, where do we get from? Then we can have from the ribs, primary in the rib, and sarcoma, chondrosarcoma giving secondaries in the lung, or lung cancer metastasis in the brain. I think, thank you. Thank you for patient listening. Thank you one and all.
Mic. Give the mic.
Any questions? If you want, they cannot ask the questions. Thank you.
Thank you, sir, for your valuable information and precious time.
Now I request Dr. Anup Desai, sir, Associate Professor, Department of General Surgery, to felicitate Dr. Mohammad Moinuddin, sir.
I request Dr. Anup Desai, sir, to felicitate our chairpersons, Dr. M. Sharif Beg, sir, Professor and HOD of Department of Biochemistry.
Dr. Nazir Ahmad, sir, Dean, Student Welfare, Professor and HOD, Department of Anatomy. Because of shortage of time, panel discussion has been matched with case presentation by PGs. Thank you for your cooperation and patience.
Good evening, everyone. I, Dr. Preeti, intern from Department of General Surgery.
And I, Dr. Prajwalita, intern from Department of General Surgery,
will continue with the event.
On this pleasant evening, it's my privilege to invite chairpersons to please come forward and to be seated on the dais.
Dr. Mohammad Moinuddin, sir. Dr. Gururaj Deshpande, sir. Dr. Sharan Basappa Hatti, sir. Dr. R.J. Devni, sir. Dr. Amresh Birada, sir. And Dr. Sangmesh, sir. And Dr. Arun Bharat, sir. May I now request our moderators to please come for case presentation by postgraduates. Dr. Nandakishore Shinde, sir, Professor and Pediatric Surgeon, Rajiv Gandhi University of Health Science and KBNU University. And Dr. M.A. Basir, sir, Associate Professor, Department of General Surgery, to please come on the dais.
Sir did his MBBS from KBNIMS and DNB.
I now request Dr. Pallavi ma'am and Dr. Sudesha ma'am from MRMC to please come forward for case presentation.
Abhijit, postgraduate from JIMS Gulbarga, to please come forward on the dais.
From MRMC Medical College, final year postgraduate. We are here presenting, me along with Dr. Pallavi, will be presenting a case of CA breast, lump in the breast. Here is a 60-year-old female, Mallamma, resident from Yadgiri, who's a housewife, came with a complaint of lump in the right breast since 1 year. Patient was apparently all right 1 year ago when she noticed a lump in the right breast in the lower outer region, insidious in onset, initially a size of a marble. Gradually it has progressed to a size of a large lesion. large lemon. There is a history of recent increase in the size of the swelling since 3 months. There is a history of nipple retractions since 6 months. No history of pain, no history of nipple discharge, no history of trauma. There is no history of bony pain like lower back pain, pain in the hip, neck or shoulder pain. No history of yellowish discoloration of the eyes or abdominal distension. There is no history of breathlessness, hemoptysis, chest pain. There is no history of headache, giddiness, vomiting, seizures. There is no history of loss of appetite, loss of weight. There is no history of irradiations in the past over the chest. No history of lump in the opposite breast, swelling in the armpit or elsewhere. Coming to past history, there is no previous history of breast surgeries in the past. There is no history of hormonal replacement therapy intake, not a known case of diabetes, hypertension, bronchial asthma or TB. Coming to personal history, diet is, she is a vegetarian, appetite is normal, sleep is undisturbed, bowel and bladder habits are regular, there is no habits. Coming to menstrual history, she attained menarche at the age of 13. She had a regular cycles, 3 to 4 days flows, and she attained menopause 12 years back, that is at the age of 48. Married life of 45 years, she got married at the age of 15, and her first childbirth is at the age of 17. She had 4 children, all were full-term normal vaginal delivery. All children were breastfed more than 1 year. There is no history of similar complaints in any first-degree relatives in the family.
What's your diagnosis based on history?
Sir, since from history, she is a 60-year-old female patient with giving a painless lump in the right lower quadrant since 1 year with a history of nipple retraction. I would like to give a probable diagnosis of malignancy of breast, sir.
See, one thing in the history of presenting illness, just go back to that slide, you are telling that there is a history of nipple retraction and all that. Okay, this particular point, that history of nipple retraction, as such patients will not come to you with a complaint unless or until you put in some leading question. Okay, so better would be that if she patient has told you, it's fine, or else you can put it in the point like on inquiry, patient also gives that there is a history of nipple retraction and all that. Okay, so that is one thing. And in your history, just go to the next slide. I've written something about no history of previous surgery. Why did you ask for that? No history of previous surgery, breast surgeries.
Recurrence, sir, in case of recurrence.
What recurrence? Recurrence of what?
Previous malignancy if she had in the opposite breast or...
Okay, let me come to the first question that I asked. History. You want to give only one diagnosis based on history?
Yes, sir.
It can't be benign at all with the history that you have got.
Sir, her age is 60 years old.
So what? So what?
60 years is the age where malignancy usually occurs.
No, usually, right? You are telling usually, but it can be rare also. Why do you want to stick to only malignancy? Because you know the diagnosis, right? So
there is a recent rapid increase in the swelling.
My point is, you should not, at the end of history, you should not stick to one diagnosis. Okay? You can say, most probably it looks like a malignant. It could be benign also. Then you will be balancing yourself.
Do you mean to say that any 60-year-old woman with a lump and retracted nipple are all malignancies? Is it your conclusion?
No, sir. Most commonly it will be...
So always better would be a differential diagnosis. In the order of preferences, you give multiple diagnosis, differential diagnosis, with CA breast being on the top.
See, CA breast is always a long case. So don't go with the biased thing that, okay, I've got, what case are you presenting? I'm presenting a case of CA breast. Don't do that. I'm presenting a case of lump in breast. So if you go with that approach, then you will have more differentials. If you think that I am presenting a case of CA breast, your mind will not think of apart from anything except CA breast. So that is what everybody is trying to come out with. Okay.
Can there be any benign cause for nipple retraction?
Sir, ductectasia can cause nipple ductectasia.
Okay. Then can there be a presentation of lump also? It could be two different things.
Sir, I didn't get the...
The lump is there. It could also be a benign. There could be a nipple retraction which could also be a benign. Can this happen?
Just now you heard a talk on rare diseases of the breast. You should have picked one of the factors.
That's the reason.
Yeah, one of the factors. See, whenever there is a question of diagnosing on history, we just make a provisional diagnosis. As sir was telling, you should have 1, 2, 3. Even if you know there is a carcinoma of breast, you should also know alternative, traumatic fat necrosis, tuberculosis. This should be at the back of your mind when you are presenting. Secondly, nowadays I find students are in the habit of no history, where the one factor was the no history of vomiting or headache, etc. That means directly you are thinking of secondaries in the brain. So, see, examiner knows that you know all these things when we ask, but so much of negative history, if you go on asking and putting into the history, a small positive history and a lot of negative history should not be there. What's the opinion?
As sir told, overall in the history of presenting illness, negative history has taken a major part. So that can be avoided as sir told. And another question as Dr. Sangmesh has raised, what does the previous breast biopsies implicate? Suppose someone had previous breast biopsies 10 years back, 15 years back. What does it implicate? What are you deriving from that history?
It was a benign disease and patient has developed malignancy in a benign disease.
So previously 10, 12 years back, suppose the patient has had biopsies and that has come as benign. So how does that affect the history? So previous breast biopsies?
Could it be related or not related? It could be a de novo disease. Previous was benign. Now this could be a de novo disease. Yes.
So any previous breast biopsies is also a risk factor for CA breast, isn't it? So you have read that among the risk factors of the CA breast, previous breast biopsies with the histologies like atypical hyperplasias, lobular carcinoma institute, they are a risk factor.
What is the pathogenesis of nipple retraction?
Sir, because of involvement of the horizontal and circular fibers of the nipple, sir, nipple slit-like retraction in ductectasia. In malignancy, there will be a circumferential retraction, sir.
Okay, proceed. I think we'll allow them for examination.
Sir, question to the panelists, sir. Like the differential diagnosis, the candidate has said about the diagnosis as a malignancy. The second question was asked like it can be a different diagnosis. And the second differential diagnosis is going on basis of benign conditions. Is it possible in an exam to say one as condition as a malignancy and second diagnosis as benign condition?
See, we are contemplating what is the possible lesion. We are not contemplating whether it's benign or malignant. So carcinoma of disease is one entity, traumatic fat necrosis is another entity, tuberculosis is another entity, retraction of nipple primary causes another entity. So these are all the 4 diseases.
Sir, no sir. My question is like in exam, first diagnosis you are given as possibly malignancy.
Yes.
Second diagnosis can be given as benign?
Yes. As far as.
At the end of history, it is acceptable. At the end of, because you have not finished your case yet, so all the possibilities are acceptable.
Yeah. See, for all the students who are postgraduates and other undergraduates also, history, provisional diagnosis, clinical examination, clinical diagnosis, investigations, confirmatory diagnosis. So that is the stages of evaluation of diagnosis. So you make a provisional diagnosis, then at the end of examination you make a clinical diagnosis, give a battery of investigation, and come for confirmatory diagnosis and get a histopathology, that is final diagnosis. So this is the evaluation.
So in examination, they will not accept telling malignancy and again coming back to benign. You have to stick on either to malignancy or benign with your history and your examination and diagnosis.
At the end of history, you can give a wide range of differential diagnosis, and we can explore all the diagnoses. As you complete your examination part, then you narrow down to a few more.
Even if the examiner asks you, why are you thinking it could be benign, you should justify. Why you are thinking it is malignant, you should justify, because it is at that moment what the examiner thinks. Okay, it can go to a lot of leading questions also. But you should be able to justify why you are thinking on both the sides. Fine? At least one point there. Sir, it could be. Fine?
So in this case, as sir has said, like what could be the possible condition in which the patient is pointing towards the benign condition? Any history which suggesting that the patient, this swelling could possibly be a benign one.
You should never utter anything just for the sake of mentioning it. Okay. As far as you can defend it, you can tell anything. That's what Gurraj sir was telling. Yeah, we will proceed. Sir, you asked something?
They didn't understood mostly, sir. Yeah. Is there any history which is suggestive that this swelling could possibly be a benign one?
The swelling is since 1 year, sir.
Yes, exactly. Yeah.
And
so when if examiner says, how can you jump from malignancy to benign, you can use this as defense, what sir is hinting.
Good answer. Very good answer.
General physical examination. Here is 60-year-old female who is moderately built and nourished, well oriented to time, place and person. Her vitals, blood pressure 110 by 80 mm of Hg in right brachial artery in supine position. Pulse rate is 80 beats per minute, good volume, regular rhythm. Respiratory rate is 16 cycle per minute, temperature febrile. Head to toe examination, hair distribution normal, eyes clear, conjunctiva is pink, oral cavity, tongue moist and pink, gums, gingivobuccal sulcus, mucosa, buccal mucosa, facial pillars normal, no pedal edema, no cholinicia, no sinuses, clubbing, no generalized lymphadenopathy. Local examination. Patient is examined with prior consent in broad daylight, exposed from neck to the waist, examined in the following position: arms by the side of the body, patient in sitting position, hands over the hip, alternating contraction and relaxation, arms raised above the head, bending forward and supine position. On inspection, right breast in sitting position, bilateral asymmetrical breast, right appears smaller than the left, right breast displaced upwards and laterally compared to the left breast, dimpling, puckering noted over the lower outer quadrant, no engorged veins, no pudiorange, no nodules, ulceration or fungation noted. Nipple, right nipple is deviated upwards and laterally compared to the left. Right nipple retracted and visible at 7 o'clock position in the right breast. No discharge noted from the nipple, no cracks or fissures. Areola is brown in color and asymmetrical, no cracks, fissures, eczema or ulcer noted. No swelling in the right axilla, no edema in the right arm, no fullness visible in the supraclavicular region. With arms raised above the head, no pudiorange noted. With leaning forward, right breast does not fall equally as compared to the left breast. So these are the images of the lesions.
Same patient?
Yes, sir, same patient.
We are not feeling like you have described this patient. If anybody disagrees with me? Nothing, no. You are totally out of track. If you are...
Sir, 1 minute, sir. Sir, 1 minute, sir. She started saying about the position and she started explaining about the positions. Rather than saying that case, she could have continued with the inspection examination. Then you could have talked about the positional changes. That could have been a better way, because the moment you started saying about the positional changes, you are missing the major important clinical examination points.
Okay,
Inspection
do
point
one
you are
thing.
missing.
Go back to the photo. Yeah, now describe.
You start with inspection, then positional changing.
Previous
how you
photo.
start.
Previous. Yeah. First photo.
Yes. Patient examined in sitting position with arms by the side of the patient. On inspection, the right breast, bilateral breast asymmetrical. Right breast is displaced upwards and laterally. There is no engorged veins. Nipple is noted at 7 o'clock position. There is no, and on supine position, sir, we are able to see the
Listen. You are going somewhere else. The positive points which are there has to be said first, right? Nipple areolar complex, displacement, scar. Okay. Then the come about the volume, both sides, any changes are there. Then the next thing will come. Otherwise, it's looking like you're doing something else.
dimpling and puckering noted, sir. Yes.
Is it?
So that
it is more prominent on.
Level of nipple will be seen by raising the arms.
Level of nipple is also noted, sir, and
Then you didn't mention that.
nipple is not visible on inspection, sir. When
But
we
at least there is something which is there. Inspection it is not seen.
at 7 o'clock position.
Then you told it is at 7 o'clock position.
Nipple is visible, sir. Whole of the nipple
level
is
of
on a
nipple
complex.
First you tell me why the pure orange is seen.
Purity orange is seen when there is involvement of the dermal lymphatic
Yeah.
vessels, sir.
So how will they become more prominent on raising the hands?
No, sir. Dimpling and puckering is when the involvement of the ligament of Cooper's is there, sir.
What is tethering?
Tethering is when the tumor is involved to the, on palpation, tethering is seen, sir. When the swelling is held and it is moved, there will be, tethering is a palpatory finding. Dimpling and puckering is a inspectory finding, sir.
So as I was asking, on raising the arms, do you see body orange? What could be the reason for volume loss in the right breast? Has she underwent any previous surgeries?
No, sir. No history of previous surgeries.
What could be the cause? There is one variety of breast cancer, scirrhous variety.
Yes.
Scirrhous variety. In that fibrosis will overtake and overall loss of volume will be there.
So to comment on volume also. Okay, as sir was telling.
Yeah.
you said nipple areolar complex was not seen.
Yes, sir. In sitting position on inspection, sir, only we could see the.
You could go on the side and seen. Like even in that the previous image, which you have shown, the previous one, it is seen there.
On raising hands.
Okay.
See, you are postgraduate student, right? You are not a MBBS, final year MBBS. So your presentation should be a concise, matlab comprehensive presentation. Not like everything step by step. A के बाद B, B के बाद C, ऐसा नहीं. Understood? You will be delivering the words, no, not ABCD. You are getting my point?
Yes.
So you should mix up everything and present it as if like you are talking to your colleague. If by description it should be like if the examiner has closed his eyes, he should get a picture or at least rough picture, right?
On palpation, sir, there is no local rise of temperature. It is non-tender. A solitary swelling of around size 5.5 into 3.5 centimeters noted involving the upper lower outer quadrant.
and beneath the nipple areolar complex, which is irregular shape, irregular margins, hard in consistency, uneven surface. Nipple areolar complex is fixed to the underlying swelling. Skin over the lump is not pinchable. Tethering of the skin is noted. The lump is non-mobile within the breast tissue. On contraction of the pectoralis major muscle, the lump was mobile in the direction of the fibers, and on contraction of the serratus anterior, lump was mobile in the direction of the fibers. There is no discharge noted from the nipple.
How do you contract the serratus anterior? I didn't get it.
By asking the patient to push against a wall, sir. That is contraction of serratus anterior, and we try to move the muscle, move the lump horizontally and vertically.
You did that?
Yes.
It was not moving.
It was mobile, sir.
Excuse me, sir. Pushing against the wall, serratus anterior. But in your examination, this thing, positions, that thing is mentioned that the patient is pushing against the wall?
No, sir.
No. You palpation of which breast?
Right breast. Right.
Other thing, you are interchangeably changing two words, mass lump, swelling. What exactly is supposed to be used there?
Lump.
So why are you changing interchangeably? So what is the difference between mass and lump?
Lump is a vague mass of a body tissue, sir, whereas swelling is a protuberance of the protuberance which can be seen.
See, sir has brought out a very important point there. See, at terms you are using swelling, at sometimes you are using the terminology called as lump. Stick to one. Slightly both are different, and it's what we can say, we can go on debating about it. But stick on to, if it is a lump, it should be a lump throughout your presentation. If it is a swelling, you are telling the definition that it is a protrusion. Means we should be able to see that, and there should be an underlying cause. Swelling is a protrusion, or it is an abnormal protrusion of an underlying structures due to any abnormal cause like inflammation and all those things. So see, so you are using at one place lump, at a place swelling and all that. So stick to one term of what you feel so.
Proceed.
Coming to the left breast, sir. Left breast nipple areolar complex normal, no dilated veins, no nipple discharge, no palpable swelling in the left breast. Bilateral axillary lymph nodes were not palpable. Supraclavicular lymph nodes not palpable. On percussion, resonant note heard over the sternum. Systemic examination, per abdomen soft, non-tender, no organomegaly. Respiratory
See,
system.
just for an interruption, don't comment like bilateral axillary lymph nodes not palpable. When you are examining the pathological side, comment on that particular lymph node size. You have to comment on lymph nodes, mobility and pulses and all this. That is LMP, lymph nodes, mobility and any pulsations with regards to. So you have to complete all those, and then you go to the opposite side. Okay, so don't tell in general like bilateral, it's normal. Right side, if there is a pathology, comment on right axillary lymph nodes and all that, and then you can go to left one.
सर ये फर्स्ट नॉर्मल बोलना चाहिए कि abnormal बोलना चाहिए?
Yes, sir. No, this question is for the panel. This question is for the panel to say like which has to be said first.
No, we normally teach our students that considering when you start your examination, after clinical examination, the left breast seems to be normal, the right breast findings are. In one sentence, you are clearing that the left breast, left axilla, is non-pathological. So later on, you need not say no nipple, no discharge like that. So you are on comparing. So you are comparing on the left hand, right hand seems to be, which is the normal.
So
Sir, I will just slightly differ over here. I think it is up to sometimes institutional teaching. Somewhere they will teach like first you would comment on normal side, and some institute they tell that you have to explain the pathology side, and once we are done, just like she has done properly, like systemic examination and all those things are normal. So they, as such, they don't carry much importance, so it can be told in the last also. So there is nothing like hard and fast protocol that this is this or it should be told first.
Yes, so, exactly. It's a chicken egg stuff. It's a chicken egg stuff. So it depends on the examiner's mood. If he says you say this, you say that first.
No, don't be scared. Both are right. Whether you do it in the end or both are right.
It's all
as long as you tell the left breast is normal Either you say in the beginning or in the end, it's okay, but only it's a way of saving your labor. That means.
See, post-graduation exams, your presentation should be so quick and crisp that nobody will catch you in presentation. Okay, your discussion should start after your diagnosis. Only then, like it means that you are doing well. Understood? So it should be like confident and quick and crisp.
Continue, please.
Systemic examination, normal, sir. Parabdomen soft, non-tender, no organomegaly. Respiratory system, bilateral, normal vesicular breath sound, sir. CNS conscious, oriented, higher mental functions intact, no focal neurological deficits noted.
Yeah. Tell me your diagnosis.
Sir, based on the history-wise, sir, since it is a lung.
No, at the end of your presentation, tell me the diagnosis.
Yes, sir. Carcinoma of the right breast with TNM staging of T3 N0 M0, sir, and clinical stage of stage 2B.
See, we had one examiner, he used to catch on this line. What is carcinoma? Define carcinoma.
It's abnormal growth of the epithelial.
You are final year student, right? Second year.
Yes.
She is final year, no? Give her mic.
Both are.
Okay, then what define carcinoma? What is carcinoma? Okay, I will give you a clue. What is carcinoma and what is sarcoma? How do you differentiate them?
Sarcomas are from mesenchymal origin, sir. Sarcomas are mesenchymal origin, sir. It could be from the and carcinomas are originating from the epithelial tissues.
Yeah.
Ectodermal
Yeah,
epithelial.
these things you can make out clinically. It's a histological diagnosis that you are giving, right? So how should be your diagnosis?
Malignant right breast.
Yeah. Okay.
Sir, my this thing is to all the oncosurgeons here, sir. She has not commented on Karnofsky and ECOG, sir. Because right now, recently, the case presentation for postgraduates everywhere, they are concentrating more on Karnofsky scale and ECOG status. So your take on this, sir. What do you want?
Definitely in oncosurgery exams, we were supposed
even
to.
for final year
now,
PGs, they are expecting
because
that.
when
Karnofsky
we used to give exams, like surgery exams, now like sir has pointed it very well, because you are giving a diagnosis of malignancy and treatment, our treatment is mainly based on the performance status of the patient.
Exactly. So what is Karnofsky scale? Next question.
In this, it is 0, sir. ECOG is 0. She's able to perform her daily activities.
So where will you give ECOG and where will you give Karnofsky's? Both are different, right?
Yes.
Yeah. See, in malignancies, which one is expected? Like sir was telling something. Karnofsky's. And ECOG? Okay, what is ECOG? Okay. Illa sir, but final year is very important.
Well, see, that is how that determines if the patient is fit for any form of treatment. Simplest thing is if the patient comes walking into the chamber on his own, that means he can withstand the treatment. Okay, that means his performance score is adequate, that he can bear the stress of the management. Okay, so that's something which you can make out the moment he enters your consultation chamber. Fine?
In the general physical examination, another important thing what recently they are stressing is BMI. Okay, so you can categorize the patient as thin, moderately built and whatever it is. So you need to stress on BMI, or you can just tell her that patient's BMI is so and so. And whenever you are commenting like this of cancer and all that, you need to tell about Karnofsky scale. It's very important.
In your palpatory findings, did you mention about the pinchability of the skin?
Yes, sir. Not pinchable.
Not pinchable. So what does that indicate?
It is not skin. Only macroscopic changes of the skin are used in staging, sir. So it is not T4.
So if the skin is not pinchable, clinically what does it indicate?
Tumor is adherent to the skin.
Adherent or involved?
Adherent.
Not involved.
How is T4 described? That's what
T4B is when macroscopically we can see ulceration, satellite nodules, fungations. That is T4B, sir. And T4A is involvement of the chest wall and the pectoralis major, minor. Not involving pectoralis major, sir. Involving the chest walls. Chest wall involves serratus anterior intercostal muscles, sir. Ribs.
Minor?
No, sir.
Sure.
Proceed. Management.
Sir, routine investigation, sir. First, triple assessment, history and physical examination, then radiological investigations, USG of the breast and the axilla. Next is true cut biopsy to be done, sir, to know for the hormonal status.
Why do you want to go for true cut biopsy, not FNAC?
True cut biopsy helps us to know whether it is immunohistochemistry and also to know whether it is an invasive disease or a non-invasive disease. Better made out in true cut biopsy.
Please remember that nowadays, I think for malignancy, FNAC is totally outdated, sir. We are always preferring true cut.
True cut biopsy.
Okay, FNAC, FNAC, nobody is doing it now. Still the age-old teaching and the professors keep teaching and that FNAC, but wherever there is no facility for true cut, it is FNAC. Otherwise, true cut is the line of investigation when we speak of triple assessment. Okay, what gauge needle do you use for true cut?
18 gauge needle.
So you should also add a point that FNAC lacks sensitivity. There are possibility of more false negatives, that is up to 20 to 25% are false negatives. That is also a very valid point you should tell when they ask why not FNAC.
So all the postgraduates, remember we are not doing, or FNAC is not that informative, it is true cut biopsy. Okay.
When do you say triple assessment is negative? And when do you say triple assessment is positive?
On clinical examination, we have found a lump, sir.
What is triple assessment? She told, I suppose. What is triple assessment?
Triple assessment, first is history and clinical examination, sir. Second is the radiological examination. Third is pathological examination.
What on radiological examination?
USG or mammogram can be done, sir.
USG or mammogram?
Is it sonomammogram or?
Sonomammogram.
In this patient, you want to do a sonomammogram or mammography?
Sonomammogram.
Share something on her also.
Mammography.
Give her. Huh?
Mammography.
Why mammography? Why not sonography? Sonography is not advocated in such patient?
Sir, sonography is ideally done in dense. Sonograph is ideally done in dense breast, and here breast tissue will be very lesser after 40 years of age, ideally. So mammography is preferred, sir.
Okay.
But have you seen a report of mammogram?
Yes, sir.
Have you seen in that they do both of them?
Yes, sir.
They do a radiological examination and a serological examination and then give a comprehensive report.
Yes, sir.
That's a better answer, I think.
Okay, sir.
See, both the things can be done. See, there are some things which are picked up. Some calcifications can be picked, some vascularity can be picked on a sonogram. Okay, both the things together gives a better understanding of the disease.
In triple assessment, what is involved? Sonography or mammography?
Sir, both, sir.
Both or either? Like that. Okay, I was asking you, when do you say triple assessment is positive and when do you say triple assessment is negative?
Sir, clinically we are able to palpate a lump. Then radiologically also it is seen, whereas in pathologically it is benign.
In that case?
Triple S, sir, in that case we have to annually full.
Okay, I will directly tell what I want to tell you.
Okay,
so triple assessment, to call it as positive, any of them, one of them, one of the three is positive, then it is positive. You have to work up further to either rule out or to prove, right? Negative is, you can call it negative only when all the three are negative.
Okay, sir.
Understood? To call it positive, one vote is enough. To call it negative, all the three votes should be negative.
One little suspicion should be.
You understood? So
So
clinical suspicion is there, sonography and FNSC or Krukut, whatever they are selling, it's non-malignant, clinical suspicion is there, you have to do a excision biopsy. Only in such cases, lumpectomy is done.
Okay,
When you are suspecting, only when Krukut biopsy and radiological are telling it's a non-malignant. Okay? Only in such cases, you have to do a lumpectomy. Otherwise, there is no reason for doing lumpectomy when you are suspecting it to be malignant.
So this patient has come to you, you have finished your examination. What is the first thing you want to do as a part of investigation? Is it true cut biopsy or imaging?
Sir, ideally imaging, sir.
Imaging.
What you want? Imaging.
Why you want to do first imaging first?
Sir, if we take biopsy, then it will alter the image study, sir.
Correct.
Continue.
So what are the investigations for this patient? What you have done?
So we have done routine investigations. After that, ultrasound with mammogram is done for this case, and true cut biopsy, and USG of the axilla is also done to see.
So USG is done, true cut biopsy is done. What is the result?
Sir, it is showing 5 cross 5.5 cross 4.3 centimeter lesion. It is present over the inner upper.
Right. What is true cut biopsy result?
Pardon, sir?
True cut biopsy.
True cut is showing invasive ductal carcinoma.
So next, what you want to do?
Sir, modified radical mastectomy.
Directly you will go
You
for
heard all
surgery.
the talks today?
T3 and pardon, sir?
Did you hear all the talks today?
Yes, sir.
Abhi bhi aaye. Oh.
Will you do a metastatic workup for the patient? Will you see where else the tumor has gone?
See, any malignancy case, not only breast, any malignancy case, if you are presenting in the exam or you feel it is this thing, you always do a metastatic workup for that patient.
Okay.
That is the where you go like first baseline investigations and investigations to confirm your diagnosis, investigations to work up the patient from surgery point of view. That is indirectly you will do something called as metastatic workup.
So you are told in your diagnosis that it is M0.
Yes.
So only by history you are confirmed that it is M0, or do you want to evaluate whether it is really M0?
Sir, we have to do USG abdomen, X-ray of the lumbar vertebra, chest X-ray.
What does the guideline say for a T3 N0? Don't you want to do PET scan? Whole body PET CT? For a T3 N0, is it advised, is it recommended?
Sir, it is T4B. It comes any ulceration, any satellite nodules, or purity orange as T4B, sir. Skin involvement.
Edema also, no? Skin edema.
Skin.
Yeah, sir.
Just now, Arun sir was saying, after your HPR report, I mean biopsy report, invasive ductal carcinoma, he was asking what we will do next. He had something in mind. What we will do with that sample again? Any further tests on the sample?
Immunohistochemistry, sir.
Ah.
IHC.
Talk loudly.
IHC will be done, sir.
Yeah, what IHC?
Immunohistochemistry, ERPR status, and HER2/neu status will be seen, sir.
Yeah.
What else? What else?
One more.
KI67, sir.
Okay. So you have done metastatic workup. It has come negative. Your ER is positive, PR is negative, HER2 is positive. What else you will do next?
Sir, after modified radical mastectomy, we can start on hormonal treatment.
So before doing modified radical mastectomy, as Dr. Sangmesh sir told, don't you want to do a pre-surgical workup?
Yes, sir.
Whether the patient is fit for surgery or not? Go in order. You are more inclined towards modified radical mastectomy after seeing Dr. Gurraj sir's presentation.
Definitely you will do surgery.
But why so hurry to do surgery? You work the patient, no? Malignancy will not increase in 2 days or 3 days.
In
You
other
define
words-
what you are doing.
Other
Got it.
words, which are the indications for the patient to go for PET CT scan or bone scan?
What are the indications for PET CT scan in CA breast?
For bone scan, when the patient is symptomatic, sir, or if ALP levels are raised, sir, or it is T3N2 M0.
And sir is asking about PET scan.
So does this diagnosis of yours fall into the category of LABC?
Still stage 2B is early breast cancer, sir.
So it's still stage 2A is early breast cancer. 2B is not considered early breast cancer.
See, the recently guidelines have changed. I think everybody should know what sir is trying to tell, that stage 2A and 2B. You all are just know ki only stage 2 and then start with 3A, B and all. Recent AJCC states there is sub further classification. Yes? Okay, so there is the classification, the age-old teaching of up to stage 2. We knew only 2. Now 2 is further divided into A, B, then 3 and all that. So what sir has rightly pointed out. So as per recent AJCC, up to 2A, that's what sir was telling. Sir, please.
So this falls into the category of LABC. So definitely PET scan is indicated in this case. How is PET scan done? When you are writing a prescription for PET scan, how will you write? What will you write?
How does it differ from CT scan?
Sir, 18 FTG is...
Talk loudly.
Yeah, talk
Louder,
loudly.
louder.
Talk loudly.
Sir, 18 FTG is injected and
What is the rationale for using 18 FDG?
sir, glucose uptake will be more in case of largely proliferating tumors.
Okay, that's it. Going back to cell cycle and metabolism, listen. Malignant cells thrive on glycolytic pathway, not on Krebs cycle. Okay? Their ATP requirements comes from the glycolytic pathway. Because as the tumor increases, the vascularity of the core of the tumor reduces. So there is no oxygen reaching to the core of the tumor. When there is no oxygen, Krebs cycle will not happen. There will only be glycolytic pathway. Glycolytic pathway uses FDG. Okay, that glucose gets replaced by FDG and it gets accumulated there. It is not further broken down. And nuclear tagged FDG, that is 18 FDG, is used so that it can emit gamma rays which can be picked up by the counters. Fine? This is an important. Why are you using that? What is the metabolic? There is a metabolic scan. Okay? And they superimpose it with a CT scan. So that first it gives only metabolic picture, then when they superimpose with the CT scan, it gives anatomical as well as metabolic picture. Fine? Sir, if I am wrong, correct?
Correct, thank you.
Yeah, see, just this patient, hypothetical situation, this patient, you worked up everything and just you wanted to send her to PET scan. Before PET scan, she had a convulsions, one episode of convulsions. So you suspect something might be there in the brain mets. But they were on the way to PET scan. They finished the PET scan and come. PET scan is normal. Do you still suspect brain mets? Did you understood what I asked? Yeah.
What will you do next? What sir matters? If your PET scan is normal, patient is having convulsions, what will you do next? Is there any other way to find out that PET scan has missed something? Sir.
Another question is, another way of asking is, does PET scan pick up the brain mets? Okay. He is also final year. You are also free to answer.
So if the patient is not affordable for PET scan and she says that she will not go out of Gulbarga as there is no PET scan here, so in place of PET scan, what else you want to do as a part of metastatic evaluation?
See, whole of the X is available in MRMC. Whatever sir is asking is available in MRMC.
Indirectly it is. When will you do certain other special investigation when PET is not available?
MRI, sir.
Patient has convulsed in front of you, you have stabilized him, what else, what investigation you want to do?
See, unless you talk loudly, nobody can hear you.
MRI, sir.
You are telling this for fourth time, I suppose, right?
So in place of PET scans as a part of metastatic evaluation, what else we will do? The other way of asking this question is, what are the most common sites of metastasis in a case of CA breast?
Sir, CA breast, lymphatic metastasis is more common, sir, to the supraclavicular opposite side also. And through the Batson's venous plexus, it can go to the lumbar vertebra.
Just now I told you something. Don't utter anything just for the sake of saying, right? You said, I will repeat what you said. Sir, in CA breast, lymph node metastasis is more common, sir. Supraclavicular lymph node and opposite supraclavicular. How many opposite supraclavicular lymph nodes you have seen? At least we have not seen almost none. Yeah, see, sir, Devani sir has not seen anyone. Huh? Don't utter just like that. Talk confidently and talk whatever you know.
Sir, metastasis is more common to the lumbar vertebra, sir, then femurs, then ribs, thoracic vertebra, liver met.
So why is it more common to lumbar vertebra?
Sir, because of posterior intercostal veins connects with the valvulus Batson's plexus, sir. So when the patient is coughing or sneezing, the cells can embolize and go to the lumbar vertebra. So more common in the...
So second most common organ for metastasis?
Next is the liver, sir. Femur, bone and then...
That is bone metastasis. Next common organ for metastasis?
Lung.
I will slightly interrupt here, sir, now. Okay, if you have done this metastatic, okay, we will go to the next stage since sir is telling there is paucity of time. Okay, you have done a metastatic workup. What next? What next you want to do now?
Your final stage is T3, N0, M0. And ERPR status positive, HER2 negative. What you will do?
Sir, neoadjuvant chemotherapy, sir. HER2 for that trastuzumab has to be given along with neoadjuvant chemotherapy cycles and then...
You are doing MD or MS?
You are a surgeon, no?
Sir, they are confused because first you said don't operate. Why you are running behind surgery?
No,
Now
there
when
are
they are
two
saying
types of-
medicines, you are saying why you are not operating.
LABC have got two types of LABC. Right? What are those?
Sir, large operable and inoperable.
Operable LABC and inoperable LABC. So in operable LABC, when do you operate? When you are, especially if you think that chemotherapy is not going to work. Okay? Triple negative, you know what is triple negative, right? Only such patients, operable, even if it is operable LABC, we have to subject for chemotherapy. Understood? So this patient, even one of us said that don't operate, you should stick. Right?
Please be louder, huh, both of you. In your exams also, please practice that, speaking loudly.
Sir, answers also, sir. Like why the PET CT doesn't pick up brain mets?
Sir, so brain consumes glucose, isn't it? So when you do PET CT, when you inject FDG18 tagged glucose, it goes and deposits in brain as well, and it is very bright on PET CT. Any metastasis which is there in the brain will not be picked up because overall the brain will be very bright.
So second, the operating LABC. Which are the LABCs which are operable? Sir, I want answer from panel, please. They are not able to answer, sir. Operable LABCs, sir. Yes, sir, please.
See, now I think the guidelines have changed because before we used to classify between operable LABC and inoperable LABC. So Clear cut, it was like any lesion limited to breast, not involving the muscles, was operable LABC. But now, since the guidelines have changed, any LABC will require neoadjuvant chemotherapy, LABC, especially when it is TNBC or HER2 positive. The first step is neoadjuvant chemotherapy.
Thank you, sir. Thank you so much. We'll start with that because again, it's again breast case only. So we can have the remaining part of the discussion in that case, sir.
Modified radical mastectomy. Nipple.
You don't shake that one. You keep it here, there only. If you are moving it, then it will make a sound.
Sir, the breast, the right breast tissue is already smaller in size, sir, and the tumor is comparatively larger in the breast.
One more thing, because our plastic surgeon is sitting here, so the post chemo RT. So you have, this is LABC. We are planning for chemo RT followed by surgery and reconstruction. What reconstruction? Immediate reconstruction is expected, or you want to wait for full chemotherapy to be done, then go for reconstruction.
Only chemo is there, yes, immediate. If you are planning radiotherapy, it's delay.
In this case particularly, sir.
Yeah.
Those with yes, sir. Sir, T4B onwards, sir, and neoadjuvant, and then downstage the disease and onwards.
Sir, we'll curtail this one. Next case, sir. The one person who is sitting in the audience and hitting sixes, we call that person on the stage. Sir, please, Tanvir sir, come on the stage, please, sir. Sitting, he's Dr. Tanvir Ustad. I think you know Ustad family, right? So, and one more thing is, he's a famous urologist, a dynamic personality. Even though he's a urologist, he has very much interest in breast. So, he's a urologist which gives urological touch everywhere. Welcome, sir. Second.
You introduce yourself.
Good afternoon, everyone. The panel members and the jury and the delegates and my friends and colleagues and juniors. Myself, Dr. H.M. Abhijit, postgraduate from Department of General Surgery in JIMS, Gulbarga. Surgery of Gulbarga Institute of Medical Science. Here I will be presenting the case of lump in breast. Next slide, please. We had a patient, B, wife of Mr. H. She is a 67-year-old female who is a housewife hailing from Gandhi Colony of Gulbarga. She came with us to achieve complaints of a lump in breast from since 2 months and wound over the right breast. Since 1 month. Patient was apparently all right 2 months back. She noticed a lump in her right breast which was insidious in onset, which she noticed while she having a bath, and which was rapidly progressive, which was initially a size of a lemon and progressed to the current size. Patient also had a history, gives a history of wound over the right breast since 1 month, which was insidious in onset, gradually progressive, initially of a small size and progress to the current size.
Hello.
And she also gives it is associated with a bloody discharge from the wound. And on further inquiring the patient, on probing, she said there is a recent retraction of the nipple was present, and she had a recent loss of weight and appetite. Upon probing the negative history with the patient, she gives no history of nipple discharge, no history of fever or pain, or no history of swelling elsewhere in the body and in the opposite breast. She doesn't give history of back pain, headache, cough, breathlessness, or no history of taking OCPs or any radiation exposure. She is a known case of diabetes and hypertension, and she was on irregular treatment for the same. In past history, she is a known case of leprosy, and she completed the treatment for the same 10 years back. Other than that, she doesn't have any complaints regarding to the breast. No family members in her family had similar complaints regarding to the breast. On personal history, she had mixed diet, appetite reduced, bowel and bladder habits are regular, and sleep was adequate. On menstrual history, she attained her menarche at the age of 14 years and attained her menopause at the age of 47 years. Upon obstetric history, she is a para one, living one, alive one. She breastfed her child for 1.5 years, and she buried her first child when she was of 25 years of age. On personal history, she had adequate sleep, appetite reduced, bowel and bladders are regular, diet mixed, and no habits. On examination, she was examined in the broad daylight after getting a verbal consent from the patient in the presence of female attendee. She was examined. She happened to be conscious, cooperative, well-oriented to time, place, and person. She was moderately built and nourished. Her BMI was 24.8. On examining the vitals of the patient, she was afebrile. She had a pulse rate of 88 beats per minute. Her blood pressure was 170 systolic over 88 diastolic millimeter of mercury in the right upper limb in a supine position. She had a saturation of 98% of room air. She had a respiratory rate of 16 cycles per minute. And her Karnofsky performance status scale was 80%, where she can able to do her normal activity with no special care needed. At the same time, she had minimal signs and symptoms to the disease. On further examining the patient, she had no pallor, no icterus, no cyanosis. At the same time, she had flexion deformity changes in the distal end of all the digits in the bilateral upper limb. On examining the lymph nodes, there were regional lymph nodes enlarged in the right axillary lesion, which will be discussed in the later slides. This is the flexion deformity of the patient. Before moving to the examination, I want to show the patient clinical details. Patient was examined in 3 positions: sitting, with arms raised above and arms by the side of the patient and bending forward. On local examination of the breast, on inspection, left breast appears normal. On examining the right breast, it appears asymmetric in position compared to the left, and a lump was noticed of size approximately 12 cross 10 cm, ovoid in shape, located in upper and lower outer quadrant, extending to other quadrants with irregular margins and bossellated surfaces with skin dimpling, puckering, and pudgy orange and ulceration. Continuing with the inspection, she had an ulcer lying on the center of the lump at the junction of upper outer and lower outer quadrant. It was of size approximately 4 cross 4 cm, which is circle in shape with a bloody discharge. It had regular margins and edges appear sloping, with the base having a granulation tissue with surrounding skin changes. Inspecting the nipple areolar complex, the right nipple appears to be displaced outwards and laterally and retracted, and displacement is about 10 cm away from the midline. Shape of the nipple is distorted, and 2/3 of the nipple and areolar complex appears to be red and edematous. She doesn't have any nipple discharge or ulceration at the nipple areolar complex. Upon examining the patient with arms over the head, the skin dimpling, pudgy orange become more prominent. Sorry, sir? Yes, sir. So only on bending forward, that doesn't fall away, sir. No, sir, no, sir. Yes, sir. Next slide, please. No, sir. No, sir. Only regarding the swelling, it's measured up to 15 cross 12 to 7. And it is non-tender and fixed to the chest wall. Next slide, please. Next slide. Previous one, please. So upon examining the regional lymph nodes of the right axilla. Yes, sir. Sir, upon examining the right side of the axilla, on anterior group and central groups were palpated, sir. They were their foramen consistency, non-tender and mobile. Other group of the lymph nodes are non-palpable, and opposite axilla was also not palpable. systemic examination was unremarkable. On summary, we had a 67-year-old female with a lump in the right breast since 2 months and wound over the right breast since 1 month, with a history of recent retraction of the nipple, ulceration, and the lump size was 15 × 12 × 7, a hard lump with the skin and chest wall involvement, with the destruction of nipple complex and palpable mobile ipsilateral lymph nodes. My provisional diagnosis will be, it might be a probably case of right breast malignancy with lymph node involvement. Sir, I will keep one more differential diagnosis, sir. As she is a case of leprosy, she might be having a reactivation of tuberculosis in the breast, sir. That will be my... sir, leprosy bacilli can mimic the tuberculosis, sir.
So why do you call it reactivation of tuberculosis?
Because she has completed treatment.
When you say reactivation, previous history of tuberculosis means reactivation.
Sir,
previous history of leprosy with reactivation of tuberculosis.
So leprosy bacilli will immunely compromise the patient, so she might have a reactivation, underlying pathologies.
She will have reactivation, she might have leprosy. Why tuberculosis?
Yes, sir.
Any other common disease you tell?
No, sir, no other thing in the mind, sir.
How is the skin over the swelling?
Skin over swelling was edematous, sir. Reddish discoloration was there, and it was not pinchable. Yes, sir.
So you said it is carcinoma breast. Anything else it could be with similar findings of ulceration?
Sir, it can be Page's disease, sir.
10 days back she had an accident, hematoma and infection and a lymph node in the accident.
Yes, that would be cause, sir, but we can differentiate with probe test, sir, for which a probe...
Can it be or can it not be?
It cannot be, sir.
Why? She's fallen somewhere. She's a leprosy patient. She's fallen somewhere. She had an injury to breast. Someone has assaulted her. She's got an ulcer and an infection and a lymph node.
Tell me, what do you want to say? See, two scenarios. If you are sticking to your history, then you tell sir that, sir, there is no history of fall. If you are accepting his history that she has fallen somewhere, yes sir, if she has fallen, there is a possibility.
So there is no history of fall, sir.
But if sir is saying, no, if she had fall, yes, if she had fall, it can be. You are getting?
Yes, sir.
Because sir is starting with that only. See, a few days back she has fallen somewhere and did that.
Can it be Phyllodes tumor?
Sir, it can be, sir. But age.
See, Phyllodes tumor you said, no? See, when somebody asks you, can it be something, like examiner asks you, can it be something, you need not always agree. Okay? It doesn't look like, sir. Bol ke, uska explanation bolo.
Why you are justifying that it doesn't look like?
How many phyllodes you have seen with ulceration?
No, you said it can be. You said it can be.
It can
How
be.
it can be? Show me.
So one is age is correlating with...
no.
But phyllodes...
How it can be phyllodes?
So phyllodes I'm saying because she's having a bosselated surface. Sir. That's the only point going in favor with
Yeah,
phyllodes.
looking that only I was thinking, but suddenly I remembered that there is ulceration.
Yes.
Phyllodes will involve skin and ulcerate?
No, sir.
Then it can be. How can it be?
That's the only point which was in favor with phyllodes, but other points are contradicting against the phyllodes, sir.
Is that enough point to rule out that it is not phyllodes?
It need to be evaluated, sir.
Huh?
It need to be evaluated.
No, based on your examination. Evaluate तो ठीक है, एक FNAC या biopsy कर देंगे हो जाएगा. You have seen this big phyllodes anytime?
Yes, sir.
Huh? You have seen?
Yes, sir.
Seen, na?
Yes, sir.
So had that involved skin?
No, sir.
No. Phyllodes, they don't involve skin.
How many lymph nodes you have palpated?
Sir, there were two groups, sir. Total almost, it was matted lymph nodes, sir. It was.
So can it be N1? You told N1. What is N1?
Sir, ipsilateral mobile group of lymph nodes, sir.
Clinical N1.
clinical
And
N1, sir.
in mobile also, mated also. Tell me what it
You
is.
told matted, no?
Yes, sir. It's a N1A, N1B, sir. If it is mobile ipsilateral, it is N1A.
Do you have N1B? You don't have N1B, I suppose.
No, no. There is no N1A, there is no N1B. So when the tumors are, you told it is multiple, matted. So what is the N staging?
It is N2.
Is it N1? If you don't know, you can say, I don't know, sir.
No, sir, don't sir.
Clinical staging of N is different from pathological staging of N, right? So matted nodes is not N1.
What next?
Sir, I want to evaluate the patient, sir.
What you will do?
Initially, according to the triple assessment, patient is already examined clinically and she has been examined. I want to go for radiological investigations and pathological investigations, sir.
What is the triple evaluation?
So one is clinical history and the examination of the patient. Clinical history and the examination of the patient, which is already done. Next is radiological investigations and pathological investigations. Radiologically, I'll go with sonomammo and mammogram.
Treatment.
So treatment, I prefer to go with neoadjuvant chemo for the patient after getting ERPR and HER2 status of the patient. And after neoadjuvant, I'll proceed with the surgery. After that,
What about metastatic evaluation?
Sir, we'll go for contrast-enhanced CT scans and FDG18 PET scan to rule out the metastasis of the other structure.
CT scan and PET scan both.
Sir, where if patient is not affordable, we can go for contrast-enhanced CT scan, sir. And if patient are okay with that, we can go for FDG glucose PET.
This particular patient, can you do mammography?
Sir, here the swelling is more obvious and all are pointing towards a malignancy. There is no points, it's not necessary to go for a mammogram in this patient.
If it is necessary in this patient, can you do mammography?
Yes, sir, we can do for it.
How can you do mammography? Because mammography, how is it done?
So it can be done in opposite breast, not in the pathological breast.
Is he asking on the opposite breast? हाँ, it is like अमिताभ बच्चन डायलॉग कभी नीचे का पैर हाथ में रखा नहीं वैसा बोल रहे हो
Sir, आराम से sir. आराम से sir.
What are the different reconstructive procedures you know?
So pardon, sir.
Reconstructive procedure.
So one is tram flap.
Full form.
Transabdominal rectus transabdominal myocutaneous flap reconstruction, sir. Then D.
You were there for the talk, sir's talk? No.
Did he talk about the tram flap first, or did he talk about the tram flap at the end of his talk?
He was not there for the talk.
You were not there?
No, sir.
Sir itself is here, so I will not talk about it.
Any other flaps you know that are used for breast?
Latissimus dorsi flap we will use.
What are the indications for LD flap? What are the indications for tram flap?
I don't know, sir.
Is there any relation with the size of the breast? If the opposite breast is voluminous, which flap you will prefer?
What will be the main principle of reconstruction?
Sir, to give an psychological upfront for the woman.
No, I am talking main principle of reconstruction. One is to cover the defect. Second is for appearance, right? Cosmesis. So with what you will compare it?
To the opposite breast, sir.
Yeah. So if opposite breast is small and if opposite breast is large, which flaps you will take? Okay, let's pack up.
Give it to service. Okay.
Two, three things, sir, actually. So in this patient, what will be the defect? Like are you going to take out, you are going to do a radical mastectomy or modified radical mastectomy? Is there adequate skin that is available? And if it is going to be a only toilet mastectomy, then our plan would be only to cover the defect. We don't per se reconstruct the breast, or breast appearance wise it will be just flat chest and cover the defect. We can use thoracoabdominal flap, we can use LD flap, we can use tram flap. These are all pedicled flap, very simple, very safe, chances of necrosis minimal. Or in other cases we can go for ALT flap, we can go for tug flap, we can go for so many other things.
Sir, PG level, sir, not MCS level, sir, please.
Thank you.
PG level, sir.
Yeah, PG level. So, in this case, 67-year-old lady, probably if she has been given an option and she is willing to undergo reconstruction, sir, are you going to do a radiotherapy post-surgery? Then I don't think I will do a reconstruction in this patient.
Well, how does radiation affect his management? How and if it is done, when it can be done, when it cannot be done?
So radiation is usually done post-surgery, sir, or after a breast conservation surgery. After breast conservation surgery, it's mandatory to give a radiotherapy.
It is mandatory to give radiotherapy.
Yes.
Why is sir concerned about radiation? Why is sir concerned about
It
radiation?
will destroy the underlying structures and it will cause fibrosis. It will not have the original anatomy of the patient. So the underlying structures will undergo fibrosis and the original anatomy will be destroyed after radiation, sir.
So the carry-home message is, if you are doing reconstruction, don't do radiation. If you are doing radiation, don't do reconstruction.
So there is no plastic surgeon who comes after radiation, never. No role of plastic surgeons after radiation.
Sir told that if the patient is going to undergo radiation, he will not do reconstruction in the same setting. Why? Because once the reconstruction is done, after that the patient undergoes radiation. Due to the radiation, the reconstructed breast, it shrinks. So there is loss of symmetry. So there will not be any use of doing a reconstruction upfront. You can do reconstruction after the radiation.
Okay, sir. Clear? Thank you, sir. Thank you so much for making this.
Is there a role of neoadjuvant radiation?
Nigungi sir is not there, otherwise he would have answered it. Please.
Thank you, Dr. Basir, sir. We are immensely honored to have you as our moderators for this session.
Thank you, honorable chairpersons. We have a great sense of admiration and appreciation for your work and achievements. Thank you, sir.
I would extend my heartfelt gratitude to all the speakers and chairpersons for sharing your knowledge and leaving us inspired, motivated, and ready to contribute to brighter future.
May I now request Dr. Nandkishore Shinde, sir, to give valedictory speech.
I, Dr. Nandkishore Shinde, Organizing Secretary of the CME on Breast Disease Update 2024, privileged to be here to give this valedictory speech. As all we know, CMEs are there to exchange the knowledge and views of the expert faculty, and it is a life wire of all academics. Definitely, this CME also is a great academic feast for all the delegates. We are grateful to the visionary, His Holiness Dr. Syed Shah Khusro Hussaini Sahab, His Excellency Chancellor Khaja Bandanawaz University and President Khaja Education Society, Kalaburagi, Karnataka, for giving us the opportunity and blessing the occasions. We are very thankful to Janab Syed Muhammad Ali Al Hussaini Sahab, Honorable Pro-Chancellor, KBNU University, and Vice President, Khaja Education Society, and Syed Mustafa Al Hussaini Sahab, Director, KBNU University, who are constant source of inspiration and motivation for us. Words are not enough to express our sincere thanks to Professor Ali Raza Moswi, Honorable Vice Chancellor, KBN University, and Professor Rukhsar Fatima Madam, Registrar, KBN University, for guiding us and providing necessary permissions and sanctions of funds for the CME in such a short time. We are thankful to Dr. Siddesh Sarwar, Dean, Dr. Sidling Chedke, Medical Superintendent of KBN University, for encouragement and giving us constant support for the CME. We are thankful to the MR Medical College, GIMS, ESIC Medical College for their active participation in the CME. This CME is an integration of expert talks, panel discussion, and case presentation by the PG, which is the perfect academic feast. We are thankful to the advisory committee, Dr. P.S. Shankar sir, Dr. Rajeshri Palladi madam, Dr. Guru Prasad sir, for guiding us. We are thankful to Dr. R.G. Devani sir, Dr. Baswant Patil sir, Dr. M.A. Basir, Dr. Anup Desai, Dr. Ahmad Khan, Dr. Monaiza, Dr. Vajreshwari, and all organizing committee members for meticulous planning and execution of plan in such short time. We are thankful to the SRs, Dr. Khaja, Dr. Faiz, and Dr. Sharan Basapa, for in addition to the support to the contribution to the CME, they are managing OPDs, IPDs, and emergency work without disturbing us. We are thankful to the delegates for their enthusiastic participation. Without you, all these events would not be possible. If time is money, then today you have spent millions for us. Thank you very much again for making this CME possible. We are thankful to the PGs and interns of Department of Surgery for their tireless, motivated, and dedicated work and enthusiasm toward the CME. We are grateful to the stage committee, catering committee, registration committee, hospitality committee, hall committee for their enthusiastic contribution to make this CME possible. We are thankful to Mr. Sridhar Bhatt for providing delicious food for this CME. We are also thankful to the media and mass communication for coverage of this CME. We are thankful to each and everyone who has contributed directly or indirectly to make this CME a grand success. I declare this CME as concluded. Thank you.
Thank you, Dr. Nand Kishore Shinde sir.
Let's embark on this remarkable journey together and make most of the opportunities that lie ahead.
Thank you, everyone.